आशीष, डॉक्टर ज्ञान, डॉक्टर कुसुम उनको को होस्ट
Okay, sir. We are live now, sir.
Okay. So, dear residents and respected faculty members, we welcome you all to the 4th edition of the LHMC Surgery PG Clinical Update. There is shloka in Sanskrit, Vidya Dhanam Sarve Dhanam Pradhanam. That means education is the best wealth among all. As one consumes or spends, it increases. As one shares, it expands. So we from the Department of Surgery, Lady Harding Medical College, are here to expand this ocean of knowledge among all of you. And believe me, it's going to be a good learning experience for every resident who is going to participate, as well as a learning experience for us as well, as the students are the best teachers. So if you have any query, keep asking. Okay. So without further ado, I will like to introduce the moderator of the first session, which is case presentation. The moderator for this session is Dr. Manoj Andle, who is Director Professor of Surgery at Lady Harding Medical College. Chairpersons for this session are Dr. Shaji Thomas, ex-head of the department, patron for this course, and presently in the Department of Surgery, he is Director Professor at LHMC. Dr. A.K. Atri, he is Professor and Head Department of Surgery at GMC at Chandigarh. Dr. Sumita Jain, Professor of Surgery from SMS Jaipur. Dr. Navneet Kaur, Professor of Surgery from UCMS Delhi. Dr. Shushanto Niyogi, Professor of Surgery from Maulana Azad Medical College, Delhi. Dr. Suhani, Additional Professor of Surgery from All India Institute of Medical Sciences, New Delhi. So without any delay, I'll hand over the stage to our moderator, Dr. Manoj Andle, to please carry on the present session. Thank you, sir.
Yeah, thank you, Dr. Gyan. I think all of us know about this format. In the first session, we have 3 cases to be discussed. Each case is given 40 minutes time for a complete discussion, and we would request all the respected chairpersons to kindly allow the postgraduate to complete the case presentation, or if they want, they can stop him after completing the history examination and other parts of the presentation and ask questions. So without wasting any further time, we will first go on to the first case, which is being presented by Dr. Shekhar Dulal from University College of Medical Sciences, New Delhi. So is it Shekhar Dulal? Are you there?
Yeah, good afternoon, sir. Am I audible, sir?
Yeah, very much audible. Yes. So Shekhar, now we start, and you have a total of 10 minutes.
Should I start sharing my screen, sir?
Yeah, please share your screen.
Is it okay, sir?
Yeah, we can see. I hope all of us can see the screen.
Yeah. Good afternoon, respected teachers. I'd like to present a case of Mrs. A, 40-year-old female, hailing from Delhi and housemaker by occupation. She presented with a chief complaint of lump in the right breast for 4 months. On elaborating the history of present illness, she was apparently well before 4 months when she noticed a lump in her right breast in the upper inner region, which was insidious in onset, initially around 1 into 1 centimeter in size, and now has gradually progressed to the present size of 3 into 4 centimeters. There is no history of any skin ulcerations or nodules. There is no history of pain, fever, or preceding trauma. There is no history of nipple discharge or change in nipple shape. No history of any lump in the opposite breast. No history of bony pain, back pain, headache, seizures, or vomiting. No history of cough, shortness of breath, or chest pain. There is no history of jaundice, abdominal distension, recent weight loss, or reduced appetite. Coming to the past history, there is no history of similar lump in past in same or the opposite breast. There is no history of breast surgeries in past. There is no history, she is not a known case of hypertension or diabetes. There is no history of tuberculosis, any cancer or radiation exposure in the past. There is no history of use of hormone therapy. Personal history, the patient takes a mixed diet. She has a normal appetite. Bladder and bowel functions are normal. and she has no addictions. Menstrual and obstetric history. She attained her menarche at 13 years of age. She has a regular cycle, 28 to 30 days duration, average flow, 4 to 5 days duration. She got married at 24 years of age. She has 3 children, all were normal vaginal hospital delivery. Her first children was when she was 25 years of age, and it was a full-term pregnancy. All children were breastfed for 1.5 years each. Family history. There is no history of breast or ovarian carcinoma in first and second degree relatives, and there is no history of any other malignancy in the family. Sir, should I proceed with the physical examination, sir?
Yeah.
Coming to the general physical examination, patient was examined after taking verbal consent in a well-lit room in the presence of a female chaperone with adequate privacy. Patient was calm, conscious, cooperative, and oriented to time, place, and person. She was average build, sitting comfortably and relaxed. Karnofsky performance status scale is 90. Pulse 88 beats per minute measured in the right radial artery, regular rhythm and normal volume. Blood pressure was 124 by 84 millimeters of mercury measured in the right brachial artery in supine position. Respiratory rate was 18 per minute. BMI was 22.9 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Coming to the local examination, first, the inspection. Patient was examined in sitting position with hands by the side, in leaning forward position, with hand raised above the head and hands pressing on the waist. The left breast appears normal. A lump of approximately 3 into 3 centimeter is visible in the right breast in the upper inner and the lower inner quadrant. There is no visible erythema, dimpling, puckering, pudgy orange, ulcer, or visible veins. Nipples, the right nipple appears to be at a higher level, and there is asymmetrical circumferential retraction noted. There is no deviation, cracks, fissures, ulcerations, or discharging. Areola, there is no cracks, fissures, or eczema. Axilla, there is no visible swelling in the axilla. Arms and thorax, there is no upper limb edema, no nodules over the skin of chest. These are the pictures. The first one is with the hand by the side, and the second picture with the hand raised above the head. Coming to the palpation of the left breast was normal. The right breast, there is no local rise of temperature or tenderness. A 3 into 3 centimeter non-tender lump is palpable, involving the upper inner, the lower inner quadrant, and extending into the retroareolar area. Surface is nodular, consistency is hard, the margins are well defined but irregular. Lump is not apparently freely mobile within the breast tissue. It's not fixed to the underlying muscle, chest wall, or overlying skin. Nipple, there is no discharge expressed and it could not be everted. Axilla, no nodes were palpable in the bilateral axilla, and bilateral supraclavicular nodes were not palpable. Here is a video showing the palpation of the breast. After checking for the superficial temperature and tenderness, I started palpating the breast with the pulp of my finger in a clockwise direction, palpating all the quadrants. While palpating the right breast, 3 into 3 centimeter lump could be felt involving the upper inner, lower inner, and the retroareolar area. While checking for the fixity of the lump to the underlying muscle and the overlying skin, first the lump was made to move in the direction of the pectoralis fiber and perpendicular to that without making the muscle taut. Secondly, the patient was asked to press against the hip and palpated that the muscle has been taut, and then the movement was checked again, and there was no restriction felt. The overlying skin was pinched to check whether the overlying skin was involved or not. Coming to the systemic examination, central nervous system, the higher mental functions were normal, motor and sensory systems were intact. Respiratory system, bilateral air entry normal and equal, and there were no added sounds heard. Cardiovascular system, S1, S2 were heard, normal, and there were no murmurs. On abdominal examination, abdomen was normal in shape, non-distended. Umbilicus was central and inverted. The abdomen was soft, non-tender, no organomegaly or lump was found. Free fluid was absent, and bowel sounds were normal. Spine and long bones were within normal limits, and there was no tenderness elicited. Coming to the summary, a 40-year-old premenopausal lady presenting with a painless progressive lump in the left inner quadrant of right breast since 4 months without skin ulceration or nipple discharge, with no history of any swelling in the opposite breast and no family history of malignancy. On local examination, there is a 3 into 3 centimeter hard lump without skin or underlying muscle involvement in the upper inner, lower inner, and the retroareolar area of the right breast, without any palpable lymph node in bilateral axilla or supraclavicular fossa, with no findings suggestive of distant metastasis. From history and clinical examination, my provisional diagnosis is right-sided breast malignancy, carcinoma with a clinical stage of T2M0N0M0, stage 2A. My other differential diagnosis could be phyllodes tumor and fibroadenoma.
Okay, Shekhar, can we stop here, please?
Yes.
Now, may I request Dr. Shaji Thomas, sir, please. Sir, talking about his history part of this case, what would you like to ask?
History has been fairly comprehensive, but I'd like to know at the end of the history, do you think it's likely to be benign, malignant? Do you think it's neoplastic or inflammatory? What have you taken to rule out?
From the history, looking at her age factor, I would like to think more towards on the malignant side. Since there is no cyclical...
What do you think the age is likely to be for a malignant side? What is the normal age of presentation of malignancy in India?
Ideally, it's above 50 years of age, usually.
In India?
It's above 50 years of age.
The West?
Sir, 60.
In the West, the mean age of presentation is around 60 years. In India, it's younger than 50. And if you look in the wards, you'll find that many of the patients are actually below 50. It's around 45 years of age. Okay, number one is age, then?
So secondly, there is, if we are considering a fibrocystic disease in this age, there is no association of pain or cyclical mestalgia, and there is no association of variation of the lump size with relation to menstruation. So I'd like to go more towards a malignancy.
A short history, patient over the age of 40, rapidly progressing 4-month history of a painless lump in the breast, one should always suspect malignancy. Okay, I think you can ask the other examiners.
Dr. Atri, please, sir.
Yeah, one or two points in the history. In the, when he was presenting the history of present illness, he straightway told the size of the lump in measurement, in the dimensions, 3 into 2 centimeter, which actually is not the case because patient does not measure the lump in those dimensions. As is a tradition, we compare it with something and then we present it. So there also, this I noted, and in inspection also he was telling about the size of the lump in proper dimensions. Okay, you can put a rough estimate, but he has straightway told that this is the dimension. And in palpation also, he did not measure the lump with the tape. I could not see him measuring the lump. He did palpate all the quadrant and he checked the mobility. So that I noted, other examiners or other panelists can dwell upon that if it is the right way of doing the examination. Secondly, he has kept this phyllodes tumor as one of the differential diagnosis. He was showing the mobility of the lump, which is quite mobile because neither it is stuck to this underlying structure nor to the overlying skin. So I think phyllodes cannot be even thought of because there is nothing like phyllodes appearance in this lump on this inspection. And fibroadenoma can be kept, but then as Dr. Shadi had told that this is a shorter duration and all. But if at all you have to keep a differential diagnosis, phyllodes I think should not be there at all.
Thank you.
Manoj?
Thank you, sir. Sir, Dr. Sumita Jain, ma'am, please. Is Dr. Jain with us?
Did not
Doc-
see her
doc-
joining actually in the beginning.
Okay, Dr. Navneet Kaur, ma'am, please. Would you like to?
Have they joined? It is
Don't
visible
think.
to you? I don't
No.
think we saw
Dr.
her.
Shushanto, yeah, I think.
Kindly unmute, ma'am.
Yeah, I have unmuted. I'm here, Dr.
Sorry.
Manoj.
Yeah. Oh,
Sorry.
welcome, ma'am. Welcome.
Okay, thank you.
Doctor-
In fact, I joined after missing maybe the first two slides. So that part of history is probably missed. So you want Dr. Sumita to come in first?
Yeah. Dr. Sumita, ma'am, please.
Yeah. Hello, am I audible now?
Yeah, very much, ma'am. You are there.
Yeah. So history of trauma, Dr. Shekhar, did you mention? I think you didn't mention.
Ma'am, I have mentioned.
Just check. Anyway, what is the importance of history of trauma in this patient?
Ma'am, history of trauma, it might be the lump. If it is in a short duration, that might be caused due to traumatic fat necrosis. So
How will you rule it out in this patient?
Ma'am, usually traumatic fat necrosis, the lump is decreasing in size. Once it has presented as a lump, it gradually decreases in size. So since the lump is progressive in this case, so it will probably not be a case of traumatic fat necrosis, ma'am.
There's no history of pain at any time and there's no history of trauma, right? One thing, and second thing, the surface is it's still variable. It's not as hard and as same all over the lump, right? So that's the difference. You can, yeah. Next.
Yeah, can we go over to Dr. Navneet Kaur, ma'am?
Yeah, I think again, I did not see the first two slides, but I presume that you have covered the risk factors for breast cancer.
Yeah, ma'am.
So what are the risk factors that will be that you will be interested to know about?
Ma'am, in this case, first risk factor is the age itself. Second is the
age is not a risk factor for this lady. She's rather young. She's a young patient with a breast cancer. 40 and less than 40, we take it as young woman. So her age is definitely not a risk factor. Older age, it can be considered. Yeah.
Family history, considering her younger age, family history of breast carcinoma or ovarian carcinoma.
Okay, that you said is not there.
Yeah, ma'am. Second is history of radiation, ma'am. Between 10 to 30 years of age, which does act
is
as
very
a risk
uncommon, which is a very uncommon history. Okay.
Ma'am, history of hormone replacement or hormone use, hormonal therapy use, will also act as a risk factor, ma'am.
Okay.
Ma'am, history of previous any breast biopsies done with a history of any atypical atypical hyperplasia that has been noted in the previous breast biopsies.
Okay. So if there is a history of atypical hyperplasia of a breast biopsy, then it should have been treated. Then there is no reason to leave that lump alone.
Yeah, ma'am.
That also is not there in this particular patient.
No, ma'am.
So any history of breast biopsy is probably something which we presume that maybe there was something like atypia which was missed and patient has then a higher probability of having it. So what is the, I would say, how much is the risk increased in a person who has a history of biopsy with atypia or without atypia?
Ma'am, without atypia is 1.3 to 1.9 risk, relative risk. And with atypia is 3.4 to 3.9 or around 4 relative risk.
Okay, so I think I'll leave it here. But if patient was diagnosed with atypia, what should have been done at that point of time?
Ma'am, then a proper evaluation and proper surgical management should have been done.
What is the surgical management for the atypia?
Ma'am, if it is a lesion that has been diagnosed on mammographic, then the excision of that lesion with a specimen mammography to rule out to check that all of the lesion has been taken out in the biopsy should have been done.
Okay. Can we go over to Dr. Shushanto, please? Dr. Shushanto?
Yes,
Yeah.
I think the history was okay, but I probably missed. Did you talk about the nipple retraction in the history also?
Yeah, ma'am. Yes, sir.
Okay, I probably missed that. So that's okay. I think he has covered all the points in the history and the examination.
Okay, Sohani, Dr. Sohani, please.
I just wanted to ask that in examination, what are the points that are favoring your differential diagnosis of a fibroadenoma or a fibroids that you put?
Ma'am, for fibroadenoma, firstly, the lump is not fixed to the underlying muscle or the overlying skin. That would be my first favorable point for fibroadenoma. And for phylloid, since it is a rapidly growing lump for a history of only just 4 months, and also the lymph node, there is no presence of lymph node. Lymph nodes are not present, so that also is in a favor of fibroadenoma. And even in case of phylloids, since lymph nodes, lymphadenopathy is relatively rare in phylloids, so that would also go in favor of phylloids.
So what I was trying to tell you, that you've written that you mentioned that there is nipple retraction, there is asymmetry of the breast, and there is a tumor which is not in the retroareolar region that you may, in a remote situation, explain. So I think, in my opinion, it's not necessary to keep multiple differentials if you're not able to defend them.
Yeah, definitely. Yeah. Thank you, Dr. Sawhney.
I like to add, we should have added the auxiliary examination also, shown to us how he has done it, because it is very useful in every exam. If there is a breast lump, the examiners are, definitely they ask at least to palpate one group of the lymph nodes.
Exactly.
More happy.
You should have demonstrated the palpation of axillary lymph nodes. Shekhar, one question from my side as far as history is concerned. You have taken a history of, say, early menarche, late menopause, and all these things. How does it make a difference in a patient who has already developed malignancy of breast to find out the history of early menarche, late menopause, and things like that?
These are just the proven risk factors, just to see if she has a longer exposure to the estrogen, cycles of estrogen during her reproductive age. Since having menarche, if it is delayed by every 2 years, starting from 12 years of age, there is much 10 to 20% reduction in the incidence of breast cancer.
So that probably means that she stands a equally high risk of developing malignancy in the opposite breast, the normal breast. Okay. Can we go back to Dr. Shaji Thomas, sir? Sir, anything else you would like to ask as far as examination and...
examination are 2 points that I want to make. When you examine the breast lump and when you describe it, you have said there's a lump that's present in the upper inner, lower inner quadrant. After your description should actually say it is going from, say, 2 o'clock to 4 o'clock, so that they have some ideas to build, because when you say both these quadrants, it actually includes half the breast. So you should say it's going from 2 o'clock to 4 o'clock. The size of the lump and how far it is from the nipple areolar complex. So that gives an idea whether how close it is to it, whether you can resect it or not. Second point that I want to make is in the video that you showed about the examination of the breast. You're putting a hand, then lifting it up, then putting it down again, then lifting it up. And that's not the way you should be examining the breast for a breast lump. You should use 3 fingers, palpate, and then you slide your hand across to the next region, still keeping covering 1/3 of the previous area that you have palpated. You don't lift it up and go down, then up again and go down. That's not the way. And of course, there are any other method of examining the breast that you know of other than this method that you showed?
So another one is wedge method, in which we start from the nipple areolar complex and go outwards, covering each wedge. And another one is linear, from where we start from up, from the medial side, from the upper, go down, and then go slightly towards lateral side, and then go up again in the linear pattern, up and down.
What is the advantage of the second method that you mentioned? You said it's what quadrant? What did you say?
Wedge.
Wedge shaped. Okay, wedge shaped or dial of a clock. What is the advantage of that?
Not sure, sir.
Normally, when you're palpating with this one hand that you showed, you tend to, the breast as well as the lump is moving along with your hand. Whereas if you're using the dial of a clock method, you're using one hand to kind of put traction on the nipple in the opposite direction, so that that part of the breast is steady while you're palpating with the hand. And so many examiners prefer that. Okay. And one last question. You said you've done all this. What is triple assessment?
So triple assessment consists of 3 assessments. First is history and physical examination. Second being the radiological examination, and third is the histopathological examination.
You've done 1, 2, 3, 4. What is the relevance of triple assessment? You've done whatever you said the triple assessment you've done. What is the relevance of all that?
So it has a high sensitivity and specificity for diagnosis of breast lesions.
In other words, how do you interpret your triple assessment? Mammogram says not malignant. Ultrasound says there is a lesion there. FNEC says no evidence of malignancy. That's it. Okay, triple assessment is of value when all your assessments are in concordance with each other. There's all your methods of assessment say it is benign. If any of them are not in concordance, then you must go ahead with the definitive biopsy. That's what it means. Okay.
Okay. Thank you. Thank you, sir. Dr. Atri, sir, please, sir, can we go on to the management part now? Shekhar, do you have any more slides?
No, sir.
I have one question with Dr. Shekhar.
Yes, ma'am, please.
Why do you do triple assessment in breast? Why not in other carcinoma? Is there any relevance in this?
Ma'am, there are a lot of
See, there are so many carcinomas, we never call it triple assessment. Only in breast we say triple assessment. Why?
There are a lot of benign lumps which might appear as carcinoma. So, just to rule out...
That status is there in every cancer. There are benign and there are malignant lumps. So actually, the sensitivity of each examination is like clinical breast examination goes till 90%. Of mammography imaging goes till 95%. When you do core biopsy, it goes till 99%. Still the 1% is left. Despite all three, this thing, sometimes you are in, so that what to do of that 1%, you do not reach to the diagnosis. And what is that 1% where you require excisional biopsy? Actually, my question is that, what is that 1% where you require excisional biopsy despite this triple assessment? What are those conditions?
Ma'am, all those proliferative lesions like sclerosing adenosis and all, which give a false impression, like which masquerade as a carcinoma, but after excision biopsy, we come to know that it's a benign lesion.
Yes.
Thank you, ma'am. Dr. Atri, sir, please.
Sometimes it's difficult to differentiate between atypical ductal hyperplasia and tubular carcinoma, radial scar, right? And curate papillomatosis, where you are not sure whether it's on core biopsy, whether it's really carcinoma or it's a simple hyperplasia of papillomatosis. And sometimes you cannot sample the microcalcification. These are the conditions where you have to go for excision biopsy despite triple assessment, right? Okay, carry on, please.
Thank you, sir. Dr. Atri, sir, please, can we go on to the management aspect?
Yeah, he can go to management.
Yeah. Sir, please.
How will you proceed in this patient now?
Sir, since I have completed my history and physical examination, I'd like to proceed with the imaging findings. I'd like to do a sonomammography. I'd like to first get a USA and then a bilateral mammogram of the breast.
You keep on explaining what you are expecting from these investigations.
Sir, first ultrasound I'll have to check whether there is any other lump that I might have missed in the physical examination, and also check the axilla for any other lymph nodes that have been missed in the physical examination. And also I can take a FNAC from the axillary lymph nodes that's present. And bilateral mammography will also help to quantify whether there are
any other information on ultrasound from benign.
So whether it's a solid cystic lesion that is
benign to malignant spectrum, how you will get that information?
So the lump is the malignant lumps are usually irregular in the breast lump, and when we talk about the axillary lymph nodes, it will be taller than wider. There will be loss of fatty hilum, and there will be hypoechoic areas.
There are other, gradings which we do on radiology. What is that grading of? Which gives a spectrum from benign to malignant.
BIRAT grading.
Can you explain that?
So it's a breast imaging reporting and data system. There are 6 grades. Grade 0 is insufficient imaging. We have to repeat more imaging. Grade 1 is we have.
It is done on this ultrasound or mammography?
Based on both, sir.
Huh?
It can be based on both.
So that's because in ultrasound you straightway went to from assessing the lump and then axillary lymph node and then straightway FNAC. So you did not stop and explain that, because BIRATS definitely gives you a definite indication whether you are dealing with a malignant lump or a benign lump. In this context, can I ask what is ThyRADS?
ThyRADS is a similar reporting system that is done for thyroid, sir.
Yeah, so that's also nowadays being taken, although it came in 2009, but it is now being very reliably being reported, and not many patients are being picked up of early malignancy in thyroids. That's good. So, Byron, I hope everybody knows if it keeps on explaining, we will lose time in discussion. So, any other thing you would like to do?
Following that, I'd like to go.
Mammographic findings.
So mammographic finding suggestive of a carcinoma is usually a Mars lesion. That's a speckled Mars lesion are seen. And there are calcifications. Calcifications suggestive of carcinoma is usually microcalcifications. It might be speckled microcalcifications. There might be linear or there might be branching calcifications. And there might be architectural distortions.
Okay. Dr. Manoj?
Yeah, Dr. Navneet, ma'am, please.
All right. So you do an ultrasound and mammogram of the breast, and you find that there are lesions there is a lesion in the breast, as well as there is a suspicion of the axillary nodal involvement also. So what would be your next step?
If the axillary lymph node is suspicious lymph node is visible in either USC or mammogram, then I'd like to go for the FNAC of that lymph node also. Next
you will not deal with the breast primary in the breast first?
The next step would be a core biopsy from the breast lesion, along with that FNAC.
Would be interested more this thing.
First would be a core biopsy from the breast lesion.
Okay, so you'll do a core biopsy from the breast, and you will like to do a FNA from the suspected involved nodes.
Suspected lymph node.
So what are the features of involvement on ultrasound of the axillary nodes which suggest involvement?
Ma'am, there will be more than 1 centimeter node, loss of fatty hilum.
How sensitive is this parameter, size of the node? Which is the most sensitive parameter in terms of involvement?
Ma'am, loss of fatty hilum.
Okay, that is one of the important parameters. Why is size not so important? Why is size not such an important criteria?
Sure.
Because there may be a reactive enlargement also. If you have done a biopsy from the breast, there may be an enlargement. So size is partly taken into consideration, but not the first thing. So loss of fatty hilum, what else?
Ma'am, taller than wider lesion.
There is no taller than wider lesion in the nodes. That is for the primary in the breast, which is described.
Ma'am, hypoechoic nodes.
Okay. So that is loss of fatty hilum, right? Isn't it? And the round shape. I think the rounded node with loss of fatty hilum is very suggestive. And then what will you do? If you find a node, maybe you will find 2, 3. What should you do then?
Ma'am, if clinically it's not palpable and it's found during the ultrasound, I'd like to go for an FNAC to check whether there are metastatic deposits or not. If FNAC comes to be positive, then I'd like to go for axillary lymph node dissection during the management of the lump.
So anything more which can be done even at this stage when you are doing a FNA of a involved node, keeping some future treatment option in mind?
Ma'am, if FNA is negative, we might go on for sentinel lymph node biopsy.
No, that is definitely the regular step. You have a very highly suspicious node. You are doing a FNA to kind of confirm that it is involved. Anything more can be done at this stage which may have a bearing on the treatment planning subsequently?
Yes. So Shekhar, you have done a FNA, you have done an ultrasound, breast and axilla, you have done a core biopsy. What ma'am is asking is anything else besides these investigations?
So you can clip that node so that you are able to identify in case you plan to do a neoadjuvant chemotherapy and then you want to do a sentinel node biopsy post that.
Okay, thank you. Thank you, ma'am. Dr. Shushanto, please. Would you like to ask something about the management or investigations?
Yeah, why do you want to do a core biopsy, not an FNAC from the lesion?
So firstly, the core biopsy will give us a greater amount of tissue. And the most important thing is that we can check for the invasion, which is not given by FNAC, the invasiveness of the carcinoma. Secondly, we can also go for checking the grade of the tumor and the hormonal receptor status.
So it's mainly for the hormonal, because why is it important to know the hormonal status now?
So it will help us in deciding the adjuvant hormonal therapy. Whether if it's ER/PR positive, we can go for tamoxifen adjuvant therapy, and if
would be the adjuvant hormonal therapy or something else? Only the
hormonal. It also helps to decide the prognosis of the tumor. Triple negative
yes, so you can plan the entire treatment for the patient at the right from the word go. Because anything else, supposing you don't have a hormonal status now, what can happen? Supposing that time it's not available, you're not aware of the hormonal status.
So then we can to proceed with the surgery and then get the hormonal status post surgery and then plan for adjuvant.
Okay. Does the hormonal status have any bearing on the type of chemotherapy that you give? Or
so chemotherapy, so triple negative tumors are mainly should be given chemotherapy in the neoadjuvant setting, even in the case of operable CA breast. And hormone receptor status will help us to take whether we can use tamoxifen or trastuzumab as a adjuvant therapy.
Can the hormonal status change during surgery? During treatment, not surgery, during the treatment?
So it may change.
So it actually changes after chemotherapy. That's why you should know upfront what your original hormonal status is. Otherwise, after surgery, if you're giving, maybe you've given a neoadjuvant, it might not be the true reflection of the original hormonal status of the patient.
Okay. Yeah. So Dr. Sohani, please. Your input as far as management investigations are concerned.
So any other further investigation you like to do in this patient? Supposing the node is negative and the tumor shows ERPR positive, HER2/neu negative, invasive carcinoma, Ki67 is 10%.
We can go for a oncotype DX 21 gene assay to check whether.
At this point, you want to do anything? How would you like to plan the further management?
Ma'am, since patient there is no history of family carcinoma, so MRI is not required in this case. If there's just a node negative and T2 lesion, then I'd like to offer the treatment options to the patient.
So what treatment option? Anything else? What is the age of the patient? 30?
40.
Anything else so how will you plan the management?
Yeah.
For this patient, since it's an operable breast carcinoma, early breast carcinoma, so I'd like to give option to the patient whether she wants to go for a breast conservation therapy or she would like to go for a mastectomy. First, the patient must agree that after breast conservation therapy, she is willing for radiation therapy. And only then I'd like to go for a breast conservation therapy. If she's not willing, then I'd like to offer a mastectomy. There's one more option of oncoplastic breast surgery. In this case, since the breast size is relatively small, and if we do a breast conservation surgery in this case, there would be a cosmetic issue. So oncoplastic breast surgery would be an option.
Can you go put the slide of the photograph of the clinical photograph? So supposing the patient wants BCS, so what procedure will you try to adopt here?
It would be a lumpectomy with a sentinel lymph node biopsy.
So lumpectomy, the lump is in the upper outer quadrant. The nipple area was normal. You like to preserve the nipple areola complex or not?
I'd like to preserve, but since nipple retraction is there, so if post radiation, it might not give a favorable cosmetic result.
No, as of now, you would like to preserve the nipple areola complex.
Ma'am, I try to preserve.
Okay, and when you'll do a lumpectomy, how are you going to cover the defect that you create after lumpectomy? Because as you said, the breast volume is not much.
Ma'am, in this case, we can go for level 1 oncoplastic surgery, where we can just go for a volume displacement from the surrounding area, from the surrounding breast tissue itself.
But if you have 3 centimeter by 3 centimeter, you'll take at least around 1 centimeter margin, and you'll remove quite a bit of your tissue will go from the outer half aspect of the breast. So do you think that you will prefer a volume replacement than a displacement?
Ma'am, if a displacement during the surgery, if you feel that displacement would not be a good option.
It will not cover. Na? You have to plan this before surgery. You can't go without a consent to the OT table, right?
Then I'd like to go for volume replacement.
So what any 2-3 options that you know of volume replacement?
Ma'am, in this case, we can go for anterior intercostal artery perforator flap or a medial intercostal artery perforator flap, or even a lateral LD flap.
Okay, sir, Dr. Thomas, sir, please. Your input for as far as the management is concerned, treatment is concerned. Dr. Thomas, please.
Yeah. What is the margin that you're aiming for when you're doing a wide local excision?
So its ink tumor must be negative. Ink margin must be negative.
Any other treatment after this surgical excision? You'll treat the axilla and look for lymph nodes. If the sentinel node is positive, then you'll go ahead or whatever. Any other adjuvant treatments that you think of?
Sir, if we are going for a breast conservation surgery, then post-op adjuvant radiotherapy is a must. That must be given.
What kind of radiotherapy?
Sir, since she's not an ideal treatment for ideal case for accelerated partial breast irradiation, so I'd like to go for whole breast irradiation. And based on the number of lymph nodes, that the involvement of other regional lymph node irradiation would be based on the number of lymph node positive.
Like what?
Sir, if it is usually if it is more than 4 lymph nodes positive, then regional lymph node area should be covered in radiation. And if it is
which regional area will be covered?
So the axilla, the internal mammary, and the supraclavicular.
So if there are 4 lymph nodes, you will radiate the axilla?
Yes, sir.
And you're done after doing an axillary dissection?
Sir, it depends upon the positivity. If among the lymph nodes, 20% or more lymph nodes.
You said 4 lymph nodes are positive. Will you radiate the axilla?
Yes, sir. If 4 lymph nodes are positive, then.
Always, sometimes, will you consider, or is it mandatory?
So it's generally better to consider. It should be radiotherapy should be considered if more than 4 lymph nodes come out to be positive.
Radiation is there, but will you radiate the axilla?
Yes, sir.
Because you've already done a lymph node dissection.
So I'd like to.
What sir is trying to ask you, what would be the indication for irradiating axilla otherwise? Is it just the number of lymph nodes, 4 or more, or something else?
It's a grade of the tumor or extracapsular extension.
The radiation is to lymph node basins, but what if you've done an axial lymph node dissection? Axillary radiation specifically is only if there's axilla is at risk, which means if there's a heavy axillary load. If you have done 1, 2, 3 nodes are positive, you've done a proper lymph node dissection, you really need not specifically radiate the axilla because already cleared the axilla. What you'll have to target is supraclavicular, chest wall, breast, etc., whatever you have, you think is indicated in this particular patient. What about chemotherapy?
Yes, sir. Sorry, sir.
What about chemotherapy? Will you give for all patients, some patients?
So chemotherapy general indication is that for any node positive disease or if the tumor size is more than 0.5 centimeter, we generally advise chemotherapy.
When is chemotherapy not likely to be helpful?
Sir, in cases of DCIS.
Invasive?
Sir, DCIS, it's seen that the systemic spread is not...
Not DCIS, I'm talking invasive. Dr. Sushanta was asking you some question.
About... Yeah, is Sushanta there? Yes, Dr. Sushanta, please.
Yes.
Dr. Sushanta was asking you a question about receptor status and etc. No? Suppose the patient is ER positive, HER2 negative with a low recurrence score on oncotype DX, then these patients do not really benefit from adjuvant chemotherapy. Okay, I think you can go on to the next.
Okay.
I just want to add a few points.
Yes, sure, sir. Sure.
He missed when he was asked what extra investigation he will do. Chest X-ray he did not say. Ultrasound abdomen he did not say. A roll of bone scan in such a patient in stage 2A which he has mentioned, or PET scan is not the size of the lump which always decides the distant metastasis or always having bony pain which will guide you. Sometimes it is mandatory to, especially the chest X-ray and abdomen ultrasound for liver to see metastasis. So these were the few important investigations which is not mentioned besides some blood investigations by LHMC and all.
Okay. Thank you, sir. I think that brings us to the end of this.
I would like to add some points. Number one,
sure, ma'am.
In node ultrasound, right? Nowadays, you should do Doppler and see the peripheral vascularity. That's very much correlated with the malignant node, right? That's one thing. And you should see SL ratio, not the size of the node where it is a SL ratio, which if it is less than 0.5, then it goes in favor of malignancy. These are two things for axillary node. Second thing, you are talking of surgery right from beginning. Will you give anesthetic in this patient? Can you plan? And why? And when?
For considering if the lesion is not amenable for breast conservation therapy and the patient is looking for breast conservation therapy, we can give pre-adjuvant, neoadjuvant chemotherapy just to reduce the size of the lump so that we can go for a breast conservation surgery.
More important criteria beyond that?
To check for the in vivo
indication of anesthetic in this patient. You'll check for molecular status first. If it is TNBC, if it is TNBC triple negative or if it is HER2, then you should give first anesthetic. What are the advantages of anesthetic?
Anesthetic is that first the blood supply is not disrupted, so the delivery of the chemotherapeutic agents is better. Second, we can check the in vivo response, if the tumor is responding to that chemotherapy or not. And second, it helps to reduce the size of the tumor so that we can proceed for breast conservation surgery.
Yes, so basically for TNBC, it's very TNBC and HER2, right? Positive tumors, just to check the response so that you can add, and if you get the complete response, it's very good. Then you get very good tumor-based ratio. Second thing is, if there's a residual disease, you can add other chemotherapy in your adjuvant treatment, right? For the better response. Then before planning BCS, will you check for something? This patient is suitable for BCS or mastectomy?
There are certain contraindications to radiotherapy before that we should consider before planning for BCS. First one is
how will you plan whether the patient is for BCS or for mastectomy?
So that, ma'am, that is based on the tumor size and the breast tumor ratio.
That's all?
And the contraindications to radiotherapy, or if the patient willingness to...
You should check mammogram first, whether it's a multicentric tumor or whether it's a multifocal or whether it's a unicentric tumor. So can you do breast conservation multicentric tumor?
No, ma'am.
So then
that's an indication
you should check first mammogram and then decide whether breast conservation or mastectomy, right? Yeah, still, there are 10% patient which has multicentric tumor. There you cannot do breast conservation. So you should decide first and you should speak that first. That before planning for breast conservation, you should go for this. What is the difference between multicentric and multifocal disease?
Multifocal is within the same quadrant, usually less than 4 centimeter from the primary lump. And multicentric is usually in the other quadrant or more than 4 centimeter from the primary lump.
Can you do breast conservation multicentric or multifocal disease?
Multifocal, if it is nearby with the appropriate area, then we can try.
Thank you.
Depending on the breast size, ma'am.
Yeah, you can add oncoplastic breast surgery in that, right? Major volume replacement, right? And then you can do.
Thank you. Yeah. Thank you, ma'am. This brings us to the end of this first case. Shekhar, can you stop sharing your screen with us now?
Yes, sir.
So that we can move on to the next case presentation to be presented by Dr. Tanvi Vijay from LHMC Delhi. I would request all the chairpersons to kindly grade or mark each candidate and subsequently send it to us. Thank you. Is Tanvi Vijay with us? Yeah. Yeah, Dr. Tanvi.
Sir, are my slides visible?
No, not yet. Please share your screen.
Now?
Yeah, now it's there. Yeah. Please switch on your video as well.
Sir, 1 minute.
No, we can't see your slides. Something is wrong. Dr. Tanvi, are you there? think, do we have the third presenter with us? Dr. Manjunath AK from Jhansi.
No, sir. He will join in 10 to 15 minutes, sir.
10, okay.
Yes, sir.
So, Tanvi?
I think they are checking out on Tanvi. Dr. Manoj, we want to check out on Tanvi what happened.
Ashish, till then make it a point that whosoever is going to present next is already added onto the group. Okay?
Yeah, please. So that if there is some delay, we can switch over to the next case and then come back to this case later. Yes, Tanvi, now we can share your slides quickly.
Yes, sir.
Yeah. Can we start, please?
Can you make it full screen?
Dr. Tanvi, can we make it to a full screen?
Sir, I've made it
Yeah, now it's okay. Fine. Please proceed quickly.
My name is Dr. Tanvi Vijay. I am a third year PG student from KTHT Medical College, and my topic for today is locally advanced breast cancer history. 48-year-old lady who is a resident of Loni, Ghaziabad, a homemaker by occupation, presented to the surgery OPD with complaints of a lump in the left breast for 1 year. History of presenting illness. My patient was apparently normal 1 year back when she noticed a lump in her left breast since 1 year back, which was progressive, painless, initially 3 into 3 centimeter in size, progressed to the current size of 8 into 7 centimeter. She also gave history of recent nipple retraction with no other history of pain or nipple discharge. There was no history of any other lump in left breast, swelling in the right breast, swelling in both the axilla or in the neck or any other place in the body. There were no skin changes over the lump, ulceration or skin nodules. History of constitutional symptoms like fever, night sweats, weight loss and loss of appetite were not there. There was no history of OCP intake or intake of hormone replacement therapy. No history or suggestive of distal metastatic symptoms like lower back pain, pain abdomen, cough, breathlessness, severe headaches, altered bowel and bladder habits. Past history, there is no history of previous breast biopsies, no history of any breast lump in the past, no history of radiation exposure to chest in childhood, no history of tuberculosis or TB contact, and there is no history of any other medical comorbidities. Personal history, normal bowel and bladder habits. She has a normal sleep-wake cycle and is a non-smoker with no history of alcohol intake. She has a vegetarian diet, no other addictive habits. Menstrual and obstetric history. Her last menstrual period was 15 days ago. She has regular cycles with normal flow for 3 to 4 days in a week, in a month. She achieved menopause at the age of 13 years and she achieved menopause 2 years back. The history of LMP is wrong. She was married at the age of 20 years and is P4L4A0. She has had all full-term normal vaginal delivery with first childbirth at the age of 21 years. She has breastfed each child for approximately 6 months with a cumulative breastfeeding for 2 years. There is no history of breast cancer in first or second degree relatives in the family. There is no history of malignancies like ovarian, colorectal, prostate, pancreatic cancer or male carcinoma breast in the family. And there is no history of hereditary syndromes in the family. Summarizing my history, a 48-year-old postmenopausal lady with complaints of painless progressive lump in her left breast since 1 year, which was initially 3 into 3 centimeter to the current size of 8 into 7 centimeter with recent onset retraction of nipple since the last 2 months with no significant past or family history.
Okay. Can we go on to, yes, examination?
Examination, the patient was examined in a well-lit room after taking informed consent. She was conscious and oriented, well-oriented to time, place and person. Her Karnofsky performance score was 90 and her ECOG score was 1. She was well-nourished and well-hydrated with a BMI of 23.43 kg per meter square. Pulse rate was 78 per minute. It was regular, adequate volume, no radioradial or radiofemoral delay, and blood pressure was 136 by 88 millimeters of mercury taken in the right brachial artery in the supine position. Other than that, her respiratory rate was 18 breaths per minute and she was afebrile with no evidence of pallor, icterus, cyanosis, clubbing, pedal edema or generalized lymphadenopathy. On inspection, the inspection was done after the patient had her hands on her side. The left breast appeared to be slightly at a higher level than the right breast. It was also slightly larger in size. Fullness was present in the upper outer quadrant of the breast on inspection on the left side, and circumferential retraction of the nipple areola complex of the left side, which is at a higher level than the right side. There were skin changes in the form of a PD orange present, and there were no evidence of redness, ulceration, or dimpling. There were dilated veins that were present over the sternum, and right breast appeared to be normal. This was examination done with her arms on the side and arms on the waist. There was on the left breast evidence of pure orange appearance could be seen with fullness in the left supraclavicular fossa and prominent veins over the chest with no evidence of dimpling or retraction of the skin. Nipple retraction was evident. Arms raised above the head. On palpation, left breast, there was a 10.8 into 8.6 centimeter hard lump in the upper outer quadrant of the breast, extending into the upper inner, lower outer, and retroareolar regions of the left breast, with no local rise in temperature and non-tender. The shape was spherical with a hard consistency, and the margins were well defined. The surface was smooth with no attachment to the overlying skin or underlying pectoralis major. There was no fixity to the underlying chest wall, and the lump was fixed to the breast tissue with no nipple discharge upon pressing the lump. On axillary examination, both axilla were examined separately with the evidence of multiple matted lymph nodes of size 2 into 2 centimeter largest, slightly tender with limited mobility in the level 1 in the left axilla, and 2 discrete lymph nodes of size 1 into 1 centimeter were palpable in the left supraclavicular region, which was non-tender and mobile. The right breast appeared to be grossly normal. Inspection and palpation, as well as the right axilla, was normal. Left arm mid-arm circumference was 22 centimeter, and the cervical and thoracic spine examination was grossly normal. Systemic examination, respiratory system, bilateral air entry was present, equal, and normal vesicular breath sounds were heard. Cardiovascular examination, S1 and S2 were heard with no evidence of any murmurs. Neurological, there were no evidence of focal neurological depth. And per abdomen, it was non-distended, soft, with no hepatosplenomegaly or evidence of free fluid in the abdomen. On distal rectal examination, normal anal tone with no evidence of any growth, and per vaginal examination, bilateral adnexa were free with no evidence of any growth palpable. Coming to my summary, a 48-year-old postmenopausal lady who presented to the surgery OPD with painless progressive lump for the last 1 year with rapid progression from 3 into 3 centimeter to 8 into 7 centimeter with recent onset retraction of nipple from last 2 months. And on examination, left breast was at a slightly higher level with fullness in the upper outer quadrant and pure orange appearance of skin with circumferential nipple retraction, and palpation of a 10.8 into 8.6 centimeter lump in the left breast occupying the upper outer, upper inner, lower outer, and the retroareolar quadrants. Hard, well-defined margins, smooth surface, not attached to skin, underlying muscles, or to the pectoralis major, and attachment fixed to the breast tissue. Multiple matted lymph nodes in the left axilla palpable, level 1, and 2 discrete lymph nodes palpable in the supraclavicular region. Based upon this history and my clinical examination, 48-year-old postmenopausal lady with painless progressive hard lump in left breast, most likely carcinoma of the left breast, clinical stage T4B N3C M0, based clinical examination stage 3C.
Okay, thank you. Sir, Dr. Thomas, sir, can we start from you, please?
Can you just show that second last slide, the one before this?
The second last slide.
The one before this. Yeah. There's been a lot of, no, not this.
The earlier one. Yes.
No, the one just before the diagnosis, where you summarized your history and...
summary ke slide,
yeah, okay. You have said retraction. What's the importance of retraction nipple? When is the nipple retraction important, or when is it surgically important in a person?
Sir, if a patient is presenting with recent onset retraction of the nipple, then it is more significant. And if it is circumferential retraction, then we consider the diagnosis of malignancy. And the type of retraction, if it is slit-like, then we consider other benign disorders.
Okay, good. Recent onset of unilateral retraction. And what about nipple discharge? When is that significant?
Sir, again, recent onset discharge of nipple from nipple, which is bloody discharge, is more significant, which is unilateral again, and it is localized to one single duct.
Okay. Unilateral single duct discharge. It may be serous, it may be bloody, but if it's unilateral single duct discharge, that's when you have to be worried about. Okay. What does this PUD orange, what does it signify?
Sir, pure day orange means that there is skin infiltration, like the dermal lymph vessels have been infiltrated by the cancer cells, so giving that an orange peel appearance. So there will be evidence of those, like when we lift the skin, there will be presence of those, an orange peel-like appearance with small dots on the surface of the breast lump. So that is referred to as PDO.
Okay, good. It's a good sign or a bad sign?
Sir, it is a bad sign.
Okay, Dr. Atri, sir, please.
Yeah. How did you come to know that the size of the lump was 3.3 centimeter and now it has increased when she came to you to 8.7 centimeter?
Sir, patient had shown with her hands, like she had roughly shown, so I estimated it to be 3.
I think I pointed out in the previous presentation also that when patient tells, it is not the size, actual size, and that is very precise measurement you are telling, 3.3 centimeter, which is not acceptable, I think, because no patient will be able to tell that precise a point unless until she keeps the fingers and then measure it on the some measuring tape. So that is one point in the history as well as in inspection you have told about that, although all other points are taken. The second point which you said, there is no tenderness in the cervical and the thoracic spine. Where do you actually expect the tenderness if there is a skeletal metastasis?
Sir, the most common site of metastasis is to the lumbar vertebrae. So that
you did not. You right actually chose to say only the thoracic vertebrae. You did not say anything about lumbar, because why lumbar vertebrae are more prone to have metastasis?
Sir, there is like spread of the cancer cells via the intercostal veins through the connection Batson's vertebral venous plexus, and by gravity they first go down. So valvulus plexus of veins. So that is why they go first to the lumbar vertebrae by gravity.
I think it's a very elaborate description. There are other plausible explanations have been given. Where the prostate cancer metastasis in the bones? And what is the reason given for that?
Sir, via the prostatic...
We remain to breast only. Dr. Manoj, you can go.
Yeah, please. Dr. Sumita Jain, please, ma'am. Ma'am, are you there?
What are other differential diagnoses in this patient?
Ma'am, considering the age of the patient and the given findings, I have carcinoma breast in my mind because she has positive findings in the axilla as well as supraclavicular lymph node and the appearance of pure day orange, which more likely go for malignancy. If there is another, like if my diagnosis after investigation is still not confirmed, I'll keep other things in mind.
How will you differentiate it with the tuberculosis of the breast? Tuberculous mastitis or tuberculosis? Or granulomatous mastitis?
Ma'am,
granulomatous mastitis.
In patients with mastitis, like they will give a history of, like, the patient will have constitutive features of tuberculosis. So there will be either weight loss, anorexia, or cough, which might suggest of another foci of TB. And other than that, she might also have on investigations when we get a biopsy done, it might be suggestive.
We are just talking of clinical things, not investigations and biopsy, just on clinical examinations, history and examinations.
Based upon the history, there will be evidence of history, symptoms suggestive of tuberculosis, and on findings, there will be presence of matted lymph nodes, which usually might be present in the axilla, but not involving the supraclavicular lymph nodes.
You may get, in tuberculosis, you may get all the wonders, right? So.
Yeah, Dr. Navneet, ma'am, please.
Yeah, I think a few things I would like to emphasize in your history and examination. In history, for example, like just for the spinal tenderness, you missed out on lumbar spine and you talked about dorsal and cervical. Similarly, in your symptoms of metastasis, you talked about alteration of bowel and bladder habit, which is not the case with metastasis from CA breast to the abdomen, right? That was a very gross mistake to talk about LMP when the patient is postmenopausal, right? And then I think you have mentioned about the mid-arm circumference on one side. So what is the relevance of examining it only on one side?
Ma'am, like I checked for the presence of lymphedema. I have not mentioned, but I compared the mid-arm circumference on both sides. It was right side 21 centimeters and left side 22 centimeters.
So you have to say that so that you are able to convey that you are looking for the presence of lymphedema, which is already there, right? And your sequence is like you have to start with nipple, then areola, and then skin of the breast. It's not the other way around that you talk about purely orange, then you'd say nipple is retracted. So there is a sequence to be followed to keep it coherent, right? So that was feedback about your history and examination, things which could have been better. And now that we have a patient who has one diagnosis is a locally advanced breast cancer, and one differential which has been discussed is a tubercular mastitis. So how would you proceed next?
Ma'am, once I have taken my history and clinical examination, I will go ahead with bilateral mammography and core biopsy of the lump in the breast. And in this case, I would also go ahead with fine needle aspiration cytology of the involved supraclavicular lymph node and the axillary lymph node. And digital mammography will be done so as to look for the presence of other cancers in the opposite breast. Whereas on core biopsy, I will look for the presence of the grade of malignancy, the ERPR status, and presence of lymphovascular invasion. And FNAC is mainly done to look for the status of supraclavicular and axillary lymph node, which if involved would be clinically stage N3C. And other than that, once my diagnosis is confirmed, I basically, because it is a locally advanced breast cancer, I will also go ahead with metastatic workup in this patient. So for that, I will get complete blood count and liver function test. And other than that, there is a role of contrast enhanced CT scan of the thorax and abdomen to rule out metastasis. There is also, I will also get done bone scan because I want to rule out bone metastasis. Yes, ma'am, this is the metastatic.
Okay. Yeah. Thank you.
All right. So, okay. I would like her to comment on the role of PET CT at this stage. Will this be a patient you would like to consider for a PET CT scan or not?
We can consider PET CT if the patient is affordable and we have the facility of a PET scan that can be done. But with this care,
it is only the availability that will make a choice, or you think this is an important investigation?
Ma'am, for patients who are having stage 3C and stage 4 malignancies, PET can help us to see the presence of another metastatic foci, so it is useful.
All right. Okay. Should I continue?
Dr. Shushanto, please. Yeah, Shushanto. Dr. Shushanto, please.
Your history and examination was okay. My only thing is that you should slightly slow your pace down of your presentation. We're quite fast. I missed a lot of the history because of your pace. Otherwise, it was good. And any role of CT chest, since we had already started the management part also. Role of CT chest in carcinoma
yes,
breast.
sir. In this patient, I would like to get a carcinoma, because it is a locally advanced breast cancer. I will get a contrast enhanced CT of the thorax and abdomen. Thorax to rule out the presence of lung metastasis, and abdomen to see for the presence of any abdominal metastasis.
So it's mandatory for all the patients, or is it only a certain subgroup of patients? If your chest X-ray is normal, you will still go ahead with a CT chest in all the patients?
Sir, patients with stage 3 and stage 4 breast cancers, we usually get a CT to rule out the presence of, because the incidence of metastasis in these patients is very high, so we will get it done. And in addition to X-rays.
Okay. But then again, the role of PET CT comes. So if you're getting a CT of the chest and abdomen, which is preferred now, whether to straight away go for a PET CT or individual CT abdomen or thorax?
Sir, PET CT will be done usually for those patients who are having stage 3C and stage 4 malignancy.
Almost similar to what you said about CT chest and abdomen also. Isn't the indication same for CT chest and abdomen?
Yes, sir, but sir, if the patient is symptomatic and if she's having any metastatic symptoms, then we'll go ahead with a PET CT. Otherwise, we will we'll do a CT thorax and abdomen only.
Nowadays, with availability of PET CT so commonly, especially for locally advanced malignancies, rather than getting an individual CT scan, you should get a PET CT nowadays with availability of PET CT so commonly. Because the indication of both the things is similar to what you said. And symptomatic, again, your patient is not symptomatic for any of the metastatic lesions.
Yeah. Dr. Swani, please. Your input, please, Dr. Swani. Yeah.
Yes, I want to actually, sorry, I got a call, so I missed the initial part. You've written multiple matted lymph nodes in left axilla level 1. So, how did you find out it's level 1 on clinical examination?
Ma'am, the lymph nodes are palpable in the anterior axillary fold. So, level 1 lymph nodes are anterior, posterior, and lateral lymph nodes. So, that is why I concluded them to be level 1.
So, it would be better if you can tell which group of lymph node you've palpated rather than going into level 1, 2, or 3.
Okay,
and what is the disadvantage of getting PET CT done routinely in locally advanced breast cancers as a staging modality? Okay, so you talk about the NCCN or the ESMO guidelines, they all recommend CT scan, right? That is what you were saying. So why is it that CT scan is the preferred modality, or is still, what is the problem with PET CT?
Upstaging of the disease with PET CT.
No, but then CT will also upstage it if there is a metastasis.
Even the inflammatory lesions might appear to be malignant on PET CT. So
yeah, so it adds more to the confusion than as a problem solving tool. Okay. How will you go about now? You've got a CT scan and a bone scan done. There is no evidence of metastasis. Now what will you do?
Metastasis.
Ma'am, once my metastatic workup is over, and based upon the hormonal status of the patient.
The patient has a triple negative breast cancer. Ki67 is 60%. And there are no metastases, and your stage is T4B and 3C M0.
Ma'am, I will go ahead with neoadjuvant chemotherapy first with taxane-based chemotherapy. So I will go ahead with in a HER2 triple negative, the HER2 negative patient, I will go ahead with dose dense AC followed by paclitaxel plus trastuzumab. And not trastuzumab, it's HER2 negative. So dose dense AC followed by paclitaxel is given every 2 weekly. And that I will assess the patient after 3 cycles of chemotherapy for the response. And if the patient has adequate response, then I can go ahead with further cycles of chemotherapy. Or if we are planning for surgery, then this chemotherapy can be also given in the adjuvant setting.
So any investigation you like to get done before starting dose dense AC?
Dose dense AC, ma'am, 2D echo to look for the ejection fraction, because adriamycin is considered to be cytotoxic, cardiotoxic.
Anything else? Blood tests?
Ma'am, routine blood investigations. I will get CBC done to look at the blood count because these drugs predispose to neutropenia or cause neutropenia. And other than that, routine biochemical investigations like liver function test and kidney function test.
Yeah, okay. Thank you, Swani. Tanvi, one question from my side. How do you assess the clinical response to chemotherapy in such patients?
Sir, clinical response to chemotherapy can be assessed either clinically by examination. So we will assess the lump, whether it has decreased in size after the every cycle we will assess the lump. And one is clinical method, one is by radiological investigation. So we can use an ultrasound, which can be used to, it can give an idea whether the lump has decreased in size from the previous size. And the third is pathological response can be assessed. When we are planning this, post-surgery, the pathological specimen that has been received for the resolution of the tumor.
Okay. No, I have just asked you about the clinical assessment of the response to chemotherapy. Okay, sir, can we come back to Dr. Shadi Thomas, please? So she has started with chemotherapy.
Yeah. How do you assess how do you say the patient is responding to chemotherapy?
Sir, after 3 cycles, we will look at the size of the lump. If there is a complete resolution, a complete decrease, then it is considered as complete response. Then more than 30%, if there is a decrease in the size of the lump from the previous first cycle, then it is considered to be partial response. Whereas if there is more than 20% increase or if it is less than 30% decrease, it is considered to be stable disease. And if the lump size increases from the first time to the time of assessment by more than 20%, it is considered to be progressive disease.
How long will you continue this neoadjuvant chemotherapy? 1, 2, 3, 5, 6?
Sir, like for HER2 neo negative patients in this scenario, if I'm giving chemotherapy and there is a response, then all the cycles of chemotherapy can be given in the neoadjuvant setting, and then we can go ahead with surgery. Otherwise, we can plan for cycles of AC, which we do in our institution. Then we can give the patient the option for surgery. And after discussing with the patient after surgery, we can give her the 4 cycles of paclitaxel.
In other words, when do you decide to continue? When do you decide to stop the chemotherapy or change to something else? Is it 3 cycles, 4 cycles, 6 cycles? When do you assess?
Sir, we will assess the response of the patient in a multidisciplinary approach in the tumor board. And if we will discuss it with the patient, and if the patient, like there is a response to chemotherapy, we can explain this to the patient that she can undergo further cycles of chemotherapy. And later we can go ahead with surgery. Or
Tanvi, Dr. Thomas is just asking you after how many cycles of chemotherapy you would say that you want to change over to some other drugs or some other treatment.
Sir, we assessed the
how many cycles?
3 cycles. After 3 cycles, we assess the response to chemotherapy.
See, the assessment of chemotherapy has to be from the first cycle onwards. It's not that you wait till the 3rd cycle. After the first cycle, suppose you find it's increased by 10%. Now, the 2nd cycle is increased by under 20%. You will not say, oh, I'll wait till the 3rd cycle and then I will assess the patient again. So, if you have to assess the patient after each cycle. When do you assess? You give the cycle today, you assess tomorrow?
Sir, after 3 weeks, when the patient comes.
Before the due of the next cycle is when you assess whether the response is not that you give this injection today and assess tomorrow whether it has changed or not. Okay. After neoadjuvant chemotherapy, what next?
If the patient is responding and later next week for after the chemotherapy is completed, we'll go ahead with surgery. And based upon the stage of my patient,
you are given the chemotherapy, there is no palpable lump left.
Sir, in this scenario, I will go ahead with and because preoperatively, if there was a if I had marked the lump site with a seed or a clip, then it would have aided in surgical resection. But otherwise, I will go ahead in this patient with left-sided MRM and yes, sir, and post-operative radiotherapy.
What is the role of breast-conserving surgery in locally advanced breast cancer?
Sir, in early operable LABC, for those patients who select patients with 3A stage breast cancer, we can give them neoadjuvant chemotherapy, which can downsize the size of the tumor so that it may permit us to do breast conserving surgery while preserving adequate margins, while giving us adequate margins. And if this is possible, then we can go ahead with BCS and post-operative radiotherapies to be given. But if the lump size does not adequately decrease and the tumor to breast ratio is not enough that it will permit us to do BCS, then we will have to go ahead with MRM.
Okay. Thank you, sir. Dr. Atri, sir, please, your take.
Tanvi, can you tell according to the stage what is the incidence of skeletal metastasis?
Skeletal metastasis. Sir, the values I don't remember.
No, there is a definite, according to staging, you do get increased incidence. So what is the incidence in stage 1 of cancer, in stage 2, local and this? So that was the question. If you don't know, we got the. Say this patient has got skeletal metastasis, how your management will change?
Sir, in a patient with metastatic breast carcinoma, we will evaluate the patient, and if she is hormone receptor negative, ERPR negative patients, then we will prefer chemotherapy. For hormone receptor positive patients, we will give endocrine therapy. Or if they are not having any visceral, limited visceral metastasis with no evidence of visceral crisis. Otherwise, if she's having hormone refractory metastasis,
but you are explaining me in a very different way. I said the patient has got skeletal metastasis on bone scan or PET scan, whatever you do. So how your treatment modality in this patient? Dr. Thomas has asked in detail about everything. How your further strategy will change in the treatment?
Sir, like in addition to chemotherapy, we have to also give bisphosphonates in this patient or anti-rankle drugs like denosumab. And other than that, like we will, the main aim in these patients with metastatic diseases to improve survival and quality of life. So I will go ahead with palliative chemotherapy and bisphosphonates for the bony metastasis.
And you will not contemplate doing the mastectomy in this patient?
Sir, mastectomy in these patients can be done, but it does not improve the overall survival. So metastatic carcinoma breast to decrease the tumor burden, or if it...
Survival is the second benchmark. I am talking about the overall holistic approach to a locally advanced breast cancer with, then it will definitely not be LABS. But I am just giving you a scenario that there is a
metastasis.
How will you treat the breast then?
Sir, we can do mastectomy to decrease the local tumor burden, but in a metastatic carcinoma breast, that is usually not recommended according to guidelines.
You will not. You will do what type of mastectomy? Simple, or you will do modified radical? What type of mastectomy you will do?
Sir, we will in these patients metastatic disease, we will do simple mastectomy to decrease the local tumor burden, so as to decrease the chances of ulceration and other skin changes. But axillary dissection only plays a role in staging. So for metastatic CA breast, it does not improve survival. So we only do simple mastectomy.
Last question from my side, rather query. Is it a standard, even the panelist can tell, doing CT scan of chest and abdomen in locally advanced breast cancer?
Sir, for all patients with locally advanced breast cancer, because the risk of metastatic disease is very high at the time of presentation, so we will always get a CT thorax and abdomen to rule out the same.
How will it change your management then? If you get the metastatic changes in the abdomen or liver or in the chest?
Sir, the same, metastatic disease, again, we will do the same thing.
And it will become stage 4 disease, we know that.
Yes, sir.
Okay, so how will you tackle that?
Sir, in these patients, we will give them chemotherapy based upon their, if they are ERPR negative tumors, we will give them chemotherapy, and ERPR positive tumors, we will give them hormone therapy.
I think majority of our hospitals do not have luxury of having CT scans. And if you send these patients for combined CT of this abdomen and thorax, and then it becomes definitely beyond the capacity of the patient to pay for investigation. I just want from panelists, maybe that it may be helpful to others also. The panelists.
So definitely CT scan, chest and abdomen is indicated in such all locally advanced breast cancer. I think that is a different situation when we don't have facility for CT. It's highly unimaginable these days. So can we move on to Dr. Sumita Jan, ma'am, please, your take on this?
Metastatic workup, yes, in locally advanced breast cancer. Role of PET CT is only when the routine imaging like CT, abdomen, chest is equilocal or suspicious, otherwise not. But there's one big advantage of PET scan is that we can see internal membrane nodes. That helps in managing nodal radiation. That's the one thing. Otherwise, PET CT has no role in locally advanced breast cancer. My question to Tanvi, yes. If the patient presents with the contralateral axilla positive for node, how will you treat this patient?
Ma'am, contralateral node positivity is again considered to be a metastatic disease. So we will manage it on the lines of metastatic breast cancer.
No, now these patients are being treated as locally advanced breast cancer with curative intent. You call it metastatic, but because there's no other metastasis anywhere in the body, it's only contralateral axilla positive, then you can treat this patient as locally advanced breast cancer with curative intent. It definitely increases, it helps in overall survival increase, right?
Thank you, ma'am. Dr. Navneet, ma'am, please.
Yeah, so this was about the neoadjuvant chemotherapy and response, and you mentioned that you would like to put a clip if a patient is being put on neoadjuvant chemotherapy. So what is the best time to place that clip?
At the time of true cut biopsy, at that time we can place a radioactive clip or a magnetic seed at that same instance, so that when we get the once we get the true cut report and we start the patient on chemotherapy, then later we can see for the response, and if the lump decreases, it might be helpful for us at that time.
So it may so happen that you may place, there's a large tumor which is not a symmetrical ball as such. You may place it in the periphery and the tumor shrinks differently, right? So how will you then be able to excise completely? So the point of putting a clip is that it should be in the center of the
lesion.
And the regression may not happen concentrically, right? So it may end up that you have placed the clip in the periphery of the tumor. After 2 cycles, it is lying in the periphery. So that is the consideration when you are placing a clip, right? Unlike for the axillary nodes, when it is at the time of FNA that you want to put a clip, because they don't have that bigger size and they will not shrink in a very non-concentric manner. The situation with the breast primary is different. So it is not ideal to place it on day 1 at the time of two-cut biopsy. So what is the second best, or I would say the preferred method of placing a clip in a patient of LABC undergoing neoadjuvant chemotherapy for the purpose of conservation subsequently?
Ma'am, mammographic, we can do it after mammographic localization of the lesion and then...
So the tumor is so huge, it is palpable. Why do you want a mammographic localization?
Ideally, the seed is placed under guidance. So we will do this under USG guidance.
Any imaging, it can be any imaging, whichever is being used. And I think using ultrasound is easier than a mammogram for palpable lumps. So you can do it. The best is to do after 2 cycles when you are sure that the response is coming, right? And the tumor has started shrinking. Because if you do after 2 to 3 cycles, you will still have the tumor which is there and you can place it in the center of that mass. And then subsequently with 4 or 6 cycles or 8 cycles, when you go up for surgery, you have the tumor position identified on the basis of clip if there is a complete pathological response. So the ideal time for placement for LABC, the clip is after 2 or 3 cycles, after there is some shrinkage, and then you are able to place a clip in the center of the tumor. And one more comment about the PET-CT. PET-CT is an accepted modality for stage 3C, even by NCCN guidelines. There is a risk of overstaging and inflammatory markers, inflammatory pathologies being taken as a metastatic disease. But I think that is very small percentage of patients where this confusion will arise. 90% of patients, you will have a very good picture on PET-CT scan about the extent of staging. So PET-CT is very much indicated for stage 3C lesions.
Okay.
Tani, I have one question.
Okay.
Is this candidate is for BCS, this particular patient? T4B and C disease?
No, ma'am. She has supraclavicular lymph nodes positive. So for this patient, we will go ahead with modified radical mastectomy.
Then why do you want to place clips and all these things?
Ma'am, this clip is so as to guide the surgical resection because this was initially an inoperable breast cancer with skin changes. So if the lump totally regresses in size, so that might not give an idea about the adequate margins for surgical resection in MRM.
Margin for in MRM, which margin do you want to take?
Ma'am, to guide the incision while we are placing, when we are doing the surgery. So if we have an idea about the area which was involved with preoperative marking and a clip, that area can be adequately resected and sent for pathologic analysis.
Modified radical mastectomy, you are removing whole breast.
The question arises only when you are contemplating breast conserving surgery.
Only breast conserving surgery. In this patient, there is no role of clipping.
Modified radical mastectomy.
And why do you want to give neoadjuvant chemotherapy still?
Thank you. Thank you, ma'am. Doctor.
Yeah, please.
Okay, thank you. Dr. Shashanto, any more inputs from your side?
The only thing that she said, simple mastectomy in a metastatic disease. For localized metastatic, like for the vertebra, there also you should do a proper modified radical mastectomy because you are decreasing the tumor burden. Simple mastectomy nowadays is only restricted for those fungating lesions where
bleeding also.
Patient is unable to tolerate prolonged anesthesia or the risk of surgery is higher. Only in those cases. Otherwise, it should not be the modality of choice of surgery.
Okay, thank you. Thank you. Dr. Swani, last comment from your side.
So how will you follow up this patient after surgery and after the adjuvant therapy is done? How will you follow up? You've done the chemo, radio, everything.
Ma'am, clinical examination of all patients who've been operated and received treatment.
No, how will you follow up this patient? Let's talk about her.
This patient will be followed up every 3 monthly with clinical examination for the first 2 years after surgery, and clinical examination will be done every 6 monthly in the next 3 years. And after a course of 5 years has elapsed, we will follow up the patient for every 1 yearly. And mammogram to look for the presence of primary in the other breast will be done annually for the first 5 years, and then as indicated.
Okay.
Okay, thank you.
Thank you very much. Thank you, Tanvi. Please go off. Stop sharing the screen with us.
Yes, sir.
Yeah, thank you. Now,
Thank you,
I would like to invite the next student, that is Dr. Manjunath, AK from MLV Jhansi. He will be presenting a case of neck secondaries with unknown primary. I would again like to remind esteemed chairpersons to kindly evaluate and mark the candidates simultaneously, and subsequently at end of session, please hand over these marks to us. Thank you. Dr. Manjunath, are you there?
Good afternoon, sir.
Good afternoon. So
Good
can you
afternoon.
start sharing your screen with us?
Yes, sir.
Yeah. We are still not getting your slides.
Sir, it is already shared, sir.
Can all of us see?
No, we can't. I can't see.
No, we can't see.
You unshare your screen and then reshare it, because it's showing that you started screen sharing, but it's not coming. एक बार आप unshare कर लीजिए इसको. Dr. Manjunath, you unshare your screen.
हाँ मैम.
ऊपर देखिए आप एक ऑप्शन है.
यार मैम, give me some time, मैम.
Dr. Manjuna, I send a request. If you approve it, you directly share your screen.
Sir, the system is hanging, sir. 1 minute.
Yeah, still not there.
आशीष, डॉक्टर सौरभ हियर. इनके ना पीपीटी होंगे आपके पास, आशीष.
ठीक है सर, मैं शेयर कर देता हूँ.
You just आप उनको रेडी रखिए.
You have to say next for your next slide, okay sir? I am sharing, sir. Give me a minute.
Yeah, now it's there.
Dr. Manjunath, can you see this screen? Dr. Manjunath?
Are you there, Dr. Manjunath? Where has he gone?
His laptop was hanging, so he may have logged out actually.
So
we are sharing this slide from our side, so he can just say next, and we can change. Where has he gone?
Yeah, Dr. Manjunath, are you there?
Manjunath is not on the system now.
Not in the system. Dr. Sarab, can we go on to the next part and come back to his case presentation after the lecture?
Yes, sir. Yes, sir. You can do that, sir.
So in the meantime, Ashish can contact Manjunath and tell him to be on hold. Is Dr. Manjunath?
Sure, sir.
Okay. Yeah. Sorry for this thing. We'd like to request Dr. Shaji Thomas to come and present his lecture on surgical part of this presentation, that is mastectomy. And we can go back to the case to be presented by Manjunath after sir's lecture. So, sir, can we go ahead with your lecture, please? Dr. Shaji Thomas, please. Yeah. We can see your slides, sir. But we are not able to hear you.
I'm audible, I hope.
Yeah. Now you are there, sir. Now you are audible, very much audible.
Okay, to all the students who are here for today's update, I'll try to keep it brief, not too long. This is not a talk to teach you how to do a mastectomy. This is just to acquaint you how to handle your table viva when you have an operative surgery table viva and you have a chit that says mastectomy written on it. These are some of the questions that you are likely to be asked. Obviously, I can't cover all the questions that can be asked, but this will be some of the common questions that will be asked when you pick up a chit that says mastectomy in your operative surgery table viva, both for MS as well as your DNB. So I'll just cover briefly some of the few points that you're likely to encounter in this topic of mastectomy. Now, as you all know, surgery is a primary treatment for breast cancer. And the goal for any surgical treatment will be a complete resection of the primary tumor with negative margins and with pathological staging of the tumor and lymph node for prognosis. Now, there are a lot of operative procedures that you will be named when it comes to the breast. Some of them can be overlapping. For example, breast conserving surgery, wide local excision, lumpectomy, partial mastectomy, segmental mastectomy, talectomy, quadrantectomy. Many of them are used in overlapping terms. Then there can be total or simple mastectomy. There can be modified radical mastectomy. There's a radical mastectomy. There's a term called extended radical mastectomy. And now there is something that has come up called a skin sparing and a nipple sparing total mastectomy. Okay, now I'll just briefly talk about breast conserving surgery or lumpectomy. Now, this basically refers to a complete surgical resection of primary tumor with negative margins. It can be done either with palpation or with image guidance. And they're applicable to most patients with stage 1 or 2 invasive cancers. There are only some relative contraindications: small breast size, large tumor size, collagen vascular disease, or any contraindications that go along with associated radiotherapy. Now, the contraindications can be multifocal disease, relative contraindications can be multifocal disease, past history of radiation, or inability to undergo radiation therapy for invasive disease, pregnancy, or persistent positive margins after conservative surgery. Cosmesis obviously is important when you're doing a BCS, but it should not outweigh clinical priority of obtaining negative margins. If you're asked about the technique, it can be performed either with palpation guidance, as in most of the cases that you see in our country, or with image guidance, where in countries where they are picked up on image, early lesions are picked up on image, which is not so common here. For image picked up lesions, wide localization of non-palpable image detected lesions are done. The specimen should be evaluated radiographically to confirm excision of the lesion before completion of the operation. A post-surgery mammogram should confirm that all calcifications have been removed. And in these sort of cases, at least a 2 millimeter margin is reasonable, and the specimen must be oriented. It's a mammogram that shows the lesion that's transfixed by the guide wire. And this is the specimen radiograph that shows the localized mass that has been removed with a good excision margin. There are options for breast reconstruction after partial mastectomy, breast parenchymal local flaps, or faciocutaneous local tissue advancement flaps, or bladderless dorsi myocutaneous flaps. These are the commonly used techniques. Then we come to total mastectomy. This refers to complete removal of all breast tissue. Again, how far should one go? Should one go to the clavicle superiorly, or the first rib, or the second rib? Well, it can vary. It varies to surgeon to surgeon. Your anatomy book says that the breast starts from the second intercostal space. So there are many surgeons who insist that one do not go above the second intercostal space. But yeah, classically it was described that you remove from the clavicle superiorly to the sternum medially, the inframammary crease inferiorly, the anterior axial line laterally, and with en bloc resection of the pectoralis major fascia. And the nipple area complex is resected with a skin paddle. When you just say total mastectomy or a simple mastectomy, it does not refer to removal of any axillary nodes, but may be performed in conjunction with sentinel or axillary node dissection. I mentioned all the variants that are mentioned along when you use the term mastectomy. Modified radical mastectomy, that is when you do a total mastectomy with an axillary lymph node dissection. A radical mastectomy, which is when you include the resection of the pectoralis major with an axial lymph node dissection. An extended radical mastectomy, which is a term used when internal mammary lymph nodes are excised, not done. Now a skin sparing total mastectomy and a nipple sparing total mastectomy, which has come up recently. A skin sparing total mastectomy and a nipple sparing total mastectomy, they're two modern variations. They're designed mainly for patients who elect an immediate reconstruction, and they're minimally invasive procedures. Technically more difficult, more time consuming, but it preserves the patient's skin envelope and inframammary fold and gives a good cosmetic appearance. Now, it's intended to be a complete total mastectomy with the same extent of resection as a traditional total mastectomy. And the reasonable oncological choices for prophylactic mastectomy and for selected early stage breast cancers. Now, obviously, it's not appropriate for cancers that are near the skin or the nipple, or for locally advanced or inflammatory cancers. When is a total mastectomy without an axillary procedure indicated? That can be in a risk-reducing mastectomy, or a local recurrence in a previously treated breast cancer, or a malignant phylloid tumor. And the contraindications of doing this total mastectomies are for inoperable locally advanced breast cancer. The procedure, as you're all aware, it's the elliptical incision, which is most usually used, enclosing the nipple area complex, or if scars are there, one can use a kind of lazy-S incision. There's a technique which some surgeons use for hydrodissection, that using a mixture of saline, local anesthetic, and epinephrine infiltrated subcutaneously to raise the flaps to decrease bleeding. In nipple and skin sparing mastectomy, they're perioreolar incisions with lateral extension. This is an elliptical incision that's made to remove the nipple areolar complex. The incision is deepened by diathermy and subdural veins are coagulated. The next question at this stage that you can be asked is, how thick should the flaps be? Flaps can vary from 5 to 10 millimeters thickness. There's usually, when you do an adequate traction and counter traction, there will be a bloodless plane between the subcutaneous tissue and the breast tissue. One can talk about the fat lobules, the size, etc. But with adequate traction, counter traction, you'll come across a bloodless plane, which is the plane. And the thickness can vary depending on how obese the patient is and how thick the subcutaneous tissue is. Again, the medial limit is the sternum. Lateral limit is the anterior border of the latissimus dorsi. The superior limit can be from the secondary or up to the clavicle. The inferior limit is the inframammary crease. The breast is lifted off the pectoralis major in a medial to lateral fashion. The internal mammary artery perforating branches are coagulated. If axillary dissection is indicated, it can be done through the same incision. And the drains are placed, two, one in the parenchymal defect, the other in the axilla if an axillary dissection has been done, and is removed when the discharge is less than 30 ml per day. This is a raised superior flap showing the breast being dissected off the underlying pectoralis major. And this is at the end of the procedure when the pectoralis major and the serratus anterior are visible. Questions that can be asked about complications. Commonly wound infection, seroma, skin flap necrosis, hematoma, chronic pain, dog ears, might not look good cosmetically, lymphedema, more so when it's associated with an axillary dissection and radiotherapy. Fibrosis, there's always a risk for local recurrence and shoulder stiffness. Reconstruction can be immediate or delayed. The options can be implant-based expanders and saline or silicone implants, or autologous tissue-based methods using a tram flap, latissimus dorsi flap, or an inferior epigastric perforator flap, or a combination of the two methods. Where reconstruction has been used, there can be complications: infected or ruptured prosthetic implant, capsular contracture, flap necrosis or loss, fat necrosis, asymmetry, scarring. Whenever you're asked a question on mastectomy, axillary dissection and axillary treatment will not be far behind. And invariably, or you should be ready to answer questions on axillary procedures whenever you pick up shit on mastectomy. And the two axillary procedures that you have to be aware of are the central lymph node biopsy and the axillary lymph node dissection. Again, briefly, some of the points that you should know. It's a minimally invasive procedure to stage axilla in breast cancer patients with clinically negative nodes. And the central nodes, as you know, are the first group of nodes that drain from the breast to the axilla. Indications are virtually all clinically node negative T1, T2 invasive breast cancer, and DCIS in whom mastectomy is required or when invasive disease is suspected. Now, SLNB is also done in these conditions, but there is limited data and it can be slightly controversial whether you should do it in locally advanced breast cancers and should you do it before or after neoadjuvant treatment, etc. The role of sentinel lymph node biopsy in multifocal multicentric disease when there's prior radiation therapy or prior breast and axillary surgery and after neoadjuvant therapy. Okay, these are still evolving fields and there are institutions where it is being done, but there's definitely no role in inflammatory breast cancer. The technique, the best results in a combination of careful intraoperative digital examination and lymphatic mapping. Lymphatic mapping can be done by injecting radioisotope alone or radioisotope plus a patent blue dye, which can be isosulfan blue or methylene blue. The injection can be subareolar, peritumoral, intradermal, or intraparenchymal. Most commonly used is subareolar. Intradermal can give rise to tattooing, not very popular. 1 to 3 lymph nodes are removed and they're tested to look for macrometastasis. Failure of lymphatic mapping can occur in medial lesions that sometimes map to internal mammary nodes without concomitant drainage to axillary nodes, or injection into a cavity with a mature lining, the lymphatics, it doesn't go into the lymphatics, or if there's excessive inflammation around a biopsy site that occludes lymphatic channels, or if there's obstruction of lymphatic channels by tumor, or if some lymph nodes are replaced by tumor, or uncommonly if lymph nodes are replaced by fat in elderly patients. When SLN mapping is not successful, then axial lymph node dissection is recommended. Contraindications are if there are obviously clinically suspicious axillary nodes, which should be evaluated by ultrasound FNAC prior to surgery, and if there's biopsy-proven node disease. Then a few points on axial lymph node dissection. Now, this refers to a complete en bloc removal of level 1 and level 2 axillary lymph nodes. It's defined by the borders of the axillary vein superiorly, the latissimus dorsi muscle laterally, the medial border of the pectoralis minor muscle medially, and the subscapularis posteriorly. And the level 3 nodes are removed only if suspicious or palpable adenopathy is present. You should preserve the nerves, the long thoracic, the thoracodorsal, the median and the lateral pectoral nerves, intercostal tubercle nerves also if possible, unless it is going through tumor. Axillary lymph node dissection has got significant morbidity. Lymphedema rates can be anything from 20 to 30% over a long period. There can be shoulder dysfunction, wound infection, seroma, nerve damage, numbness, chronic pain, and very rarely brachial plexus injury. Post-operative surveillance, or rather post-treatment surveillance, 3-monthly clinical assessment for 2 years. Some institutions follow up to 3 years, and 6-monthly for the next 2 to 3 years, that is still 5 years, and then annually for lifetime. Mammography annually. An aggressive workup for metastasis is not required in the absence of symptoms like bone pain, headache, abnormal laboratory chemistry panels. This is in brief about the points that you might be expected to know, which will be asked when you in operative surgery table viva. So I've just covered that. This is not, like I said, a lecture to teach you how to do a mastectomy. Thank you.
Thank you. Thank you, sir. Thank you, sir. Can we go back to Dr. Manjunath? Is he there? Ready with his presentation? Dr. Manjunath, are you there? Unmute yourself, please. Can you hear us? No, we can't hear you.
He was there. Yeah,
no, he's coming. Yeah, Dr. Manjunath, yes. So, Dr. Manjunath from MLB Medical College, Jhansi, would be presenting his case of neck secondaries with unknown primary. So, yeah, are you ready, Dr. Manjunath?
Yes, sir, I'm ready.
Yeah, share your screen with us and make it full screen. Yeah, now we can start. Start, please.
To all the dignitaries present here. Now I'm presenting.
You are still not audible.
Hello, is it audible, sir?
Yeah, now audible. Yeah.
To all the dignitaries here. I'm presenting a case. Here is a patient named Mr. X, age 65-year male, is a daily wage worker, belongs to the low socioeconomic status, residence of Jhansi. Presenting with the chief complaint of left-sided neck swelling since 4 months. History of presenting illness. Patient was apparently asymptomatic 4 months back. Then he noticed the swelling in the left side of upper neck while he was shaving. It was insidious in onset and progressive in nature. Initially, swelling was pea-sized. Now the swelling is of lemon size. The swelling is not associated with sore throat, pain and fever, breathlessness, discharge, change in the voice, no aggravating and relieving factors. Patient also has a history of loss of appetite since last 3 months. Weight loss, along with weight loss of about 10 kg in the last 3 months. No history of any other swelling in the neck and any other part of the body. No history of bone pain, joint pain, pruritus or malaise. No history of unique rise of temperature, night sweat, cough, pneumocrisis, chest pain, sore throat. No history of difficulty in opening mouth, oral ulcer, exophytic growth, excessive salivation, extraction of filthy nature, sharp edged tooth. No history of ear pain, deafness, nasal blockage, bleeding through the nostrils or trismus. No history of dysphagia, dyspnea, hoarseness of voice or swelling of teeth. No history of exposure to any radiation. No history of hyperthyroidism. Coming to past history, no history of tuberculosis in the past. No history of any previous surgery or swelling in the neck. No history of any oral ulcer or growth. Coming to personal history, patient is a BD smoker since 30 years, 20 BDs per day. Tobacco chewer since 20 years. Alcohol intake of 1 to 2 times a week since 20 years. Patient consumes mixed diet. Comorbidities, no history of any thyroid disorder, diabetes or hypertension. Family history, nothing significant. No history of tuberculosis in the family, or no history of malignancy in the family. Drug history, no history of any drug intake. Hello?
Yeah, please go ahead.
Coming to the general physical examination, patient was conscious, cooperative, and alert. BMI is 17.9 kg per meter square. On ECOG, score is 1. Pacing is normal. Nutrition inadequate. Hydration adequate. BP 130 by 72 mmHg. Right arm sitting position. Pulse 82 beats per minute. Regular. Normovolumic. Temperature of febrile. Mild pallor is present. Icterus absent. Cyanosis absent. Clubbing absent. Generalized lymphadenopathy not present. Both the supraclavicular fossa free. Coming to the local examination, on inspection, a single swelling of approximately 6 to 5 cm over the left side of the neck. It is irregular in shape. Margins well defined with lobulated surface. No dilated vein seen. No discharging sinus. No visible pulsation seen. Trachea is midline in position. No other swelling seen, including thyroid. Is normal. Tenderness absent. Size 6 to 5 cm. Irregular in shape. Hard in consistency, surface lobulated with well-defined margins, mobility skin over the swelling is pinchable. Superior on the dimensions of the swelling, superiorly 1 cm below the angle of mandible, posteriorly 2 cm beyond the posterior border of the sternocleidomastoid, anteriorly 2 cm lateral from the midline, inferiorly 1 cm below the thyroid cartilage. Lymph node levels present at 2A, 2B, and 3. Palpation of continue, non-expansile, no transmitted impulse site, carotid impulse palpable on both the sides, no other lymph node palpable in the neck. Pre-auricular, post-auricular, occipital lymph nodes not palpable.
trachea is midline in position, not tender. Thyroid is not palpable. Oral cavity examination, poor oral hygiene. Rest of the things are normal. That is, lip is normal, mouth opening, 3 fingers, tongue and tongue protrusion normal. Floor of the mouth, hard and soft palate, retromolar trigone. We did not see any core or ulcer. Alveolus, no swelling or tenderness. Ula, midline in position. Bimanual examination, parotid and submandibular not enlarged. Pharynx normal. Nasal cavity, dorsum, midline, vestibule is normal, septum is midline. Examination of face normal. On para-abdominal examination, abdomen is scaphoid, no hepatomegaly or splenomegaly present. CDL, S1 and S2 are normal. Respiratory system, bilateral respiral sound present. CNS, clinically normal. Spinal examination, no tenderness and abnormality. Case summary. Here is a 65-year-old male patient with the left side neck painless progressive swelling since 4 months with history of BD smoking, tobacco chewing, and alcohol intake, with a loss of appetite and significant loss of weight. On examination, swelling is non-tender, hard in consistency, lobulated surface with level of lymph nodes 2A, 2B, and 3 group are involved with the dimensions of 6 into 5 centimeter. Clinically, it is P0, N2B, M0 stage. Provisional diagnosis. Here, a 65-year-old male patient with a painless progressive swelling on the left side of the neck at the level of 2A, 2B, 3 with stage of P0, N2B, M0. Probably, it can be a neck secondary with unknown primary.
Thank you. Sir, Dr. Thomas, sir, so starting from you only. So we can't hear you, sir. Please unmute yourself. Yeah.
Can you hear me now? Okay. Yeah. Can you tell me what do you think is the likely etiology? Do you think it's likely to be congenital, traumatic, neoplastic, inflammatory?
It is more of a neoplastic etiology, sir. The features by the history and clinical examination, it is more of a neoplastic etiology.
You don't think it can be chronic inflammation like tuberculosis?
Sir, on the history, there is a loss of weight, loss of appetite, along with rapid increase in the size of the sphincter.
Okay. You think it's primary or secondary?
On the examination, sir, since the levels of level 2A, 2B, and 3 groups of lymph nodes are involved, sir, we have to search for the primary case. More of a secondary, next secondary.
Dr. Manjunath, sir is exactly asking that only. Do you think this swelling is a primary malignancy or a secondary malignancy?
Sir,
why not a primary?
More of the features are suggestive of secondary malignancy, sir. No primary.
Why not a lymphoma?
Since it can. I have a 2-3 differential diagnosis, sir. First of all, I will be considering next secondary with unknown primary. Next with tuberculosis. Next lymphoma. It can be lymphoma, sir. But since the consistency is hard and since the consistency is hard, sir, I am not thinking of lymphoma.
Okay.
Okay. Yeah, Dr. Atri, sir. Sir, are you there, please?
When you have a neck swelling, you always keep the differential diagnosis. You just kept one provisional diagnosis and rest it is being asked by the faculty, like Dr. Shadi asked. So you have to know different. You said there is a weight loss. Even tuberculosis can produce weight loss. We know that. But you have to say points in favor and points against of such a swelling. Okay, all neck swellings are very because you don't have any evidence of any primary in this patient. Is there any change in voice? I missed that particular point. Change in the voice of this patient, hoarseness of voice or anything?
Okay.
You did not mention, I think it is.
I have mentioned in the history, sir.
And you mentioned it in the history. Okay, it must be, don't go. Okay, so show the photograph of the swelling.
Clinical photograph, please.
Clinical photograph. Yes. This is the, describe the swelling once again now.
On inspection, sir, swelling
you can combine everything, you can combine.
Pardon?
There is no other swelling other than this in the neck.
Sir, no other swelling.
Okay, so if you have secondaries from unknown primary, it usually have only one lymph node involved in the beginning, or one group of lymph nodes involved.
No, sir. It may involve multiple groups, sir. But, since sir, in this patient the swelling is large, sir.
I come to the same point. Why you did not consider of tuberculosis in this patient as a first possibility? When you did not have any evidence of primary, why did you not? Because it is a clinical. What is tested in the exam or in discussion is approach towards patient, but not about the diagnosis. Diagnosis may turn out to be something else. Your approach to the patient has to be on those lines. Why did you not think of tuberculosis in this patient as a first possibility?
Since the swelling is hard, sir, since the swelling is hard, sir, which has rapid increase in the size and loss of significant weight loss in the last 4 months, sir.
So we have to rely on your finding that it is a hard swelling. What type of swelling you get in tuberculosis, and what type of swelling you get in this lymphoma?
But lymphoma, we get a rubbery consistency, sir. In tuberculosis, the consistency varies as the stages of TB, sir. Initially, when it is enlarged, it may be hard, sir. Later on, it changes its consistency to firm, and
it may be the first stage. It may be tuberculosis and hard. Okay.
Other features.
Your presentation should match with your history and other things. Examination in totality now.
Yes. Based on my history, sir, within the swelling of since 4 months, sir.
Tuberculosis can also appear in 4 months. Tuberculosis can also, and tuberculosis is far more common entity in our country than other conditions. Dr. Manoj, you can go ahead.
Yeah, please. Dr. Sumita Jain is madam with us. I think she had to attend an urgent official meeting, so probably she has left. Madam, Dr. Navneet Kaur, ma'am, please.
Yeah, I think looking at this picture, I would like you to consider why can't we say that this is a involvement of nodes in the level 5? Why did you only say level 2, A, B, and C? What is the boundary of level 5 group of lymph nodes?
Posterior border of the sternocleidomastoid is the boundary. Since my swelling is extending beyond the posterior border, it may be, but as per the patient, the swelling was originated from lateral part of the neck, then it went beyond.
But do you think there are multiple matted nodes, or is it a single node?
Since the swelling is of 6 to 5 centimeters, the lymph node can at this size it actually ruptures. So it cannot be a single node at this stage, ma'am. It is a
So then why should we rely on patient's version that it started medially and then now the same swelling has grown in size and is jetting out posteriorly? It is possible that this group of nodes is also involved.
Ma'am, it can be more level 5.
So what are the boundaries of level 5 group of nodes?
Anteriorly, posterior border of the sternocleidomastoid. Posteriorly, anterior border of the trapezius.
Right.
Anteriorly, 1/3 of the clavicle.
Okay, so this is the upper 5A, which is primarily visible in this picture. So how is that important? If we just upgrade from level 2 A and B and C to level 5 also, how does it change the possibility of looking for a primary?
Level 5 group of lymph nodes usually drain the scalp, parotid, and the posterior part of the nasopharynx. And along with at this age, we can also consider a differential diagnosis of pharyngeal polyp.
All right, so the primary sites that you are going to look for carefully will accordingly be decided by the group of nodes that you find on examination, isn't it? So on clinical examination, you are not able to find anything which can point towards a primary. So what is the next step?
I have to take the FNAC of the lymph node, ma'am.
FNAC may just tell you what you know clinically. It's a squamous cell carcinoma. So does that resolve your query?
No, ma'am.
About the primary?
Yes, ma'am. First, based on my history and the clinical examination.
So after history and clinical, it is your unknown primary, right? Your primary is unknown after your detailed clinical assessment, right? So now what is the next thing that you need to address? You're going to look for an occult primary. So how do you look for the occult primary which may be there?
I will be doing a pan endoscopy. For the nasal endoscopy, I will be looking for the
nasal endoscopy. What is that? Nasal endoscopy?
Nasal cavity and nasopharynx are using this.
Nasal examination is not pan endoscopy. What are the three components when we say it is pan endoscopy?
Esophago-bronchoscopy, laryngoscopy, and indirect and direct laryngoscopy, esophago-bronchoscopy, and gastroendoscopy.
No, there's no esophago endoscopy or something. It's esophagoscopy, laryngoscopy, and bronchoscopy. Okay. But other than that, you have to examine. So that is still part of the clinical examination. Before you proceed to pan endoscopy, what are the other things that need to be done? You may be a general surgeon, but you may need help of a specialist who can look at areas which you can't look at, as we are not trained as general surgeons in doing that.
Basically, ma'am, indirect laryngoscopy we can do it clinically also in the open setup.
So what do you want to look for in indirect laryngoscopy?
We have to look for larynx and hypopharynx. Those are the term larynx, hypopharynx.
So since they have very limited kind of evaluation on indirect, you will be doing a direct laryngoscopy, which becomes part of your pan endoscopy. But before that, what else can be looked at? Something you said initially as part of pan endoscopy, but that is not the pan endoscopy, but it is the first step in evaluation.
Nasal cavity.
You examine the nose and the sinuses, right? So that examination will be done by ENT surgeon, and if nothing is visible either in the nasal cavities or in the paranasal sinuses, which can be clinically assessed, then obviously you will have to go. So how is pan endoscopy done? Who does that? Where would we do that?
It is a combination. They have to involve otorhinologist along with general surgeon.
So before this, an invasive procedure, right? This will require an anesthesia. But before you do that, what else can be done? So what is the role of imaging when you are evaluating a patient of unknown primary?
After this, we have to go for pan endoscopy. Then
after that, what is the role of imaging?
MRI. Since it is an invasive procedure, non-invasive procedures like CT or MRI can be done.
Okay. Can we go on to Dr. Sushanto, please? Sushanto.
Hello. One thing in your examination, the photograph which you showed, is it a nodular lesion? Because you said lobular, because it's appears like a big nodule which is sitting on the top of that lesion. So I feel it's a discrete nodule, and that's the only part in the examination which I found that probably should have been corrected by you. It appears like a big nodule. I mean, 2-3 nodules are actually visible on this photograph itself.
And posteriorly, it is popping out, sir. It is like more of a multiple nodules, sir. So I said I use the terminology only.
So that's why I said it should be called a nodular lesion rather than a lobular lesion. And I agree that it looks like a posterior triangle lymph node mass rather than a anterior triangle lymph node mass, at least on the photograph. Clinically, I don't know what it was. Coming on to the, supposing there are two scenarios. One, this comes out to be a adenocarcinoma on your FNAC. How will it change your investigation protocol?
So if it is an adenocarcinoma, I have to look CT and MRI of head and neck. And I will be looking for the glands like parotid gland and thyroid gland. Then after that, I will be going for malignancies of the lungs and abdomen. So I will be getting a chest X-ray and ultrasound whole abdomen. And I will be
okay. Where all are you suspecting other than salivary glands?
Sir, pardon me.
I didn't get the last part. Where all are you suspecting the primary to be?
In case of adenocarcinoma.
You only said the primary may be in the parotid gland, thyroid gland, in the lungs, in the stomach, in the prostate, and the testicular may be there. So I will be investigating based on the organs.
What about colorectal area, colorectal region?
So if it is a colorectal, sir, I will be getting a swelling for in the abdomen, sir. Abdomen. Firstly, before coming to the next swelling, the paraortic and parotid nodes will be enlarged. So since the abdominal examination of this patient is nothing.
So I mean we are dealing with probably a hidden primary. So patient may not have presented with any symptoms related to colorectal region or maybe gallbladder or stomach. But still, as Dr. Shushanto has pointed out, if it turns out to be adenocarcinoma on FNA, then these are the areas which should be screened for possible primary. Okay, can we go to Suhani? Dr. Suhani, please.
Yes, sir. So, Dr. Manjunath, actually, I was not clear. What did you say about the imaging? You like to get a chest X-ray, ultrasound, abdomen, and
HRS of the pelvis, sir.
Sorry, I can't understand.
Just the whole abdomen, pelvis, and HRS the inguinal scrotal region.
I am not able to follow. What will you get for the inguinal scrotal region?
Basically, we will be looking for the testicular. If it turned out to be an adenocarcinoma, then it will be the last consideration. But we have to investigate if we don't get any other malignancy.
So, for abdomen and chest imaging, neck imaging, what imaging will you do?
What will you do for imaging suspected primary in the abdomen? Once you get adenocarcinoma in this FNAC of this neck swelling, which
just if the abdomen is not significant, I will be going for CCT abdomen.
And from this FNAC, would you like to get a coroneal biopsy also, or only FNAC will suffice?
Then at this stage, I will not be considering biopsy.
You will?
Normal anatomy of the neck.
I didn't get you. You will be getting it done or not getting it done? Yes or no?
At this stage, I will be searching for the primary then. I will not get done a biopsy now. If I didn't get any primary, then lastly I will be going for biopsy.
So what will happen if you get a biopsy, coroneal biopsy done?
Sorry, you are speaking about the coroneal biopsy?
Yeah, I'm saying that you have got an FNAC done, which shows that there is a adenocarcinoma. You are getting imaging done to hunt for the primary. You are not able to hunt it as far as now. Or even while you are getting the imaging done, would you like to get a core needle from this neck node mass?
Yes. Core needle can do.
How it going to help you?
Since if the FNAC If the FNA is not significant, then coronary biopsy will be helpful.
No, but I'm saying that the FNAC shows there is adenocarcinoma. Would you like to get a coronary biopsy from this next node or not?
Not necessary, ma'am. No need.
So will you get it done or not? Necessary or not necessary?
Say yes or no.
Yes, ma'am.
Okay, then madam is asking, how will it help you? Will it not help you to identify cell of origin? Probably it will indicate something about the primary somewhere. Some investigations can be done on that biopsy specimen. I think that is what Dr. Sohani is trying to ask you. IHC, markers and other things. Yeah.
So I'm telling you that you should get a coronary biopsy because it's not a very big invasive procedure. It's an OPD daycare, minimally invasive procedure. It will give you a good tissue to have better identification of the cell of origin, and you can easily do immunohistochemical markers to know whether it's a carcinoma, sarcoma, whether it's okay, you have an adenocarcinoma. What you can do markers to identify the source of origin, and you can get a focused imaging of that particular part.
Exactly. So can we come back to Dr. Thomas, sir?
Yeah, Manjunath, this position that you're showing on the photograph is, I think, level 2 and probably level 5. Now, just tell me, what are the primaries that come here, this particular site? That's level 2 and probably level 5. Where will you look for? What are the areas of primary?
Level 2 lymph nodes drain basically the nasopharynx.
Okay. Okay, oropharynx, nasopharynx, hypopharynx, then the scalp, maybe the parotid can come here. Okay, now as Dr. Sohani said, you do FNAC first. FNAC can show you either squamous cell or it can show you adenocarcinoma. If it's adenocarcinoma, you look at those parotid, etc., where it could be the primary, could be there. Now, squamous can be from a variety of places in the upper digestive system. Next would be a core needle. And then what's the role of a PET CT in such a patient where you can't make out primary in the initial investigations, clinical investigations? Is there any role for a PET scan?
The PET scan we can consider also. Since the cancer cells take the FDG18, fluorodeoxyglucose 18, it will be a necessary investigation to trace the METs and also the primary.
Would you like to do your CT of the chest, abdomen, pelvis, or would you like to do a PET scan to see where the source of likely primary? If the PET scan does not show any of the primary, then what should you do?
Yes. See, Manjunath, there is a possibility that whether your routine imaging, as possibly guided by core needle biopsy and IHC markers, the routine imaging may take you to the primary. But there is again a strong possibility that they still may not show the primary. Then you go for a PET CT, whole body PET CT. That may or may not show you the primary. So sir is asking, if the PET CT still does not show or be able to locate the primary, then what will you do? How will you proceed further? If primary is located, things become easier. If primary is still not located, then what will you do?
We can do the surveillance biopsy, which are taken from the upper side.
Can you repeat it? Your voice is not very clear. It's crackling.
Sir, we can do surveillance biopsy. Sir.
Surveillance biopsies, sir. Dr. Thomas, sir, he says surveillance.
What is surveillance biopsies? Where all will you take what?
From the upper side, such as fossa of Rosenmuller, tonsil, base of the tonsil, and piriform fossa.
Okay, if that is negative, any role for tonsillectomy?
Sir. If the biopsy findings are negative, sir, we can do ipsilateral tonsillectomy.
Okay, there are very rare situations where you cannot trace the primary. In today's era, when you have PET scan done, you have CT scans, etc. done. Usually, with fine needle aspiration, you will come to know generally what it is likely to be. With a core needle biopsy, which you should do with the markers, you might be able to have some idea where the primary is coming from. And based on that, you can proceed next whether your PET CT will help or it's a pan endoscopy that will help. And based on that, then you have to assess if all of them are negative, you still cannot, then you must figure out whether a tonsillectomy should be done. Very often, sometimes small lesions in the tonsil has been shown to give rise to this kind of lesions. And you must also assess whether this lymph node group is likely, you can do some kind of surgical excision or lymph node dissection with some kind of possible curative intent if the primary is not localized anywhere. It's a small primary that you cannot figure out where it is.
Okay, thank you. Okay. Dr. Atri, sir.
Can you think of any remote possibility of it being a benign lesion in this area?
Benign, it can be like lipoma, sebaceous cyst. It can be, but consider
No. You are going for that. It's not neither it is cystic nor it is soft.
Yes.
I'm talking about anything. What is this actual site for carotid? Say some examiner may be very imaginative, like I am imagining it. Any other possibility you can think of? Because in absence of any primary, and clinically you have not confirmed it, pathologically you have not confirmed it that it is a metastatic lesion. So can it be some other primary lesion? You have already told tuberculosis, lymphoma, you have told those possibilities. Any other remote possibility which is not very common? Have you heard about carotid body tumor? Is it a site for that?
More lateral, sir.
More,
the swelling is more lateral.
Where it arises?
It will be in the carotid triangle, sir.
Carotid triangle?
Carotid triangle.
Triangle, or where the what happens to carotid? From where it takes the blood supply?
Blood supply.
Carotid body tumor, from which part of carotid it takes blood supply? Okay, chalo. So I think you have already covered everything, and all the panelists have asked the relevant questions. So Dr. Manoj, you can.
Yeah, Dr. Navneet ma'am, we still have around 10 minutes with us.
Okay. So I think I'll ask you something which is going to be the most likely scenario. This is a patient who is a chronic BD smoker or whatever, and he's elderly person. He has nodes in the upper neck, and this is most likely to be a metastatic squamous cell carcinoma. On examination, you are not being able to pick up a primary, right? So now we have discussed all the investigations which can be done and in what will give you what information. Can you spell out for me steps 1, 2, 3, 4? How will you proceed now with the evaluation of this patient? Clinical examination, no primary, upper neck nodes involved, elderly person and a chronic smoker or whatever, BD. And likely probable diagnosis, 80%, 90% will be a squamous cell carcinoma. So how would you now investigate this patient? 1, 2, 3, 4, tell me that. Pan endoscopy is not the first thing. That is invasive. That should come in the end. So let me answer it for you. First, ENT evaluation, right? Then head and neck CT scan to pick up any primary which may not be visible clinically. Indirect laryngoscopy followed by a pan endoscopy and the biopsies if nothing is being picked up on any of these, right? Role of PET CT we discussed and role of core needle biopsy we discussed. So at what stage will the PET CT be useful to you? Should you do core biopsy before or after that? So you are done?
Yes.
You are not able to pick up anything on CT of head and neck region. Let's presume that, not even on indirect laryngoscopy. Before you go for pan endoscopy, which will be under anesthesia, which will be accompanied by biopsies, you can subject the patient to a PET CT scan, right? So would you like to do a core needle biopsy before PET CT or after? And any reason to make a particular choice, one over other?
PET CTs are high cost. We can go for core needle biopsy after that.
So you want to do PET CT first and core needle biopsy after that?
Core needle biopsy first and PET CT after that.
Okay. So what are the problem if you do a core needle biopsy first and then do a PET CT? What can be the problem?
it is invasive.
So what with invasion?
For needle.
So what is the problem with invasive procedure before PET-CT?
Feeling may be higher.
So it will change the anatomy of the region. It may also increase the uptake of the tracer because the tissue is now traumatized. So biopsy should be done after you are done PET-CT. That is the point I wanted to make, because PET-CT is a good investigation, rejected for the simple reason that it may confuse picture in inflammatory pathologies or these kind of situations when the tracer uptake is higher. Okay. And if after all this we still don't have a primary identified, and you have defined this node as 6 by 5 centimeter mobile, not fixed to skin, or though it is looking very close to skin, at least in the picture, almost ready to jut out of the epidermis, but still I accept it as a mobile node, then what will be your next call?
Management part.
Yeah, what next?
We can do a neck dissection. Radical neck dissection.
Radical neck dissection. So would you like to proceed with radical neck dissection, or you have alternatives?
We have modified radical neck dissection. Selective neck dissection. But in this patient, we will be considering a modified radical or a radical.
Okay. Any role of selective neck dissection?
Selective neck dissection in this patient, no role, man. Since it is done for L0 nodes, where the primary is known and lymph nodes are not enlarged. It is preferred in L0 node.
So what is the indication for selective neck dissection then?
If it is a tumor of a nasopharynx with L0 node, will be operating on the primary.
What do you really understand by selective neck dissection? What is
like it, based on the region? If the supra-omoid neck dissection, where the level 1, 2, and 3 lymph nodes are removed, group of lymph nodes are removed. Whereas in the anterolateral selective dissection, level 2, 3, and 4 lymph node groups are removed.
So unless you have an identified primary, then you can't choose a selective. It has to be selective in the context of where the primary is identified, and then the draining lymph nodes can be picked up, avoiding the radicality of the procedure. Okay. What is the role of sentinel node biopsy in head and neck cancer? Do we use sentinel node biopsy? Is it modality being accepted as a procedure of use?
Yes or no?
No.
No.
Okay. You need to maybe go and read about it today. You will find what are the indications and how useful this can be.
Okay, Dr.
Head and neck
Shushanto.
cancer.
Yeah.
I'm not talking about this case, right?
Shushanto, Dr. Shushanto. Are you there? Dr. Shushanto, please. No. Dr. Sohani. Dr. Sohani, are you there?
Sir, yes, sir.
Yeah, please.
I think we've covered enough.
Okay. So my question from my side, Manjunath, suppose as Madam was asking, you are still not able to find the primary, and we have on biopsy and FNAC proven it to be a squamous cell carcinoma. Is there any role of systemic chemotherapy as a primary treatment modality in such cases?
So we can do a insulated tonsillectomy, then we can do a radical neck dissection. If it is a squamous cell, no role.
See, we have not yet been able to locate the primary. You are just probably trying to treat the secondary by removing all the nodes on that side of the neck.
Suppose patient says no for surgery. Do you have an option? Patient says, I don't want to get operated. I'm old. I may not be fit also. With comorbidities, he could be having coronary artery, bad chest. What can be the alternative?
We can go for chemotherapy with cisplatin paclitaxel.
So you have not thought about radiation therapy as the second line of treatment?
Therapy can be given up to 40 to 45 days.
I think that should be considered first before you talk about.
Definitely.
Can I
Yeah, sir. Dr. Thomas, sir, your concluding remarks.
Dr. Manjuna, did you mention ultrasound of the neck? We have done a lot of extensive investigation. Did you mention ultrasound of the neck? You would like to do ultrasound of the neck before putting a needle into the neck, whether it's fine needle or core needle. You'd like to see what this swelling is: single, multiple, calcified, solid, complex. How many are there? Which are the areas that are involved? What is the thyroid? What is the relation to the carotid? What is the relation to the internal jugular? Before you tell your first year PG to go put a needle into it. And the core needle can sometimes be more dangerous than a fine needle in the neck. So I think first investigation that you should get done first in ultrasound of the neck to see what exactly is going on there. And then you decide to put in a needle, etc. Now, suppose you do this test and it comes out as lymphoma. Can you tell me how to stage lymphoma? First of all, what is A and B symptoms in lymphoma?
A is asymptomatic. B has symptoms like weight loss more than 10% in the last 6 months.
10% where since?
And fever, night sweat and fever.
10% weight loss in how many months?
In 6 months.
Okay. Drenching night sweats. These are B symptoms. Okay. How do you stage lymphoma? Suppose it is lymphoma.
So according to Ann Arbor's stage,
Uh-huh.
it is staged into 4 stages. Stage 1, single lymph node. No extra lymphatic site is involved. Stage 2, more than two or more than 2 lymph nodes. With,
more than two lymph nodes? Or lymph node groups?
Lymph node group with extra lymphatic site involvement.
What kind of fever do you get in Hodgkin's?
Pelepsin fever for more than 10 days.
What is pelepsin fever?
It's the waxing and waning of the fever episode. Sir.
What is waxing and waning? What is the classical pelepsin fever?
For after every 3 to 4 days, it will be getting a fever. Sir.
There will be
fever episodes after every 3 to 4 days. Sir.
It lasts for how long? How many hours?
More than 48 hours. Sir.
Is present in only a minority of patients, but where the classical pelepsin is present, then is very, very typical of Hodgkin's lymphoma. It's high-grade fever lasting for anything from 3 to 7 days. Then the patient becomes almost afebrile for the next 5 to 7 days. Then he starts having fever again. When this occurs, it's very characteristic of Hodgkin's. Any particular cell type that you get in Hodgkin's?
Yeah, in Hodgkin's, we get a rich stomach cell.
Okay. I don't think you need to go into the classification, pathological classification of lymphomas and all that.
Thank you. Thank you, sir. Thank you, sir. I think we have covered most of the aspects related to these neck secondaries with unknown primary. And now we come to the end of this session. And I would like to thank all our chairpersons for sparing their time to guide our postgraduates. I would request all chairpersons to please send us the marks given to each of these 3 students. They can send it to us by the WhatsApp or maybe an email. And now I would like to hand over to the day repetitors, Dr. Gyan Saurabh and Dr. Saurabh Bogadia. Thank you. Thank you very much.
Thank you all.
Thank you all. Is Dr. Gyan Saurabh there?
Sir, I think you can introduce the next speaker only.
This next मैं ना अपनी अटेंडेंस लेता हूँ हम ये यूँ कह रहे हैं कि पहले SRPG की बनाओ एक्चुअली वो पुट अप नहीं कर रहे.
Okay, now we go over for the inaugural function. And Dr. Gyan, are you there? Yeah.
Yes, sir. I'm very much here, sir. Actually, Director, sir, is busy in some commitments, so he would be joining us soon. So till then, we can have a tea break for some time. So all the residents and faculty members could have tea. We wish that we could have served to you physically, but unfortunately, we are on virtual mode. So all of you could take a quick break.
For 5 minutes, we can take 5-10 minutes.
Yeah, till the time Director, sir, is joining for the inauguration ceremony. So, but be online, everyone. I request you all Okay. So we have our next moderator as well as of other faculty member here. Ashok sir, there has been a question from one of the PG student. What about microinvasion carcinoma breast? Is chemotherapy indicated in these patients? So somebody has written this question in the chat box.
Microinvasion? What? Please repeat.
Probably what I believe is that the case scenario was ongoing on the early carcinoma breast.
Okay.
The case presentation was ongoing on that. So probably somebody has put this question in the chat box. So I thought if we're having some free time, let us utilize it. So he has probably asked if there is microinvasion. He has written chemotherapy advised question mark.
Microinvasion or micrometastasis, I think he is a bit confused about it. Microinvasion is always the margin is related to it, and micrometastasis is something else. So when you are suspecting micrometastasis, there is a role of chemotherapy. Otherwise, microinvasion doesn't have, because anyway you have to take a margin of 2 centimeters if you are going for breast conservative surgery, or if you are doing MRM, there is no question of microinvasion.
Okay. So if there's any other question till the time we are having some free time, so you can put your question, all the students. You can put your question. It's a wonderful opportunity to discuss your doubt. As far as the first session goes, so we had a case on early carcinoma breast, locally advanced carcinoma, and then next secondaries. So if you have any query, so we have all faculty members sitting here. And I would request the previous chairpersons and faculty members also to be present for the inauguration ceremony, which is about to begin shortly.
Gyan, there was I think the question on microinvasion.
Yes,
if there, like Dr. Ashok said, there are two different things: microinvasion and micrometastasis. Micrometastasis per se is not an indication for in lymph nodes. That's not indication of sentinel node biopsy. That's not indication for chemotherapy. Sentinel node biopsy, as I already mentioned, if it's micrometastasis or isolated tumor cells, that's not indication for sentinel node biopsy. Axillary lymph node dissection if it's in the lymph node. If you're talking of microinvasion in the primary tumor, indication of chemotherapy, that's only if those patients are lymph node positive. That's an indication of chemotherapy. If the lymph nodes are negative, then it is indicated if the tumor is more than half centimeter in size with bad prognostic indicators, either ERPR negative, HER2 positive, or microvascular invasion, etc., high grade tumors. Then and only then. Just having a foci of microinvasion without lymph nodes less than half centimeter in size is not an indication of chemotherapy. That is for the primary tumor.
I think a couple of other queries are pouring in chat section. So as far as a question regarding imaging modalities, so one PG is not clear as to what imaging modalities should be used. I believe they're talking about carcinoma breast, or are they talking about next secondaries? This particular person hasn't made it clear. And he's also putting in a question, any role of radiotherapy to neck in unknown primary?
It has already been discussed by Dr. Navneet. If you are not able to find out any other primary source which you can treat, then you have the options for local control. Your option is for your surgery or local radiotherapy, depending on where it is or the extent of the disease. But obviously, if you see the primary, then only you'll come to know what exactly the chemotherapy or whatever is can be done. But in the absence of that, just like you talk about in the breast or in the axilla, you'll have to think of doing a surgical excision if it's possible to excise it completely, or radiotherapy for control, for local control.
Another question is regarding, is there any size criteria below which primary is less likely to be detected?
This for breast or for?
No, sir, for primary. They're probably trying to ask question regarding
next secondaries.
Yeah, next secondaries.
I think the size criteria should be only those sizes which cannot be picked up by normal imaging like CT. So anything less than that would constitute this particular size below which it cannot be picked up.
It depends. There are small mucosal lesions that may not be picked up. Sometimes may not be picked up even by endoscopy. Solid lesions less than 1 centimeter may not be picked up even by ultrasound and by CT scan. So even PET scan need not necessarily pick up small lesions and lymph nodes, and that can be confused with inflammatory lesions. So no lesion is no investigation is 100% sensitive or specific in picking up some of these. So that's why you may have to use multiple modalities, biopsies.
So another question is regarding SLNB in neck. Yes, sir. Has sir joined?
Just trying to offer a clarification. I think the candidate wants to know under which size are these lesions difficult to be picked up clinically? Because the clinician is more worried about picking it up clinically. Now, as far as the investigations go, different investigations have different level of sensitivity. So that is up to that investigation. But as far as we are concerned, we usually say that lesions less than 0.5 or lesions less than 1 centimeter can be missed clinically in a high proportion of cases. And that is why we use these ancillary modalities like CT scan and ultrasound to pick up, which now form an extension of the clinical examination. But clinically per se, lesions less than 1 centimeter would be very difficult to pick up. So I think that would be, would answer the question better to that candidate.
So a few more minutes. Dr. Ankita has just called me to tell that sir has reached and he would be joining very soon. So any other question in the chat box? The students can ask question related to the previous session. I guess all the questions we had covered so far.
Gyan, there's a question like SLNB neck when all used.
Somebody has put in this question. So do we have any comment from any of the chairpersons?
Sentinel it is about the selective lymph node dissection?
I believe, Shadan, that is pertaining to the neck secondaries with unknown primary.
But this is sentinel node biopsy.
About the sentinel
lymph node biopsy in neck when all used. This is what he's trying to
let me clarify. As far the current literature is concerned, in various centers, it has been shown that sentinel lymph node biopsy is an excellent modality for early breast cancer, and it is recommended for the center with a very good facilities for sentinel lymph node biopsy. And only there is a small concern of false negative, less than 10% cases, what they have said. During the follow-up, the node may come up. So for early tumor, small, that will also depend upon the primaries. So if the center is well equipped and primary is small, you can go with the sentinel lymph node biopsy. However, if the primary tumor itself is a big, so there is a phenomena called shine through, where they says radioactive tracer uptake in primary often masks the basically the sentinel lymph node. So then pickup rate goes down. And another thing is, if the primary tumor is very advanced, what it will do, it will be destroying the lymphatics, and then your first echelon may change. So if it is for early lesion, if your center is well equipped, it is a very good modalities. It can be used.
The question was SLNB neck, not in the breast.
Actually,
Yes, sir, it is about the neck.
Asking about SLNB in neck. The question is regarding that. And,
yes, sir. The answer. I was answering about the sentinel lymph node dissection in the neck with suspected oropharyngeal primaries.
Okay.
So early tumor, well-equipped center, no problem.
Another question is presence of axillary.
It is not
lymph node.
relevant in this, Manoj, it is not relevant in the case that was being discussed because there's basically large palpable lymph node. So that was just a theoretical question that was asked by one of the examiners. It was not pertaining exactly to that particular patient because this patient has obviously got a big lymph node.
I think that Madam herself clarified.
Yeah, it is only for where there is no palpable node. It is recommended NCCN where facilities are available that you can do sentinel node biopsy for head and neck cancers.
There are two more questions, I believe. Is presence of axillary lymph node contraindication for BCS? No. Is HER2 neu positive bad prognosis and why? You have a treatment against HER2 neu positive patients. So you usually do not consider it to be a bad prognosis. Third is in case of unknown secondary, it should be unknown primary. It was
nowadays when you talk of this, when it comes to prognosis, as of today, there are two types of staging in breast cancer. One is your normal anatomic staging, other is the prognostic staging. The prognostic staging takes into account both your ER/PR positive negative as well as HER2 positive negative. And the prognosis is based on the available treatment modality for those particular lesions. It's not an untreated HER2 positive or an untreated ER/PR positive. The prognostic staging is taking into consideration that you're given the appropriate treatment for that particular biological markers. So you have a full two-page prognostic, both clinical as well as pathological staging of breast cancer based on all these markers. So those who are interested, they can go into that in detail, but it's not something that you should memorize. You should just know that prognosis depends on these factors and the prognosis based on appropriate treatment for that particular marker.
Okay. So last question is unknown primary, not clear whether biopsy first or PET-CT. I think that has already been answered by Dr. Navneet Kaur.
See, you are doing a PET-CT to look for a primary. For that, you have to first prove that it is actually a malignancy. It could be tuberculosis, it could be whatever, like a carotid body tumor. So first you should know the anatomy, get a local ultrasound done, find out what exactly it is, then do an FNAC or a core needle again under image guidance, and then decide what to do next based on the likely primary and where, how, and likely it is detected.
I think the last one has already been answered. Dr. Gyan, are we ready for inaugural function?
Sir, I just got a call from sir that he is joining very soon. So just wait for some. Although we took a margin, we had given 30 minutes for the inauguration, which wouldn't last for more than 7 to 10 minutes. So we do have a good margin. And we have this moderator and the chairperson for the next session ready, as well as the presenters. So we'll quickly go through the inauguration ceremony. Just got a call from sir.
Whatever you're speaking now is audible to all the participants, or is it just between a few of the organizers?
Sir, it is whatever you are discussing right now is visible and audible to all the
all 450.
Yes, sir. Yes, sir. It is. We are live right now.
Okay, so
it is live in YouTube also. We have got the YouTube link also. It is live in YouTube also, sir.
Good. So I put my video on.
You're looking very handsome as always. So you have been clicked in the multiple screenshots so far, which you will see later when your session gets over.
So
I think we must thank Dr. Thomas. He gave us a few 10-15 minutes extra from his lecture, which we could devote to the discussion of the cases.
That becomes very important. That's a very good opportunity.
I could have used it now.
So, Dr. Lal sir, you are muted. Please, unmute कीजिए अपने.
Okay. I wanted to ask a question to the outside panelists, non-Lady Harding, because हम लोग तो आपस में डिस्कस करते रहते हैं. So can anybody tell me, not can, but you can, but please will you tell me what is the status of carcinoma breast in Indian scenario today? Do we treat it above cervix, or it has still to catch up, and why the changes are coming, so that we have a general perspective, question to the students. Anybody? I see.
हमें जवाब देने से मना कर दिया, अब क्या करें हम?
Naveen is there. Sanjeev Singhal is there. Or okay, sir has also joined, I think.
Ashish, please enable audio of director, sir. He has probably joined.
Yes, sir, it's enabled, sir.
Let me see. Because he has already joined, just got a call from Dr. Ankita that he is able to hear us and see us, but his access to microphone is denied.
Sir, good afternoon. Can you hear us, sir? So we are not able to get your audio. We can see you are trying to speak, but we're not able to get the audio.
Sir, I think some technical issue with Sir. So Ankita is making him join through her own mobile. So at least he would be visible and he would be able to see us. There's some technical issue. He's trying to, now we can see, sir. But his voice is not.
He is appearing unmuted, but we can't hear him.
Is volume there or is?
Good evening, sir. If you can, director, sir, if you can hear us, maybe the volumes, it's not open.
सर के माइक्रोफोन तो ऑन का ही दिखा रहा
है। या तो ऊपर से माइक्रोफोन बंद होगा। ये ऊपर से तो कैमरा होता है।
नहीं सर, म्यूट का साइन नहीं आ रहा है।
नहीं आ रहा, म्यूट का साइन नहीं आ रहा है।
If
he can hear us and
sir needs to log from some different.
I think you can try in the next room.
This is what it is.
Why Ankita is not giving her phone?
Sir, Ankita is already there. I just called her up, but I believe that she is trying to help him.
He's also not able to log in.
Yeah. Because the fact that he's logged in a meeting means that nothing is wrong with the link. There's some technical glitch probably on the desktop or the laptop.
Ashish, kindly unmute, sir.
Hello.
Good evening, sir. Now we can hear you, sir.
Yeah, there's some technical glitches in the last minute, and one of the, my desktop, which is supposed to be one of advanced version, was not letting me to speak to you. Allowed me to log in. I was visible. I could see you. I could hear you, but it was not allowing me to speak to you. So okay. What ends well is well, and so should I now start?
Yes, sir. Thank you so much, sir. Sir, sir, can you hear us?
Yeah.
We can't see him. We can't see him.
Yeah, okay, sir. So, sir, now after such an informative session and bit of technical jingling, we are back to action. And now we'll begin with the inauguration ceremony of the 4th edition of LHMC PG update. Before we begin, I'll just recite shloka. To begin with, the shloka goes like it's in Sanskrit. Vakratunda Mahakaya Koti Surya Samprabha Nirvingam Kurum Deva Sarve Karvayeshu Sarvada, which means, O Lord Ganesha, with the effulgence of a billion suns, always remove the obstacles in all our undertaking. And the biggest obstacle in an online program is internet. So we wish we do not have any internet technical glitches during the entire course. And I'm sure the course is going to run very smoothly from that angle. Now, may I request our organizing chairman, Dr. Umesh Lal, Director, Professor and Head, Department of Surgery, to grace the virtual podium. On behalf of organizing chairman and organizing committee, I request our chief guest, Dr. Ram Chandra, Director, Professor and Director of Lady Harding Medical College, to be on virtual podium. Thanks for your time, sir. Now we would request our patron and ex-head of the department, Dr. Shaji Thomas, to be on virtual podium. Now I would request organizing committee members and the whole Department of Surgery to grace the virtual podium. Now we'll begin with the inauguration ceremony with Saraswati Vandana. Mr. Ashish, to play the Saraswati Vandana. Ashish, are you there? Ashish, can you hear us?
So we are sharing.
Ashish and Pragya, please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Okay, so I wish that Saraswati, after Saraswati Vandana and after the prayers that we have recited, I wish that the whole program is going to run very smoothly without any glitches. Now, may I request Dr. Rumesh Lal sir, our organizing chairman, to give the inaugural speech.
On this cold and rainy day, after a little bit of delay, I bring very warm greetings and a very good afternoon to all the faculty and delegates on behalf of the Department of Surgery, Lady Harding, New Delhi. Again, on behalf of the Department of Surgery, Lady Harding, I would extend a very warm welcome to our patron and chief guest, Dr. Ramchandar, our very own likable director. Now, continuing with the endeavor and unflinching quest to dissipate surgical knowledge, on this momentous occasion of the inauguration of 4th edition of LHMC Surgical Clinical Update, we are honored to bring to you an extravaganza of academic feast specifically designed for the exam-going PGs and DNB candidates. Initially, we had planned to conduct this update offline, and we thought that we would have the privilege of hosting you all. However, due to the third wave of corona setting in Delhi, there was a setback and the offline mode had to be shelved. But as every setback either breaks you or gives you an opportunity, we took the opportunity of holding it online. And it is heartening to know, and I'm proud to inform the August virtual house, this year 350 plus students have already registered. We had closed the registrations, but on persistent demands and requests from the students who were not able to register early, we had to open the registration. These students who have registered, they will be enlightened by a strong and an exceptionally experienced faculty, which numbers over 70. In addition, we also have complimentary free registration of 200 final year exam going students of Lady Harding. So therefore, we have a gathering of 650 to 700 participants in this online mode that we are going to present. Now the question arises, what is so special about Lady Harding holding an update? And what is the reason for its success? What is the USP? Sorry, there was this. Okay, so now I would say the reason why Lady Harding updates are successful are because of the team Lady Harding Surgery Department. We have experienced teachers, we have experienced examiners who are in great, since Delhi is a central location, our faculty members are in demand for examinership right from Kashmir to down south and anywhere in the country. So that's one thing, is that we have the experience of teaching and taking exam. And the other advantage we have is that Lady Harding is a very regular center for the conduction of surgical MS exams and DNB exams. So we not only have the knowledge, we also have the facility to hold it. Therefore, after being armed with such a strong faculty and such an enthusiastic delegation attendance that we have, in the presence of state-of-the-art infrastructure backup, we would just like to inform that presently the net we are using is a backup network. We have, I think we have begun very well, but as we all say, well begun is only half done. So we therefore over the next 4 days will strive to deliver and come up to your expectations and promise to make this memorable update for you. After this short introduction, I will now request our chief guest, Dr. Ramchandra, Director LHMC, to say a few words to encourage and boost the morale of the expectant students. Sir, Dr. Ramchandra, and thank you all.
Yeah, I was hearing. Thank you, Dr. Ramesh Lal, for giving me an opportunity to interact with my own colleagues, which you have said that a faculty of 70 and a delegation of around 500 plus. At the outset, let me congratulate the Department of Surgery, Dr. Ramesh Lal and his team in particular, when he is being, advised by senior people like Dr. Pathania and Dr. Thomas, and enthusiast, active people like Dr. Gyan Saurabh, and many others, Dr. Ashok, Dr. Andley, so many others. So whenever there is a desire and whenever there is an intuitions that you should have a backup net, you are very right in saying so, because today network is creating a problems because of the rain, unexpected rain, and the weather problems. I am very happy that Department of Surgery has gone many miles ahead as per the expectations. As you said, that you are always in demand, not only for the postgraduates, but for the junior faculty and also the candidates who have enrolled for the DNB. I am sure that this 4 days academic bonanza is going to make delegates better prepared to appear in the exam and coming out with colors. not only that, the department will attract them for the senior residency and for the junior faculty, and many others like pool officers or the project or the research activity. So this type of activity is always welcome, and I'm sure that all the faculty are going to do just with the topics and will keep the delegates engaged, because this teaching and learning goes hand in hand, and the faculty or the students who have adopted or who have taken medical field, particularly the surgical one, they are dedicated and committed one. They are going to be lifelong learner, because every day there is some advancement as far as the technology is concerned, as far as the equipment is concerned, as far as the patient related problem is concerned. And I am sure that they are going to be more wise, more equipped with, and more satisfied after the 4 days of academic feast, which you are going to offer to them. With these words, and I again congratulate the Department of Surgery, the all eminent and august faculty in the department, their leadership, their teamwork, their postgraduates, their senior residents, their other team members of the department. And I will like that you will continue hosting these type of academic activity in the future also. Will now like to go in the offline mode, and you will see the coming up new constructed infrastructure to be used like anything to make this department and the environment of the college a vibrant environment, a happening environment, and full of academic activities. Thank you very much. With these words, Dr. Ramesh Lal, back to you.
Thank you so much, sir, for the encouraging words and boosting our morale. And with this, I'll request you to kindly declare the update open.
Okay. In the last, as formally I am being asked by Dr. Gyan Saurabh, I declare this fourth postgraduate surgical update open.
Thank you so much, sir.
Thank you, sir.
Thank you, sir. With this, we come to an end of the inauguration ceremony.
I will like now, let us have a virtual cup of tea.
Yes, sir. Thank you, sir. Thank you so much, sir.
I think, Gyan, you can start the further proceedings.
Yes, sir.
Doctor, the director, sir, can stay on with us and participate in the deliberations. And I think we must thank him for his encouraging words and the bright future he is showing us by offering us the new building as soon as possible. Thank you, sir.
Thank you. Thank you so much, sir. So with this, we come to an end of the inauguration ceremony, and we'll begin with the next session, which is going to be the case presentation. And for this session, we have as a moderator, Dr. Ashok Kumar, who is Director Professor of Surgery at Lady Hardinge Medical College. As a chairperson, we have Dr. Beena Ravi. She is Professor at Sharda University, Noida. We have Dr. Ramanuj Mukherjee, Professor of Surgery at R.G. Kar Institute, Kolkata. Dr. Rajdeep Singh, Professor from Maulana Azad Medical College, Delhi. Dr. Sanjeev Singhal, Consultant and Head, NCRH, Delhi. Dr. Kamal Kataria, Additional Professor Surgery, AIMS, Delhi. Dr. Priya Hazra, Professor Surgery, Lady Hardinge Medical College, Delhi. And Dr. Shadan Ali, Professor of Surgery from Lady Hardinge Medical College, Delhi. Now I hand over the stage to our moderator, Dr. Ashok Kumar, sir. Please, sir.
Thank you, Dr. Gyan. Can you hear me?
Yes, sir. You are audible and visible. You're looking very handsome.
Okay, thank you very much. On behalf of Department of Surgery, LHMC, I welcome all the chairpersons and the delegates to the session 2 of LHMC Surgical Update. In this session, we have 3 cases to be discussed, followed by 2 lectures of operative surgery related to the cases itself. So I welcome all the chairpersons again, and I ask the first presenter, who is Dr. Tanuj Singla, Tanuj, welcome. And I request you to go through all the slides completely till the end of diagnosis. And at the end, I will ask the chairpersons to go one by one to ask you questions. And the questions may be either from the history or from the examination or the any discussions. But it will always be better if the chairperson first start up with the history and then the clinical examination in the second round and then subsequently. But they are free to ask you question from any segments of your presentation. So can you start now?
Yes, sir. My screen is visible, sir?
Yeah, sure. Yeah, continue.
Yes. Shall I start, sir?
Sure.
Good evening, everyone. Today I'm presenting a case on neck swelling. My patient is 38 years old female, resident of Vikas Nagar, Dehradun, daily wage worker by occupation. She presented with the chief complaints of swelling in anterior part of neck for the 4 years and heat intolerance for the past 4 years. History of present illness. Patient was apparently well 4 years back when she noticed swelling in anterior part of the neck, which was initially small, like 2 cross 2 centimeter approximately, and has gradually progressed to attain its present size. There is no history of pain or sudden increase in the size of the swelling. Swelling is associated with tremors in the hand, inability to sleep. Patient is having weight loss despite of good appetite. She is giving history of irritability, intolerance to hot environment, increased stool frequency, and oligomenorrhea. There is no history of change in voice, difficulty in breathing, and difficulty in swallowing. No history of palpation, syncopal attacks, or dyspnea on exertion. There is no history of visual disturbance or any other swelling in the neck. No history of bony pain or hemoptysis. Past history. Patient has no history of any radiation exposure, no history of any drug intake for the long term. Patient is not a known case of diabetes mellitus, hypertension, tuberculosis, or asthma. There is no history of any previous surgery or known drug allergies. Personal history. Patient is giving history of inability to sleep for the 4 years, and there is increased history of stool frequency. There is no history of any drug addiction. Family history. No history of similar swelling in the family. No history of any malignancy in any of the family members. Menstrual history. Patient is giving history of oligomenorrhea. Approximately 1 pad is getting soaked per day. Her cycle is prolonged for the 35 days and it usually lasts for 2 to 3 days. Patient is mother of 2 children born by normal vaginal delivery. Both are healthy at present. For the summary of history, 38-year-old lady with the history of swelling in anterior part of neck with the thyrotoxic features. Moving on to examination, patient was examined in a well-lit room in the presence of a female chaperone. Patient is conscious, oriented to time, place, and person. Patient appears anxious and restless on the general appearance with average built and nourishment. Patient's BMI is 19.8 kilogram per meter square. Right. Patient is afebrile, 98.8 degree Fahrenheit. Pulse rate is 94 per minute in the right radial artery with regular rhythm and good volume. Respiratory rate is 16 cycles per minute. Her blood pressure is 104/68 in right arm supine position. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. No pretibial myxedema. Patient's palmar aspect of the hand were warm and moist. Fine tremors could be elicited in both the hands. On examination, neck examination, swelling of approximately 12 cross 8 centimeter situated in anterior part of the neck with smooth surface, well-defined margins with visible lower border of the swelling. Swelling was extending superiorly from the thyroid cartilage to 1 centimeter above the sternal notch inferiorly and extending bilaterally till the sternocleidomastoid muscle. Swelling is moving up with deglutition and does not moving up with the protrusion of tongue. Skin over the swelling has tattoo marks, no distended neck veins, no other visible swelling in the neck. Patient's Pemberton sign was negative. On palpation, there is no tenderness or local rise in temperature. Patient had inspectory findings were confirmed on palpation with well-defined swelling of approximately 13 cross 10 centimeter anterior neck with smooth surface, firm in consistency, extending superiorly from upper border of thyroid cartilage till 1 centimeter above the sternal notch inferiorly. Swelling is moving up with deglutition, which was confirmed while palpation. Lower border of swelling is palpable 1 centimeter above the sternal notch. Bilateral carotid pulsations are palpable. Trachea appears to be central. No other palpable swelling in the neck. Cervical spine and nape of the neck are normal. Oral cavity, no lesions or no significant findings. Percussion, resonant note over the sternum was noted. On auscultation, no bruit heard over the swelling. For the eye part, eye signs, exophthalmos was noted. Lid retraction and lid lag were present. Stilwell, Joffre and Mobius signs were positive. This is a video demonstration how to examine for the eye signs. Here I am doing the lid lag sign first. We usually tell the patient to first look at relax the accommodation to look at the farther point and then follow our finger as we move it from top to up to down. And then while movement with the finger, we can see the upper eyelid will lag behind the movement of the eye globe. And then to look for the exophthalmos, we usually initially look from the front. If the sclera is visible all around the limbus, then we usually take it as exophthalmos is present. Then we can look it from the side of the patient at the level of the eye to look if there is any protrusion of the eyeball. And then to elicit the Neff-Zigger sign, we usually go behind the patient and then with neck in extension position, we look for the if the eye is protruding out from the superior orbital ridge. And then here I am doing to check for the ophthalmoplegia, the H test to look for the note the movement of all the extraocular muscles, to check the movement in all the gauges. And then now I will be going to do the convergence test. For this, patient has to look behind. I will tell the patient to look behind my wall to relax the accommodation and then bring the finger from the side in front of the patient to check for the convergence. Moving on to systemic examination. Patient's CNS examination, all the cranial higher mental functions were intact. Cranial nerves were intact. Deep tendon reflexes, patient had brisk knee jerk. Power and tone were normal. Respiratory system, bilateral air entry equal. For central cardiovascular system, S1, S2 was heard and there was no additional murmur. For the summary of history and examination, 38-year-old lady with diffuse goiter since 4 years with thyrotoxicosis and eye signs. And my provisional diagnosis will be diffuse toxic goiter with ophthalmopathy, likely to be Graves' disease.
Thank you, Dr. Tanuj. Now, this presentation is open for discussion. May I request Dr. Beena Rabi? Ma'am, Dr. Beena Rabi is there? Dr. Beena Rabi, ma'am, is there?
No, Dr. Ashok, she has not joined. She will be joining shortly.
Okay, Dr. Ramanus is there?
Hi, very good evening, sir. Am I audible?
Yeah, sure. So, Dr. Absolutely. You can ask the questions either from the history.
Okay. To begin with, it was a good presentation, but a few comments on the clinical methods and the way you described this one. To begin with, Doctor, can you go back to the picture? Can you go back to the history slide in which you commented upon the histories that regard the function of the thyroid.
Yes, sir.
Yes, absolutely right. So you have said that this lady noticed a swelling in the neck. Now tell me, what are the points in the history after you have made a final diagnosis that point that this lady may be suffering from a thyroid disease?
Sir, first is the swelling is in the front of the neck. It is in the thyroid region.
Sir, kindly, Dr. Sir, understand the question. What are the points in the history that make you feel? I am not asking you. What are the points on your examination, sir? Okay. So please listen to the question, understand, and right. Please.
On history, sir, patient is giving history of hyperthyroidism features, sir.
Saurabh, please mute yourself.
Right. What are the points that are in favor that the patient has a history of hyperthyroidism?
Sir, there are tremors in the hand. Patient is complaining of inability to sleep. And there is weight loss despite of good appetite, which is usually seen in hyperthyroidism. And patient is also giving history of intolerance to hot environment, sir.
Okay. So we always try to mention the most specific symptom that suggests a disease, then go to other ones like tremors or loss of sleep in the night, which are less specific ones. Okay. Now,
yes,
when you come to the history in a lady, what are the other histories regarding gynecological problems that you should be asking?
In thyroid swellings, patient is usually having amenorrhea or oligomenorrhea, sir.
Okay, number one. Number two, how many children does this lady have?
She has 2 children, sir.
Okay, is it at all relevant in this disease or in this case?
Yes, sir. If a female is young, then she can present with infertility, sir. Due to hypothyroidism, there is associated infertility sometimes.
Okay, that's a good one, sir. But this lady is married, and maybe that she will be taking some contraceptive pills.
Yes,
so now I will give you a hint on this one. So now please tell me, what is the effect of, or what is the relation of taking a contraceptive pill in treatment of this disease?
Sir, hyperthyroidism, there will be increased metabolism rate, which can lead to early clearance of the oral contraceptive pills, which can lead to contraception failure, sir.
Very nice. So that means this is a part of the history that is usually not discussed very frequently. But in younger patients, ladies, particularly in the fertility age group, this is the history that you should be asking, not only about menstrual disturbances, but also about fertility problems, particularly oral contraceptives and their drug interactions, their clearance, etc., which may be with 2 of the problems. Okay. The next one is that if you go to the point on clinical examination, the first picture that you showed.
Yes.
Right. Okay, doctor, just one little point to modify. Can you go back to the last slide, please? Yeah. No, not the, yeah, after the summary, please. Not the provisional diagnosis, something that is called as general examination, or a slide named like that, isn't it? Right. It is not called general physical examination, sir. Okay. It is called as a general survey. So examiners will be a little more specific on this point, and then they will ask about something called general examination. Okay. You have said anxious and restless, etc. Examiners will be asking for faces. Sorry. Does this lady have any particular faces that you want to describe?
Yes, sir. Patient usually have that staring look. The patient with toxic features usually have a staring look, sir.
Okay. Did this patient have that? Because the video that you showed did not exactly look like that one.
Sir, actually, video I did with one of my co-PGs, sir, to illustrate the science.
Right. So
dummy patient, I think.
Okay. So this is the point I was saying, that how could a lady become okay, right. So my mistake. Right. Okay. Now you have mentioned the BMI, that's pretty nice. What is the blood pressure in this patient?
Sir, 104/68 millimeters of mercury.
104/68. So do you think it is very normal blood pressure in this patient to have this? Or should I be measuring the blood pressure in the left arm also? Or should the blood pressure, or do I find an abnormality in the blood pressure? Or do you expect a change in blood pressure in a patient with a thyrotoxicosis?
Patient can have hypertension in some cases, sir, but
Sir, there can be increase in the stroke volumes. That means the systolic component will be more. Due to the peripheral vasodilatation, the diastolic component will be less. So that will mean that the pulse pressure is widened. Okay?
Widened, yes.
Right. What is the character of the pulse that you usually get?
Sir, pulse, sometimes patient can have a collapsing pulse with wide pulse pressure, sir.
Right. Which was not good. And the last question, I think that there are other examiners who are also waiting. So can you go to the next picture, the picture of the neck of the lady? Right. Doctors, what is this mark on the neck?
Sir, these are tattoo marks, sir. She got it done because somebody told her that this will get resolved, the swelling.
No issues, because we also get a lot of patients with alternative medicine being tried. This is a very, very interesting picture on this one.
Okay,
Doctor. Right. So please, thank you.
Dr. Asdeep?
Yes, thank you, sir. Dr. Tanuj presented well. So one of the presenting complaint was heat intolerance.
Yes, sir.
So what did the patient actually say? कि गर्मी में गर्मी लगती है?
That's a very pertinent question because it was the chief complaint. So I didn't describe anything about it subsequently. So Rajdeep pointed it out and you have to answer it because it comes in the chief complaints.
Yes, sir.
What did you ask?
Sir, I asked as a part of history, sir, during the swelling that if she feels like if she feels too hot in the surrounding environment relative to other.
Relative to what? See, firstly, if you have asked for the history, then it's not a presenting complaint. It's not a chief complaint with which the patient has come. And secondly, quantifying or anybody coming and saying that they have heat tolerance is very, very difficult to say.
Yes.
Firstly, the patient themselves will not be aware that they have heat intolerance. उनको तो गर्मी लग रही है. They don't know कि बाकियों को कम लग रही है. So it is only in relation to somebody else. Somebody else has pointed out the other persons in the room or in that area are not are wearing sweaters, and she does not feel the need to wear sweaters. So in this photograph, I see that she is wearing a sweater here. So those are various points which you have to think about, right? And when did this heat intolerance start?
Sir, she said when she noticed the swelling, then she relaxed.
Since 4 years.
Yes, sir.
That's a bit strange. But anyway, you mentioned about the size that initially it was started at 2 by 2 centimeter to reach the present size. But in the history, you forgot to mention what the present size is. Approximately, I'm not talking about the exact size. So you said it started at 2 centimeter and to reach the current size. I did not know at that point that what size you are talking about. You also mentioned inability to sleep since 4 years. So she has not slept for 4 years.
Oh, sir. So she finds difficulties, sir, like.
Yeah, difficulty. So there are two types, either onset of sleep or maintenance of sleep, or she wakes up repeatedly during the night. So these are the points. This inability to sleep, just saying that there's not having able to sleep for since 4 years doesn't make sense.
Yes.
So there has to be something there. So, okay, so rest of the points you had covered, including about arrhythmias, syncope and dizziness. Eye signs you mentioned. You mentioned the trachea central. Where did you check for the trachea in this patient?
Sir, in the sternal notch, sir, below the swelling.
You could feel the trachea there in that small area.
Yes, sir. Sir, when when the swelling moves up with deglutition, that time I could feel.
Okay, so we'll take your word for it. And right, eye examination, you had mentioned that it was fine. Your diagnosis is a diffuse goiter Graves' disease. That's your diagnosis, no?
Yes, sir. Yes.
I give you a second situation that it is multinodular goiter with secondary hyperthyroidism.
Dr. Rajdeep, let us go to some other.
Right, yes, sir. Please, definitely.
Is there? Dr. Sanjeev?
Hello, good evening, everyone. Lot of points have been covered. I just wanted to draw attention to a few points. You said the BMI is 19.8.
Yes.
Whereas in the history, you say the patient is having weight loss.
Yes.
Do you think you need to rethink in the light of the BMI, a significant weight loss
lead to BMI less than
should go down. So
yes,
are you
sir.
sure about the
17 or 18? Yes.
So are you sure that there is a history of weight loss? How did you come to that history, especially with a good appetite?
Sir, actually, she told sir she is having a loosening of clothes, sir. She has not measured exactly, but she was telling her blouse is getting loose.
Okay, you mean
I'll pass on. I'm not going to stop here. All I mean to say is that when you get a BMI of 19.8, then when you are giving a history of weight loss, be careful. Second thing I wanted to ask you is, number one, what is Pemberton's test? Why is it done and why was it done here?
Sir, Pemberton test is usually done to look for the retrosternal extension of the thyroid swelling, sir. In this, we tell the patient to raise her arms above the head and until they are touching the ears, and then we can look for the congestion of the face and if she is having any respiratory difficulties.
So in a patient where you find a very clear more than 1 centimeter margin from the sternal notch, why was it done?
Sir, actually, it is not required in this patient, sir.
Not in this case, what is an absolute contraindication to Pemberton's test?
I'm not aware, sir.
Okay, see, what does Pemberton's test tell you? It tells you that there is
obstruction
it is a thoracic inlet obstruction.
Yes, sir.
Then it is a second corollary that it might be due to thyroid. It might be due to anything. So if there is already any evidence of thoracic inlet obstruction, so this test actually makes a latent obstruction obvious.
Yes, sir.
So if you already have evidence of obstruction in the form of raised JVP or congestion, then do not do it. Patient might even collapse.
Okay. So, okay. Thank you, Dr. Sanjeev Zinkla. Dr. Kamal is there? Dr. Kamal? Dr. Kamal Kajaria? It's not there. Dr. Priya? Dr. Priya is also not there.
I'm there, sir.
Dr. Priya is there, yes.
Do you have any?
You said in history that there is no dyspnea. Can you say what type of dyspnea you can expect, particularly in thyroid disorders?
Ma'am, it is usually dyspnea on exertion, like when she has to work more than her routine activities, then she can suffer from dyspnea.
Dyspnea on exertion is more for a cardiac cause, or if a thyrotoxicosis is causing a cardiac problem, then there's a dyspnea on exertion.
Yes, yes.
The mass, the goiter itself, what sort of dyspnea does it cause?
It can cause due to tracheal compression, ma'am, difficulty in breathing.
So yes, so what it is, either mainly orthopnea and positional dyspnea, which is described, because the weight of the thyroid falls onto the trachea while lying down or in certain particular positions. So that is what it is described more, rather than exertional. Exertional will be a cardiac cause.
Cardiac cause.
Other issue is, you said there are no visual changes. What visual disturbance did you ask for?
Ma'am, sometimes patient can have diplopia and there is difficulty in looking at the outward, like lateral gaze, my difficulty is there to see the object.
So they can be diplopia, they can be dyschromatopsia, photopsia. What are they? Do you know? Changes in color vision and flashes and visual field defects. This can occur in.
Okay, Dr. Priya. Now, Shadan. Dr. Shadan is there. Dr. Shadan.
Yes, sir. I am here, sir. Okay. Okay, Dr. Tanuj, good presentation. Did you take the history of drug intake or drug allergy in this patient?
Yes, sir.
So Arnott, she was advised any drug in the last 4 years. This is still having sleep disturbance. She is not on any medication.
Sir, she has taken some drugs, but she has not any drugs with her to see like what she was taking.
Suppose the patient is having a disturbance in sleep, she get woke up in the night. What could be the possible other causes?
Sir, other causes can be she is having any difficulty in breathing, like if she is having sleep apnea, and then there can be cardiac issues, like if she is having chest pain or anxiety.
Okay, so you should rule out OSA also. Let another causes of sleep disturbance in spite of medication if the patient continue to have the symptoms. Come to the eye signs. Can you go to that slide?
Yes, sir.
In all those signs, can you tell me what are the signs that you get in specific types of toxicosis, a specific disease that we commonly have?
Yes, sir. This lid retraction and lid lag can happen in any of the thyrotoxicosis, sir. But the exophthalmos and staring look and Mobius sign is usually specific for the Graves' disease, sir.
So,
which are due to the deposition of.
Dr. Tanuj, you mentioned exophthalmos Mobius sign, isn't it? Out of these signs, which one is specific to Graves' disease? Which sign is specific to Graves' disease? Rest of the non-specific signs.
Yes, sir.
First is the exophthalmos and Mobius sign, isn't it?
Yes, sir. Exophthalmos and
Mobius. And you said the last point was no ophthalmoplegia. At the same time, you say Mobius sign is positive. How can it happen? Mobius sign is positive. There is difficulty in convergence of the eyes. At the same time, there is no ophthalmoplegia. This can't happen, isn't it?
Yes.
And exophthalmos without any eye symptoms are very rare.
Yes.
So that's also a point of concern. In the second round, we will. Dr. Beena Ravi has he joined?
Sir, we can't see her yet.
Okay, fine. So there's the history and examination part. So in the second round, we will manage the case. And before that, I want to point some lacunas in the history. First, the swelling is the anterior part of the neck. This is not the way to describe the thyroid cell. It should be the front of the neck rather than the anterior part of the neck, right? So when you are facing you get this sort of case in the exam, you say swelling in front of the neck. That will be the better term because the anterior part is quite a big. And Dr. Rasdeep has already said heat intolerance. So you have to be careful about when you have mentioned it in the presenting complaint. So you have to. And one thing more, you said there is no history of diabetes, mellitus, and hypertension. Hypertension is a part of thyrotoxicosis. So that's why a question was asked by Dr. Ramanus. But do you think diabetes mellitus is somehow related to Graves' disease?
Sir, sometimes type 1 diabetes mellitus can be associated with Graves because of autoimmune.
Yeah. So it's a part of the autoimmune process. So diabetes mellitus type 1 is related to, and it has been seen that these patients who have already diabetes before it was diagnosed are found to be resistant to insulin. So they need to have a higher dose of insulin, and their HbA1c is rate. So let us start the second round for diagnosis and management. Dr. Ramanu is there?
Yeah. Hi, sir. Very good evening. Right. Sir, before we go to the second round, just one comment on the clinical method. Can you go to the lid retraction and the lid lag sign, please? The video that you are showing. You see the technical point, Dr. Sir, is hello. Am I audible?
Yeah, Dr. Ramanu, we have because we have left with only 10 or 15 minutes.
Just one small comment. Is that whenever you see this sign, please use your other hand to fix the head of the patient. Your colleague is not to look up, but in a real world, patients will be looking up. Okay. Now coming to the management of this case, what is the sequence? First, what is the sequence of investigations that you would like to do in this patient? Sequence of investigations.
Sir, first I would like to go for biochemical investigations, that is thyroid, TSH, T3 and T4, sir.
Next one.
Next, I would like to go for USG.
The TSH in this patient, the TSH in this patient is low than normal levels.
Yes,
then
sir.
what is the next investigation that you do?
Sir, if the TSH is low, then we can go for the thyroid scan to look for the uptake of the gland.
Okay. Will you like to do an ultrasound of the neck also? Or
Yes,
is the thyroid enough for this patient?
No, sir. USG neck should be done, sir, to look for if there is any nodularity or suspicious nodule in the patient.
Is it mandatory to do a radioiodine scan, or is an ultrasound of the neck sufficient enough?
Sir, in diffuse swelling, it is not necessary to do the radioisotope scan, sir. USG will be sufficient in this case, sir.
Tanuj, will you do or not do? Is your diagnosis?
In this patient, I will not do, sir.
So you will not do. Okay. A point well taken. Now tell me, if you have done an ultrasound, how are you going to distinguish between a multinodular goiter or a toxic multinodular goiter with a Graves' disease on an ultrasound?
So, sir, on in diffuse goiter, there will be no nodules on the.
No, sir. You did not get my question. My question is: one side of patient is a Graves' disease. Now it is called as a diffuse toxic goiter. Another side of the disease is a patient with a toxic multinodular goiter. So, how will you distinguish between them?
Sir, toxic multinodular goiter, there is usually long-standing history of the goiter.
Sir, I have asked on ultrasound. Okay. This is the reason. It is ultrasound is a complementary investigation. If you go through the ATA guidelines, American Thyroid Association guidelines, low TSH should have a radioiodine scan to know the type of the uptake, which determines everything. The last question is, apart from the toxic multinodular goiter and a grave, what is your nearest differential diagnosis in this patient, in this age group, in a female? This is the last question from my end.
Sir, I would like to keep a diagnosis of.
Any other? Yes, sir.
Sir, if there is acute phase of thyroiditis, sir.
Very good. What type of thyroiditis?
Sir, autoimmune thyroiditis.
What type of autoimmune thyroiditis? So you see, one answer is taking
Hashimoto thyroid.
Right. So come on, man. So tell that, sir, it is maybe an acute phase of a Hashimoto thyroid. Okay. Please.
The sound is a must, right? It must be done. This and followed by you didn't mention about the tumor. I mean antibodies. Yeah.
Yes, sir. Antibodies.
So in Graves' disease, you have to get the antibodies done. This is because it's indirect. It will give you the indirect a scan. Yes, you can avoid a scan. You can't get the scan, then it will do. But you have to get. You have to substantiate whatever you are saying on the ultrasound by the radio, by the antibodies. So next is Rajdeep. Dr. Rajdeep is there?
Yes, sir, I am here, sir. Very much here.
Rajdeep, it's you.
So in the investigations, you talked about the ultrasound. But still, I would like to go back to your clinical diagnosis and your diagnosis. Why do you say it is a diffuse goiter and not some other form of goiter?
Sir, actually, I could not feel any nodules during the palpation, sir. Otherwise, it can be a possibility of toxic nodules.
Okay, so I'll go to what is the natural history of Graves' disease.
Sir, natural history of?
Graves' disease. So diagnosis is Graves now.
Yes, sir. Sir, natural history.
Natural history means if you leave it as such, what will happen?
Then, sir, it can progress further, sir, with the exacerbation of ophthalmopathy and leading to ophthalmoplegia.
So this is an autoimmune condition. Normally it peaks fast. Graves' disease peaks fast within a year or so. Then it plateaus, then it subsides.
Yes,
and it burns out
static phase
ultimately.
comes after 1 and 2 years.
Exactly. And now this has been 4 years since the patient is having symptoms.
Yes.
So that point for Graves' disease to progress for over 4 years is a bit not in the normal course of things. Either the patient has developed hyperthyroidism later on. So the patient had some other cause of goiter, which most commonly in India is the multinodular goiter. And later on, the patient has developed hyperthyroidism, secondary hyperthyroidism. Or like sir said, it may be thyroiditis, which is again a recent onset thyroiditis, rather than it being a Graves' disease. Just one comment on the examination, etc. Your entire examination and presentation is fitting very well into a case of hyperthyroidism. In reality, it usually does not happen. You are lucky to get such a case. Otherwise, you would always have that some eye signs are present, some are absent, some features are present, some are absent. Everything was fitting exactly what you found. Yet pulse rate was high, sleep disturbance was there, heat intolerance was there, eye signs were there. Usually, you will not get such a patient in real life.
Dr. Sanjeev Singla?
Yes. So let us proceed further. I think most of the points in here have been covered, and the basic investigations and the importance of antibodies is extremely relevant both for Graves' disease and for thyroiditis. So how will you go further now? Let's go further. What will you do next?
Sir, for the management part, I will start with the anti-thyroid drugs, sir.
Okay, so you want to offer the patient medical management for thyroid. Why medical? Why not surgical?
Sir, surgery we can plan after discussion with the patient, but initially we have to give medical treatment to make the patient euthyroid, sir.
Is that so?
Yes, sir.
Is it a mandatory requirement that a patient has to be made euthyroid by anti-thyroid drugs before taking up for surgery?
Sir, if we are planning to plan for emergency surgery, then we can do it with beta blocker, but usually we do anti-thyroid drugs to make the patient euthyroid and then take up for surgery, sir.
Dr. Tanuj, what he wants to ask you, there are 3 modalities of treatment. The first is drug that is radioactive. What have you planned in this case? Is it the anti-thyroid drug only, or you want to give the anti-thyroid only to prepare the patient for surgery, or surgery is going to be the primary treatment mode of treatment, or a radioiodine?
Sir, I will give...
You have put it very nicely well. Thank you.
Sir, I will make the patient euthyroid first with anti-thyroid drugs, and then I will counsel the patient about surgery. If she is willing, then I will make the decision of surgery in this patient.
Okay. So, what are the problems or in surgery when you make the patient euthyroid by anti-thyroid drugs? What problems can you anticipate during surgery which have arisen because of the use of anti-thyroid drugs? I am asking you a reverse question. Normally, people will ask you what will happen if you don't prepare the patient. I will come to that later. Now, I am asking you, you have made the patient euthyroid. You have made the patient euthyroid. Does that make the surgery easier or difficult?
Sir, it prevents thyrotoxic storm, sir.
Yes, very right. That is the advantage. Now I'm asking you, what are the drawbacks? Are there any drawbacks?
I'm not.
What will happen when you give anti-thyroid drugs to TSH?
TSH will increase, sir, in this situation.
So when the TSH increases, what happens to the vascularity of the gland?
Vascularity will increase.
The vascularity will increase. So that is one area you have to take care. Now coming to thyroid storm, if you have operated a patient, say emergent case, and the patient is, how will you identify thyroid storm? What will you do?
Sir, patient will have tachycardia and high-grade fever, and patient will have patient can have arrhythmias as well as dehydration also. And I will manage the patient initially with IV fluids, and we can give propranolol to block the sympathetic system, as well as conversion of the T4 to block the conversion from T4 to T3.
Very good.
And And propylthiouracil is also given in acute episodes, sir, as well as steroids to suppress the thyroid release and symptoms.
Any role of IV iodine? And if you have to give IV iodine, how will you procure it?
I'm not.
Okay. So to choke the gland, IV iodine is a very ideal solution thing and very easy to procure. Your radiologist friends are using iodinated contrast left, right, and center.
Yes, sir.
Very easy thing to have, very cheap, and immediately available if you just think about it.
Thank you, sir. Thank you, Dr. Kamal. Now you have the option. Now you said that you will prepare the patient for operation. Is that the primary model? So you have already said how to prepare. So you have to give the antithyroid drug. You have to give propranolol. You have to do what the sir was telling, Dr. Singla was telling, Dr. Kataria was telling, that you have to give the iodine in the form of Lugol's iodine, right? So that's how, and propranolol as well. So that's 4 drugs which you need to give before you take up the patient. The idea is to make the thyroid euthyroid so that you avoid the complications intraoperative and postoperative. Right. Now, what surgery will you like to do in this case?
Sir, I would like to go for total thyroidectomy.
Total thyroidectomy. Why do you want to do? Why not any other surgeries you know about? Which
Yes,
kind
sir.
of?
Near total thyroidectomy or subtotal thyroidectomy is also used.
What is Dunhill procedure?
Sir, Dunhill procedure is a type of subtotal thyroidectomy, sir. When we remove one lobe and isthmus and the second lobe, some part of the lobe is left, sir. That is done.
One part completely and
other part, some part is left. Sir.
You left. Dr. Priya, you have any questions?
Why did you choose surgery over radioiodine therapy in this patient?
Ma'am, she is a middle-aged female, ma'am. Radioiodine therapy we usually use in older patients, sir, ma'am, because they are more likely to go hypothyroid after that, which will require the supplementation as well.
Anyway, all the patients are going to be hypothyroid.
Yes, sir.
Then your idea is to make the patient either euthyroid or the hypothyroid, isn't it?
Euthyroid, sir.
Then how can you calculate that? You can't calculate the dose. You can calculate, but there is no any formula as of now that can calculate the exact dose the patient needs of a radioiodine. Because most of the time, if you give the radioiodine, the patient is going to be the hypothyroid sooner or later,
yes.
Right? So, what are the methods of giving the radioiodine?
Sir, radioiodine we usually give orally, sir.
No. What are the different methods? It's 2 methods. The one is fixed dose method, and the second is calculated dose method. There is no absolute formula for calculated dose where you exactly calculate the dose of radioiodine. That's why we still feel that we give a fixed dose iodine of 10 millicurie to 20.
8 to 12 millicuries.
That anything between the two, depending on the stature of the patient. So radioiodine has got its own complication area. Of course, in India, it's very difficult to procure it. But what are the complications of radioiodine?
Sir, radioiodine therapy can lead to swelling in the neck and the salivary glands, tender gland, as well as it can lead to infertility in some patients.
And because the patient, your patient is having the Graves' ophthalmopathy, so there are chances of
exacerbation of
and radiation thyroiditis is another other things. So anyway, radiation thyroiditis leads to hyperthyroidism and sort of a thyroid storm. So this finishes your case. One last question from Dr. Shadan.
Thank you, sir. Thank you. Since he has answered well, so I would like to ask few tricky questions. When any indication of doing FNAC based on the finding in your previous all other investigation?
Sir, if we have any suspicious nodule in the USG, then we can go for
yes.
it.
Any and if you get a cold nodule on your thyroid scan, and when you do a Dunhill procedure in current situation, and what is the aim of it? So if you are operating a patient for total thyroidectomy, on one side you are not sure that whether, and you could not visualize the parathyroid gland, and your dissection was not clean. So to save the parathyroid, the other side would like to do a near total, a part of cuff is left so that to prevent the injury to parathyroid.
Dr. Sadan asked you a very pertinent question. Suppose you got the ultrasound done and you find some suspicious nodule there in the thyroid, then that suspicious nodule needs to be biopsied, even if it's hyperthyroid. So don't be afraid of thyroidism because you are targeting the place where the nodule is cold, probably. And what's the percentage of hot nodule to be malignant?
Sir, it is around 5 to 10%.
It's less than 1%. Anyway, thank you, Dr. Tanu. With this, we wind up showcase, and the next presenter is Dr. Kainat.
Good presentation.
Yeah, good. Dr. Kainat.
Good evening, sir.
Civilly presenting a case of solitary thyroid nodule. Thank you very much. Now you can start.
Good evening, Dr. Kainat.
Good evening.
Start, Dr. Kainat.
So is my screen visible?
Yeah, but it has not started as it.
Good evening, everyone. I'll be presenting a case of anterior neck swelling. My patient, Mrs. A, a 57-year-old lady, homemaker, resident of Delhi, came with complaints of swelling in the front of the neck for past 3 years with rapid increase in the size for 6 months. History of presenting illness. My patient was apparently well 3 years back when she noticed a swelling in the front of the neck. Swelling was...
Dr. Kainat, please do the slide sharing.
Yeah.
Please do the slide sharing.
Sir, I've shared.
Yeah, I can.
Slideshow.
Slideshow karo usko.
Slideshow.
Full screen. Make it full screen.
राइट साइड में नीचे देखो कप जैसा बना होगा उसको
So slideshow.
You can do one thing, stop sharing and share it again to your slideshow view. Share it again on your slideshow view.
वही क्या होता?
अब कुछ हो रहा है? पूछो.
सर वो भी स्टॉप किया हुआ है.
क्या चीज? वो किया तो था अभी शेयर करो. अभी स्कोर ये कर दो.
ये क्या
करो अभी करो. अब पूछो.
So is it visible now?
Visible, but it's not the slideshow mode.
क्या बोल रहे?
अभी मैं करिए slideshow में.
नहीं हो रहा.
Can you go to the presentation again, doctor?
Grant permission कर दो.
Can you again start sharing a screen?
मेरे उनके पास जो दिया हुआ है उसे.
Can you accept my request, please? Sharing request. ठीक है.
So is it visible now?
No, doctor, it is not visible yet.
Option slide entire screen.
Dr. Saurabh, why can't you ask Ashish to demonstrate this presentation?
Doctor, can you go to that up the panel above on that the top panel? Can you go on the top panel, please? You have home in, yeah, absolutely right.
So is it visible now?
Yes, very much.
Visible. Please start presenting the case.
Yes, sir. So my patient was apparently well 3 years back when she noticed a swelling in the front of the neck. Swelling was insidious in onset, was present in the front of the neck, was painless, was initially of a size of 2 x 2 centimeter and has rapidly increased over the past 6 months to reach a size of 6 x 6 centimeter. There's no history of difficulty in breathing or swallowing. There's no history of any change in the voice. No history of any other swelling in the neck. There is no history of radiation exposure to head, neck, or chest region. There are no symptoms suggestive of hyper or hypothyroidism, and there is no history suggestive of distant metastasis. Past history, my patient has no other comorbid conditions. There is no history of any surgery in the past. Personal history, my patient takes a mixed diet. Her sleep and appetite are normal. Bladder and bowel habits are normal. Menstrual history, patient is postmenopausal 6 years back. She attained menarche at 15 years, had regular cycles and average losses. Patient has was para 2, living 2, all normal vaginal delivery, and there is no history of any abortions. Family history, there is no history of any goitrous enlargement, head and neck malignancies, or men-associated disease in the family. Summarizing my history, a 57-year-old lady, resident of Delhi, presented with painless swelling in front of the neck for 3 years, rapidly increasing the size over past 6 months to reach a size of 6 × 6 centimeter, with no pressure symptoms and is clinically euthyroid. On examination, patient was examined in a well-lit room after informed consent for examination and photography. Patient was sitting calmly with normal facial expressions and palms were not moist. Patient was examined in sitting position with adequate exposure till chest. Patient was conscious, oriented to time, place, and person with a performance status of ECOG 1 and was averagely built and well nourished with a BMI of 24. The pulse was 86 beats per minute with a regular rhythm, good volume, no radial delay or no radiofemoral delay, with a blood pressure of 130 by 76 millimeters of mercury in the right brachial artery in the sitting position. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pretibial mixed edema or pedal edema. There were no tremors or eye signs in my patient. In head and neck examination, a solitary swelling present in the region of the thyroid on the right side and the center of the neck of a size 6 × 6 centimeter, globular in shape, with a smooth surface and well-defined margins, extending superiorly up till the thyroid cartilage, inferiorly till the suprasternal notch, medially till 2 centimeter left of midline, and laterally till the anterior border of the right sternocleidomastoid muscle. The swelling is moving with deglutition. The inferior margin is clearly visualized when the swelling is moving with deglutition. Skin over the swelling is normal. There are no sinuses or scar marks, no engorged veins over the upper neck or chest. Trachea is central. Trail sign is negative. There are no other visible swellings in the neck. There are no eye signs. Ear, nose, and oral cavity, scalp, and cervical spine inspection was normal. This is the swelling. In this video, the swelling can be seen moving with deglutition. On palpation, the findings of inspection were confirmed on palpation. The local temperature was normal. A solitary, non-tender, firm thyroid swelling arising from the right lobe and isthmus of size 6 × 6 centimeter, globular in shape with smooth surface and regular margins, extending superiorly up to the thyroid cartilage, inferiorly up to the suprasternal notch, medially till 2 centimeter left of the midline, and laterally reaching deep to the anterior border of the sternocleidomastoid muscle. Swelling is mobile in horizontal direction and moving with deglutition. Finger can be insinuated between the sternal notch and the inferior margin of the swelling. Bilateral carotid pulsations are palpable. Trachea is central. Cervical lymph nodes were not palpable, and cervical spine was normal. Systemic examination, respiratory system, bilateral equal air entry. Cardiovascular system, S1, S2 was heard. There were no murmurs. Central nervous system, no focal neurological deficit. Higher mental functions were normal. And per abdomen examination was normal. Summarizing my case, a 57-year-old lady with painless swelling in the front of the neck for 3 years with rapid increase in the size for 6 months with no pressure symptoms. On examination, a non-tender, firm, solitary thyroid swelling arising from the right lobe and isthmus of a size 6 × 6 centimeter with smooth surface and regular margins, moving with deglutition, with no cervical lymphadenopathy, no eye signs, and clinically euthyroid. Rest of the systemic examination was normal.
Thank you, Dr. Kainath. You presented it well. May I, Dr. Ramanus, any point to be made in history and examination?
Sir, the first one is that it is good to mention about the endemicity of the region that the lady is coming from. But Delhi is a non-endemic, I hope, number one. Number two is that what is the daily consumption of iodine, particularly remember that you are presenting a benign disease in which majority of the diseases will be related to goiter formation. So it is you may mention that particularly. Number three is that is your diagnosis going to be a cancer? If it is not going to be a cancer, then mentioning ECOG may not be a very good idea if your diagnosis is not going to be a cancer in the end. Apart from that, I am more or less, it is good enough. You should have mentioned little more about the functional symptoms like hypo and hyperthyroidism in this patient. Little more in details, and as it was mentioned in the last case, maybe you have omitted for that reason. Regarding the clinical examination, There are some points that let us discuss about with the other examiners also. But particularly, I think you have talked about the trail sign in which the trachea was present. And I'll be more happy if you have felt about the lymph nodes in the neck and the signs or any other signs of hyperthyroidism. I think so. This is from my end.
Okay, thank you, Dr. Ramanus. Dr. Kainath, you mentioned ECOG 1.
Yes, sir.
Is it the patient is having just a swelling or more or less asymptomatic? Why do you put it ECOG 1?
So she is.
No. What is ECOG 1? So I'm not happy with the ECOG 1. It should be ECOG 0. Anyway, so that was the one mistake. Dr. Asdeep is there?
Yes, sir, I'm here, sir.
Dr. Asdeep, any questions from an examination?
Nothing right now, sir. Move on in the discussion.
Okay. Dr. Sanjeev Singla?
So, if we are talking about the history, why do you take the history of radiation and what radiation?
Sir, in a case of thyroid swelling, if the patient has received radiotherapy for any disease in the past, approximately 20 to 30 years back, the patient has a higher chance of thyroid malignancy, particularly papillary thyroid carcinoma in the adult age, with a latent period of 20 to 30 years.
I am not sure I'll grant it to you. Radiotherapy for any disease? What kind of radiotherapy is relevant to thyroid malignancies?
Sir, usually in olden times, radiotherapy was given for acne vulgaris. Low dose radiotherapy was given for acne vulgaris and other dermatological conditions.
So now you have come out with a golden word which I wanted to hear, the low dose radiotherapy. So it is not any radiotherapy for any disease. The only relevant radiotherapy history is for low dose radiotherapy.
Yes.
Almost practically given up. I'm not saying that you should not mention it, but if you just, when you are saying the history, just say low dose radiotherapy, the examiner will also know that you understand the significance. Otherwise, I'll just think that you did not know the significance and made it more as a rote. That was one point I was trying to make. Thank you.
Yes,
Dr. Kamal? Dr. Kamal Kataria?
Sir, Dr. Kamal and Dr. Beena Ravi are not there in this session.
Okay. Dr. Priya? Dr. Priya, you have...
What family history did you take for this patient? And regarding your suspicion of a malignancy, what are the features that you're suspecting?
Ma'am, family history of any goitrous enlargement in the rest of the family members or people living nearby to rule out any endemic goiter. History of any men-related malignancies, but usually patients with men-related malignancies present at an earlier age. And history of any
Kainath, which MEN-related disease? Which MEN type?
Sir, MEN related are MEN 2A, MEN 2B, and familial MEN syndromes.
Okay. What are the different types of medullary carcinoma?
Sir, medullary thyroid carcinoma can be with the MEN 2A, in which it is associated with pheochromocytoma.
No, I'm not. So there are three types: sporadic,
familial, and non-familial. Familial non-men related medullary thyroid carcinoma.
To me, is sporadic, familial, and syndromic, right?
Yes.
So, in family history, you want to ask about the familial MEN or familial medullary or ME syndromic, isn't it?
Yes, sir.
Both 2A and 2B have medullary carcinoma. Which one is dangerous one, where the medical ulcer develops?
So, in MEN 2B related is associated with poor prognosis.
Yes, meant to be related will be have the. That's about the family history, because you have asked the families about the swelling, about the similar swelling in the family. So you have to keep this thing in mind. 2B and 2A are medullary related. What are the genes responsible for it? Medullary carcinoma?
Sir, usually RET PTC translocation,
Okay.
PTC1 and PTC3.
Right. Now, Dr. Sadan.
Yes, sir. You said translocation. The translocation is associated with the papillary. The gene point mutation is associated with the medullary carcinoma. So in this lady, what do you think are the 2 points that can favor it being a neoplastic etiology?
Sir, old age and rapid increase in the size over a short period of time.
Tell me the types of malignancy where you will get the rapid rise, rapid increase in size of the swelling among the thyroid.
So follicular neoplasm can present in a long-standing.
I'm not talking. I'm taking rapid increase in size. In which types of thyroid malignancy you will get that?
So anaplastic.
Yeah, anaplastic, very good, and also in medullary.
Yes, sir, medullary.
Lymphoma.
Yes.
Thank you, sir. We can proceed ahead.
Yeah. So let us finish this examination part of it with the 2 comments before we go to the Ramanus. One is you said the swelling is mobile in the horizontal direction. Is the thyroid swelling mobile in the horizontal direction?
So to some extent, thyroid swellings can be mobile in horizontal direction.
Attached to posteriorly to the trachea. So if you are moving it, the trachea is moving along it. So this is so if you want to move the trachea, it doesn't have any individual its own mobility, transverse mobility. It has got the vertical mobility, and that too is not of its own. It moves because the thyroid or the larynx are moving.
Yes, sir.
With it. Okay, fine. Let's go to the next part of it. Dr. Ramanus, questions in management.
Right. So now, doctor, what is your provisional diagnosis? Can you kindly repeat that for all of us again?
Sir, a 57-year-old lady with a history of thyroid swelling for the past 3 years with rapid increase in size.
We need a provisional clinical diagnosis. We don't need a summary.
Sir, patient with a solitary thyroid swelling with rapid solitary thyroid swelling with clinically euthyroid with no pressure symptoms.
So let us stop at that. So the patient diagnosis is a solitary thyroid nodule, right side of the thyroid gland, no pressure symptoms is good enough. How do you define a solitary thyroid nodule?
So solitary thyroid nodule is a discrete swelling in the thyroid gland with the rest of the gland normal or impalpable.
Okay, is it a clinical diagnosis? Is it a radiological diagnosis? Is it a pathological diagnosis?
So it is a clinical diagnosis.
Okay, so what are the pathological entities that can make up a solitary thyroid nodule?
So thyroid cyst can present as a solitary thyroid nodule. Adenomas, follicular adenomas can present as a solitary thyroid nodule. Multinodular goiter with a dominant nodule can present as a solitary thyroid nodule. So carcinoma, thyroid carcinoma can present as a solitary thyroid nodule.
Okay, so you have mentioned number 1, a multinodular goiter in which there is a large nodule, which is either a discrete or a dominant nodule. Yes. Number 2, a papillary carcinoma. Number 3, a follicular neoplasm. Number 4, a cyst in the thyroid.
Yes.
So please remember it in that sequence, isn't it? Okay.
Yes, sir. Yes,
so and then you investigate based on this clinical diagnosis. I think, sir, this is from my end because we will have more discussions on this regard.
Okay, fine. Okay. Right. Next to Dr. Rajdeep.
Yes, Dr. Kainat. So how will you proceed?
Sir, I would like to do investigations to confirm my diagnosis, and sir, I'll like to do ultrasound, which is an extension of the clinical examination. Ultrasound of the neck with a Doppler and, if possible, elastography. And I'd like, as the patient is clinically euthyroid, we can first go for an ultrasound and then we can go for a biochemical investigations. So on ultrasound, we'd like to see.
Before you go further, I would like to disagree here. The thyroid function test is always done first, then you move on to the further examination.
Yes.
Okay. So the first step is whether the patient is euthyroid or not. Clinically, I agree, you have said, but biochemically, whether the patient is euthyroid or not, that is the first step. Then you move on to the ultrasound. Okay. Why do you want an ultrasound? What are the things you are specifically looking for?
So in an ultrasound, we'd like to see the status of the gland, if it is a solitary nodule or there are other nodules present, to see for any vascularity and make a Thyroid's score of the gland, to see for other lymph nodes in the neck. In the thyroid, for the thyroid,
solid or cystic?
To look for the composition, to look for echogenicity. Composition can be solid, cystic, or mixed. We can look for the echogenicity, which can be hypoechoic, hyperechoic. Then we can look for the margins of the nodule, which can be irregular or regular. Then we can look for any calcifications, punctate calcifications, or any. Then we can look for vascularity, peripheral vascularity or central vascularity, and echogenic foci.
Based on your different ultrasound findings, let's call it the thyroid score.
Yes, sir.
What would your further investigation be?
So based on the ultrasound findings, if the thyroid is 1 or 2, the patient might not need an FNAC, but as the size of the swelling is large in my patient, and we would like to go for an FNAC if the patient is euthyroid.
Supposing it's a cystic lesion.
So purely cystic lesions are at a very low risk of malignancy. Less than 1% of them can be malignant, purely cystic lesions. But because it is a large swelling, we can either monitor the patient or we can go for an FNAC depending upon the clinical suspicion.
Like you said, it's a large swelling, so you will not just monitor. Yes. So how would you, this overlaps with the management also. So in a cystic lesion, how do you proceed in such cases?
Sir, because it is a large swelling, we'd like to go for an FNAC, and the FNAC, depending upon the Bethesda classification.
FNAC from where? It's a cystic lesion.
So from the most, from the largest, from the margins of the cyst.
Randomly? No. So you aspirate the cyst completely, and if there's any residual mass, you take an FNAC from there, or if there's a wall irregularity,
from there.
And you can complete the management here itself. So cyst is there, it should not be bloody, it should be clear, cytology should not be malignant. And if all is fine, then you can send the patient home. And if the patient comes back after, say, 6 months with recurrence of the swelling, what do you do?
We can re-aspirate 2-3 times, and if it still recurs, then we'd like to go for a lobectomy.
Okay, so cyst is out of the way. We finished the discussion about that. Now let's move on to a solid lesion.
Yes.
So if it's a solid lesion on ultrasound, how do you proceed now?
So if it's a solid lesion, then we'll like to do an FNAC from all the suspicious nodules. Then depending upon the Bethesda classification, depending on what grade the FNAC report is, if it is of atypical of unknown significance, ATP of unknown significance or follicular lesion of unknown significance, we can either monitor the patient, or we can, or if the clinical suspicion is high, we can also do molecular tests to rule out any neoplasm. If there is, if the Bethesda shows a lesion that is suggestive of a follicular neoplasm, and if the size is more than 2 centimeters, then we can go for a lobectomy. And depending upon the features, if the age is more than 55, and if there is extravascular, there is vascular invasion, there is extracapsular extension, there are lymph nodes present, or there is any history of radiation, then we can go for a completion thyroidectomy. And if the patient falls into a low risk, then we can monitor the patient and give levothyroxine suppression.
Those points will be discussed further. Now, my question is a bit different. What's the role of radioisotope scans?
So in a patient with hyperthyroidism, with a toxic patient, so we can do a radioisotope scan to see if there is to see if it is a toxic nodule or there is a multinodular goiter with toxicity.
So that's an hyperthyroid patient.
Yes,
But
sir.
in this solitary thyroid nodule, any role?
So if the patient has toxic, if the patient is hyperthyroid, then we can go for a radioisotope scan. Otherwise, it is not indicated.
Yes, so that's just a point I needed to mention, that some people think that radioisotope scan is to be done in euthyroid patients. Presently, it is not indicated routinely. So, but in malignancy, is there any role for radioisotope scans at any stage of management?
Sir, in after total thyroidectomy has been done, we can do a radioisotope scan to look for any residual disease in the neck, to look for any metastasis at any other places and lymph nodes.
Good, right. So for the rest of the discussion, I think we can move on to the next examiner.
Dr. Sanjeev Sinha, sir,
You have been answering very well. First of all, let me compliment you.
Thank you.
We are talking of radioiodine, so I'll just take a few questions on that. What is the difference in the isotopes used for radioiodine scan and radioiodine therapy?
So we usually do the scan with iodine 123, which has a half-life of 13 hours and has gamma rays, which emits gamma rays. And so for treatment, we usually prefer iodine 131, which has both beta and gamma rays and has a half-life of 7 to 8 days.
It has more beta rays, in fact, not just though both of them have got both. It's just which has got more of which. So 123 has got more than 80% gamma rays.
Gamma rays, yes, sir.
Whereas 131 has in a similar proportion 80 to 90% of beta rays.
Yes.
What is the advantage of beta?
Sir,
one you have already said is the
ablation.
right?
Sir, it is, and it there is. So there is more ablation with the organs in contact.
So beta rays do not propagate far; they remain inside the body and they are locally very, very small, 1 to 2. Whereas gamma rays propagate farther and can be picked up by a scanner, even outside the body.
Yes.
Very good. Very good.
Dr. Priya, have you any questions?
Would you like to do a true-cut biopsy in this patient? In which conditions would you suggest it in thyroid?
Ma'am, in patients in this condition, true-cut biopsy is not indicated, but in patients where of anaplastic carcinoma and lymphoma, true-cut biopsy can be done for a histological diagnosis. Also in renal thyroiditis, where the gland is fibrosed and an FNHC can be undiagnostic, true-cut biopsy can be done for a diagnosis.
Why don't you normally do a true-cut biopsy?
Ma'am, there are more chances of hemorrhage, and there are more chances of hemorrhage with a true-cut biopsy, and other organs, other structures can also be damaged, like recurrent laryngeal nerve.
Dr. Shadan?
What is?
Okay, sir. Dr. Gainath, I think you mentioned that you will do ultrasound and you will do Doppler and you will do elastography.
Yes, sir.
So you also mentioned about thyroid staging, I think. Huh?
Yes, sir.
So why the vascular T is not included in thyroid scoring? It is not included in that, no? I hope.
No, sir.
So why it is so? And what do we want to see in Doppler? What will be the finding in a neoplastic one?
Sir, I'm not sure why vascularity is not included, but in a neoplastic or a malignant swelling, there will be central vascularity in the nodule, and if there are lymph nodes, peripheral vascularity can be seen in the.
Yes, here too. Probably the thyroid scoring is primarily meant for the papillary, and there the vascularity is not that much. But yes, if we're talking about the follicular, it is significant. You talked about also elastography. Can you tell me the limitation of this test where it will not be useful?
Sir,
it is done to look for
if the nodules are not compressible and they are hard. If the nodules are not compressible on elastography, and there are more chances of it to be malignant.
yeah, basically it look at the inconsistency from history. So if you get an ultrasound purely cystic swelling there, of course, it will not be much of use. And if you have a patient who has a very bulky neck, fatty one, there it will not be of much use, limitation. And if you get a multinodular goiter where your focus nodule is lying posterior to the one you have, and also a patient with a nodule that is situated very far posteriorly. So that is the limitation you should keep in mind. And then you said you will do the FNAC.
Yes, sir.
So you did a USG guided FNAC from the most suspicious spine. So when will you say your FNAC is adequate?
Sir, the FNAC specimen is said to be adequate if 6 follicles are taken with 10 to 15 cells in each follicle.
And is it required to exclude or to diagnose the case? I'm trying to say, is it this much of finding is required to exclude the neoplasia, or is it having some exception?
So to increase the sensitivity.
When you will not require these criteria, and you can make a diagnosis. This is primarily basically to exclude the diagnosis of neoplasia. You need this much of cytological finding to say. Until your FNAC is adequate, you cannot say whether you cannot exclude the possibility. What are the exception where you can make a diagnosis without having 6 follicle with 10 or 15 or more cell? You can make a diagnosis straightforward.
Sir, if we see any extrathyroidal extension, if there are lymph nodes.
No, on FNAC, you won't be able to see extrathyroidal extension, but you will see the cell are contained.
Sir, there is amyloid stroma.
There is amyloid stroma. It's straightforward. It will suggest the diagnosis. And
sir, there are.
So if you get too much,
colloid is less.
Yes, if you are getting colloid, you can make a diagnosis. Basically, it is to exclude. If you get too much of lymphocyte, you can make a diagnosis. And even if you get few cells, ATPR cells, you can make a diagnosis of malignancy. So to exclude the diagnosis of neoplasia, you need this much of finding. What are the types of FNAC that are done by ultrasound? Suppose you got an ultrasound, you targeted the nodule, and you use but you were 25 to 23 gauge needle, you introduce into the nodule, then what is the method of getting this?
Sir, we can do, so there are two, sir, in one type of FNAC, we go with it while aspirating.
So one will be aspirational, where you will create a suction.
And then one will be non-aspirational. Yes.
Very good. And so then other will be non-aspirational.
Yes, sir.
Okay. So what will you do after taking out the needle? Of course, you will release the suction. You will take it out.
So we'll release the suction when we remove the needle. Then we will remove the needle hub from the syringe. We will fill the syringe with air, and then we will replace the syringe, the needle hub. And then we will push the contents over a slide and put another slide over the slide over which the contents were pushed.
Very good. Then you can use either air dried method or to fix it and stain as per.
Yes.
Thank you, sir. Thank you. Very good. Very good answer.
Dr. Shadant, so if you get a solitary thyroid nodule, the first you get the TS is done as Dr. Rajdeep said.
Yes.
So then follow it with the ultrasound. And ultrasound will grade you likely to be the malignant one. One is thyroid, the another is your ATA guidelines, ATA sonographic risk pattern, which classifies into the higher suspicious, intermediate, low suspicious, very low suspicious, and benign. Now, Dr. Sadan was asking whether vascularity is included into the thyroid, doesn't include the vascularity, whereas the ATA, this ATA guidelines or ATA sonographic pattern or ATA guideline or grading system, they include the vascularity. So thyroid is very old one. This is the new advancement. So you have to remember the ATA sonographic grading rather than the thyroid. Now once you have done this thing, then you have to, based on this finding, you have to get the FNAC done. And Bethesda tells you what next, isn't it? So with us, Now, suppose this is all about the EU thyroid. Suppose you get a solitary thyroid nodule and you get the TSH done, and TSH is on the higher side of the normal. Is there an inference for it? So it's likely to be malignant. So this has been come into the paper. So it is likely to be malignant. Okay. Yes. So next session we will have, according to now, the management depends upon the what comes out in the FNAC, isn't it?
Yes, sir.
Next round, Dr. Ramanus will ask you different FNAC findings and the management. Dr. Ramanus?
Right. Sorry, sir. Hello. Am I audible now?
Yes,
right.
Sir.
Very good evening. Now, as we are going to talk about the FNAC, have you seen an FNAC of the thyroid being done, madam, in your institute?
Yes, sir.
Okay. What was the anesthesia that was used during the FNAC?
Sir, lignocaine local anesthesia.
Did they use an anesthesia during an FNAC?
Yes, sir.
Oh, very interesting. Okay, what was the size of the needle?
The 23 gauge.
23 gauge. We usually use a 25 to 27, right, for an FNAC, and we do not use an anesthesia because it's only a needle prick. It is better done with an ultrasound guidance. Okay.
Yes, sir.
Now,
Yes, sir.
so dependent upon an FNAC, can you narrate what are the Bethesda classification of an FNAC of a thyroid, and how do you plan your decisions thereafter?
So depending upon the Bethesda classification is type Bethesda 1 is non-diagnostic, Bethesda 2 is benign, Bethesda 3 is ATP of unknown significance or follicular lesion of unknown significance. Bethesda 4 is suspicious of a follicular neoplasm or suspicious of Hurthle cell carcinoma. Bethesda 5 is suspicious of malignancy. And Bethesda 6 is biopsy proven malignancy.
Right. So say for example, this lady comes out to be a Bethesda 3.
Yes, sir. ATP of unknown significance.
And the TIRADS tells you that this is a 4A, or according to the ATA guidelines, it shows some, or it shows a suspicious features of a malignancy.
Yes, sir.
Okay.
Yes.
So what is your next step then? A Bethesda is a Bethesda 3 and you have a TIRADS 4. So what is your next step then?
Sir, as the ultrasound features are suspicious of a malignancy and the size of the lesion is 6 centimeters. So depending upon if the patient is willing for a lobectomy, so ideally we would like to go for a lobectomy in this patient. If the patient is not willing for a lobectomy, then we can go for further molecular tests to confirm our diagnosis, to prove if the patient has a malignancy or not. If the molecular tests also come out to be positive, then we would like to go for a lobectomy. And if the molecular tests are not positive, then we might keep the patient on ultrasound monitoring. And if the size of the nodule or any other suspicious, any other features that are suspicious are present, then we can we can repeat an FNAC and then further plan.
Okay, right enough. Sir, it is all from my end. Thank you.
Dr.
You answered well, Doctor.
Dr. Rajdev?
Yes, sir. So, any further thing you would like to do in this particular case? I mean, after surgery.
Sir, after surgery, sir, if we operate with a diagnosis of malignancy, depending upon if it is a papillary thyroid carcinoma or a follicular carcinoma, we would, if the patient has all the high risk features, we would go for a total thyroidectomy, and post-op, we would like to do a thyroid radioisotope scan to look for any residual disease. And
tumor markers?
Sir, thyroglobulin can be done for a differentiated thyroid carcinoma, which includes follicular and papillary. And if it is a medullary thyroid carcinoma, then baseline CEA levels and calcitonin levels can be done. So if it is a high suspicious lesion and for a differentiated thyroid carcinoma and following total thyroidectomy, we'd like to do a radioisotope scan for residual disease and any distant metastasis. And we would keep the patient on a suppressive levothyroxine therapy.
Why do you want to do a total thyroidectomy when the disease is unilateral?
Sir, we decide upon the total thyroidectomy or lobectomy depending upon the clinical patient features and the histopathological features. If the patient comes in low risk for a papillary carcinoma, if the size of the lesion is less than 1 centimeter, that is micro carcinoma.
I'm talking about this patient. It must be more than 2 centimeters.
Yes, sir.
So in this particular case, why would you? It's a unilateral disease. Why do you want to do a bilateral or total thyroidectomy?
Sir, in this patient, although there are no lymph nodes, but if the histopathology, but the age is more than 55, which comes in the high risk features, and for a thyroglobulin assessment and radioisotope assessment is better if we do a total thyroidectomy. And if there is recurrence, then a revision surgery is more difficult.
So one you have said for post-operative follow-up.
Yes.
So whether the patient has mets or not, radioisotope scan.
Yes, sir.
Any reason for doing it, say, in a papillary thyroid cancer?
Sir, in papillary thyroid carcinoma, as in this patient, the size is more than 4 centimeters. It is indicated that we do total thyroidectomy because usually if the size is more than 4 centimeter, multifocal disease is more common and occult metastases are common.
Yes, so the reason is because multifocality is more common. So that's why you go for total, apart from the postoperative management. And it's not only a total thyroidectomy, something else is also done along with it?
Sir, prophylactic central neck dissection can be done if there are if lymph nodes are present in the central group. And if lymph nodes are also present in the lateral area, then we can also go for a prophylactic or we can go for a lateral neck dissection.
So it won't be prophylactic if nodes are present.
Yes, sir.
Therapeutic neck dissection.
Therapeutic neck dissection.
So otherwise, in your case, it's going to be central neck dissection.
Yes.
What are the boundaries of the central compartment?
The central compartment is superiorly the hyoid bone, inferiorly the suprasternal notch or the innominate artery, and bilaterally the carotid artery.
Yes.
Okay. Doctor.
Yes, sir.
Hello, am I audible?
Yes, sir.
Okay, most of the things have been asked. When you were talking about doing a thyroid scan post-operatively, how would you prepare your patient for a post-operative thyroid scan?
Sir, for a post-operative thyroid scan, if patient has already been started on thyroxine therapy, then if we are giving T4, the patient needs to be put off the treatment for a period of 4 to 6 weeks for the thyroid gland, for the remnant tissue to be receptive to the iodine and can uptake it. If the patient is being given T3, then we have to keep the patient off the treatment for up to 2 weeks, and we advise the patient to take a low iodine diet in that time.
Anything else which you can do? I mean, making a patient hypothyroid is not a very easy or a comfortable thing for a patient, especially in early.
So we can also give recombinant TSH, that is thyrogen, to make the tissues more receptive.
Good.
Dr. Priya, you have any question?
What is the difference in staging of the different types of thyroid malignancies?
So, Dr. Priya, it will take a lot of time. We have running sort of time. Only
the main difference, she has to tell what is the main difference in staging between differentiated thyroid carcinomas And metastatic carcinomas.
Ma'am, in differentiated thyroid carcinomas, if the age is less than 55, there is only stage if the age is less than 55, if metastasis is present, then the patient is stage 2, and if the metastasis is not present, then the patient is stage 1 disease. And if the age is more than 55, then according to stage 1 is T1, N1, T1, N0, M0. Stage 2 is T2, T3, N0, M0. Stage 3 is stage T1, T2, N1, M0, T3, N0, M0, and stage 4 includes T3, N1B, T1, T2, N1B, T3, N1A, and T4.
I just asked what is the difference between differentiated thyroid carcinomas and medullary carcinomas in staging. I didn't ask you the entire staging.
Dr. Priya,
You do not have age factor.
We do not have the age criteria in the medullary
staging.
thyroid carcinoma.
Otherwise, the nodes and the T staging is the same.
Yes, ma'am.
That is, and you do not have any stage 4 and stage 3 disease in
differentiated thyroid in less than 55 years.
Okay. Dr. Sadan?
Sir, just few quick one-liner I would like to ask. Other than getting a control of the tumor, what is the advantage of doing total thyroidectomy in differentiated thyroid carcinoma? Okay, answer is it makes surveillance easy. It makes thyroglobulin level, anti-thyroglobulin level more pertinent. And the second question is, how much TSH you should be happy with before going for thyroid scan, if you talk about the value?
So less than 0.1.
No, TSH before radio-iodine scan. It should be above 30. You want to make you in a hypothyroidism. That will be.
Yes, sir, yes, sir.
And what is the advantage and one disadvantage of using technetium pertecnate rather than iodine 131, 123?
Sir, advantage is it has less radiation, and the report can be the report is ready. We can get the report readily, and the disadvantage is there can be discordant scans in which a nodule may be there can be a higher uptake in the nodule, but that may not be malignant.
No, it has a less thyroidal intake. It is actually better for lymph node if you talk about this. And disadvantage of using iodine 131 is it is highly unstable, and if it is not freshly prepared, it gets impurities. That is not a good to and I think it is not available in most of the centers. Okay, thank you. That is from my side.
Okay, Dr. Kainat, a quick few sentences. I have seen somebody, the examiners asking about the triple test in the thyroid as well. So you need to you need to know it. Triple test is like the same, the clinical examination, the
Radiological and FNS.
And sometimes they also ask quadruple test.
Sir, along with the clinical, radiological, that is ultrasound, and FNAC, we can go for molecular testing. That is quadrupled.
To the ATA guidelines, but it's not being followed all over. What are the molecular testing? What are the genes you will likely to look for?
So we like to check for BRAF, KRAS, PPAR and PAX8, RET PTC.
Yes, good. And the last question, what you was talking about the technetium drawback, and you talked about the discordant scan. What you said is not the discordant scan. Normally, what happens? It has been seen in 20% of the cases. Even the thyroid cancer becomes hot, takes up the technetium 99, then becomes a problem. For to rule it out, you have to again go back to iodine 131, and in that it becomes cold. This is known as discordant. One is hot, and other becomes
cold. Yes, sir.
Discordant. Thank you very much. That's a good presentation.
Thank you, sir.
I wind up here.
Dr. Kainat.
Thank you, sir.
The third presenter, who is Shubham Gupta. Dr. Shubham, are you ready? Share your slide. Yes, sir. Share your slides. Let's start up. Is it visible, sir? Yeah. Continue. Can you start up? I'll start, sir. Yeah. Good evening, everyone. I am Dr. Shubham Gupta, third year postgraduate resident from Department of General Surgery. My clinical case is a 40-year-old housewife, resident of Indore, came with the complaints of ulcer over the right border of tongue since 4 months, pain at the site of lesion since 2 months, and she has difficulty in speaking since 1 month. The patient was apparently well 4 months back when she noticed the ulcer-proliferative growth in the right lateral border of tongue. It was small in size, spontaneous in onset, and gradually progressive. The ulcer not seen. Lights are not seen now, neither is heard. Any problem with network?
Ashish, just try to call him and see what the problem is occurring.
Yes, sir. Yes, sir.
Network is probably.
Sir, if there is any problem in his internet connectivity and if you feel appropriate, we may start with the lectures and he can be accommodated as and when he join back.
Sure. So, are you ready?
Sir, he probably has joined back now. Yes.
Dr. Shubham, you can switch off your video, so it will be help to. You can switch off your video.
Okay, sir. Am I audible, sir?
Sure. Yeah, Shubham, kindly start presenting your case, sir.
Yes, sir. I have a 40-year-old housewife, resident of Indore, came with the cheap complaint of ulcer over the right border of tongue since 4 months, pain at the side and she had
Shubham, there is a problem. There is a problem in probably your system or internet.
She was apparently all right 4 months back when she noticed the ulcer.
Dr. Shubham, your internet connectivity is too low, sir.
Yeah.
So we can start with Dr. Priya, and meanwhile we will connect.
Yes, sir. Yeah. If you feel appropriate, sir, this is probably the best solution right now. Thank you.
Priya? Dr. Priya?
Yes. I'm presenting. Is my screen visible?
Yeah, it's visible.
So the lecture is on thyroidectomy. Regarding the MS, from the MS point of view, they might be asked questions on relevant anatomy types, indications, contraindications, procedural steps, complications, and recent advances. Regarding the relevant anatomy, the pretracheal, the thyroid has a true capsule, which is the capsule of the thyroid gland, and a false condensation of pretracheal fascia around it, or which is also forms the ligament of Berry. It is important because the thyroid venous plexus lies deep to the true capsule and it should not be injured while dissection. The dissection plane is between the true capsule and the false capsule or the pretracheal fascia. Blood supply of thyroid is from the superior thyroid arteries, the branches of external carotid, the inferior thyroid, thyrocervical trunks, and thyroidema arteries. Thyroidema is more overemphasized than seen. The external branch of the superior laryngeal nerve descends along with the superior thyroid artery into the superior pole. More directly, the inferior thyroid artery runs behind the carotid sheath and loops up to the inferior pole of the thyroid, crossing the sympathetic trunks, and has the recurrent laryngeal nerve in its terminal branches. The superior thyroid vein follows the course of the superior thyroid artery. The middle thyroid veins don't have a middle thyroid artery. They drain directly into IJV. The inferior thyroid veins drain into innominate vein, and they do not follow the course of the inferior thyroid artery. They drain directly from the isthmus and the lower pretracheal areas. This is a picture of the blood supply of the thyroid showing the superior thyroid vessels, the middle thyroid vein, and the different patterns or the course of the inferior thyroid artery and the inferior thyroid veins. The recurrent laryngeal nerve loops the subclavian on the right and aortic arch on the left, ascends in the tracheoesophageal groove behind the thyroid, and enters the larynx under the inferior constrictor just posterior to the cricothyroid joint. It supplies all the intrinsic muscles of the larynx except cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve, and it supplies both the adductors and the abductors of the larynx. The posterior cricoarytenoid is the only abductor of the larynx, of the vocal cords, sorry. And it also gives sensation to the larynx and branches to the trachea, esophagus, and inferior constrictor of the pharynx. There are a lot of variations with respect of the recurrent laryngeal nerve with respect to inferior thyroid artery. It can travel behind the branches of the inferior thyroid artery, in front of it, or in between the branches. The right recurrent laryngeal nerve is more superficial. It crosses more in between the branches of the inferior thyroid artery or anterior to the inferior thyroid artery. And it is also more oblique. It enters at a 45 degrees angle. So it is more prone to damage than the left recurrent laryngeal nerve. We should be aware that there can be non-recurrent laryngeal nerves, which is rare anomaly, more common on the right side and extremely rare on the left side. These non-recurrent laryngeal nerves might descend along with the superior thyroid artery or cross in between the superior and inferior thyroid vessels, the type 2A, and the type 2B is along with the inferior thyroid artery. External branch of superior laryngeal nerve, which is a motor to the cricothyroid muscle, which helps in high-pitched voice sounds, important in singers, descends with the superior thyroid vessels. Injuries to these nerves can be easily overlooked at postoperative laryngoscopy. The Cernier classification classifies the relationship between the superior thyroid vessels and the external branch of superior laryngeal nerve. Type 1, it crosses 1 centimeter above the pole of the superior pole of thyroid. In type 2A, it is within 1 centimeter of the superior pole, and it is frequently in between the branches of the superior thyroid vessels. And type 2B, it is inferior. Type 2B is more commonly seen in large goiters. There are certain triangles which have been mentioned in literature regarding identification of recurrent laryngeal nerve and the external branch of the superior laryngeal nerve. The Bear's triangle, the common carotid artery, inferior thyroid artery, and the recurrent laryngeal nerve. However, one should remember that recurrent laryngeal nerve should be detected prior to identification of this triangle. Therefore, the recurrent laryngeal nerve forming a side of the triangle doesn't make it helpful. So that's why Simons have described another triangle in which is bounded by the common carotid artery, inferior thyroid artery, and the esophagus. The nerve crosses this triangle. Other triangles described are the lower central triangle, which is again the common carotid, inferior thyroid artery similar to the Simon's and Bear's, but the third side is by the thyroid lower pole. And also described as a lower triangle by carotid artery, the superior inferior thyroid pole, and trachea and esophagus. These are various triangles or the areas in which one can look for the recurrent laryngeal nerve. The Joel's triangle is defined for detection of the external branch of the superior laryngeal nerve. Its sides consist of the attachments of the strap muscles, the midline, and the superior thyroid pole. The picothyroid space of Reeves is a vascular space between the upper pole of thyroid and the plicothyroid muscles, which has to be dissected open to prevent injury to the external branch of the superior laryngeal nerve. There is also another triangle which is described as a triangle of concern, which has an apex at the ligament of Berry and trachea medially and recurrent laryngeal nerve laterally. There are small vessels of the inferior thyroid artery as well as the inferior laryngeal artery which cross these areas. And bleeding in this area can be troublesome, should not be cauterized with a monopolar cautery or clamped, but one should use bipolar or vessel sealing devices in this area. These are the various diagrammatic depictions of the Bear's triangle, the triangle of concern, and Simon's triangle. The other anatomic landmark which is useful in identification of the recurrent laryngeal nerve and the parathyroid is the tubercle of Zuckerkandl, which is a posterolateral protrusion at the thyroid lobe. It is found in 80% of the thyroids, and 93% of recurrent laryngeal nerve are medial to this tubercle. The superior parathyroids and the inferior parathyroids are usually 4 in number, but can be supernumerary, especially the inferior parathyroids, which are often supernumerary, which can be supernumerary and have varied locations. The superior parathyroids are located 1 centimeter superior to the junction of recurrent laryngeal nerve with inferior thyroid artery, just above the tubercle of Zuckerkandl, and they lie deep to the plane of recurrent laryngeal nerve in unretracted thyroid. The inferior parathyroid, whereas the location being more variable, it is in the inferior pole within 1 to 2 centimeters of the insertion of the inferior thyroid artery and lies superficial to the plane of recurrent laryngeal nerve. The parathyroids are usually supplied by inferior thyroid artery with certain collaterals from the superior thyroid, thyroidema, tracheal, and esophageal arteries. So that was mainly the relevant anatomies which you might be asked when you are given to describe the process of thyroidectomy. Then the various types of thyroidectomy. There are many nomenclatures used for types of thyroidectomy like partial, isthmusectomy, lobectomy, hemithyroidectomy, subtotal, near total, total thyroidectomy, and completion thyroidectomy. The standard ATA definitions of the types of thyroidectomy are: one is a lobectomy, hemithyroidectomy with or without isthmusectomy, a near total thyroidectomy which removes all gross visible tissue, leaving only less than 1 gram of tissue adjacent the recurrent laryngeal nerve in the ligament of Berry. Total thyroidectomy is removal of all gross visible thyroid tissue, and they describe subtotal thyroidectomy as leaving greater than 1 gram of tissue in the posterior capsule on the uninvolved side. Others describe it as leaving of approximately 4 to 8 gram of tissues to achieve a new thyroid state. Then you might be asked about the indications and contraindications of thyroidectomy. Thyroidectomy is indicated in malignancies, which may be diagnosed malignancies, follicular neoplasms, indeterminate or suspicious FNACs, benign thyroid masses, which are symptomatic or for aesthetic reasons, in thyrotoxicosis, which is refractory to drugs, non-compliant to medications, or there are side effects of medications, or thyrotoxicosis, Graves' disease associated with exophthalmos, a large goiter, retrosternal goiter with compressive symptoms, or when there are contraindications to radioiodine therapy. Thyroidectomy may also be performed as a part of other operations like laryngectomy and tracheal tumor excisions. Uncontrolled severe hypothyroidism is a relative contraindications and in pregnancy in certain conditions. The special preoperative considerations or optimizations that are required is thyroid function test and an adequate control of thyroid function, USG thyroid neck, FNAC, vitamin D levels and supplementations, X-ray soft tissue necks for tracheal location, imaging for retrosternal extension or tracheal compression and SVC syndrome as may be indicated, and definitely a vocal cord evaluation to pre-op documentation of which is very important to assess any changes in the intraoperative or postoperative period. Approaches to thyroidectomy might be open or minimally invasive. and they might be by a midline or a lateral approach. The minimally invasive approaches are transoral nodes, or transaxillary, supraclavicular, or robotic approaches. Here we discuss the procedural steps of an open thyroidectomy by a medial approach. You might be asked about the special equipments, and one of the common equipments which might be asked is a self-retaining thyroid retractor or the Jones retractor. The other special equipments which might be required are bipolar cautery devices, vessel sealing devices, and intraoperative nerve monitoring devices. The procedure is done under general anesthesia with endotracheal intubation, and muscle relaxation may be employed with caution, especially if an intraoperative nerve monitoring is being done. Position is supine with the operating table tilted 15 degrees and neck extended with sandbags behind the shoulder blades and a ring on the head. A curvilinear skin incision in the lower skin crease 2 finger breadth above the sternal notch and the superior edge of the clavicles is placed about 4 to 8 centimeters. Some say from one sternocleidomastoid to another sternocleidomastoid, depending on the need of exposure, how large the gland is. After the skin incision, one deepens the incision through the platysma and raises subplatysmal fat in an avascular plane anterior to the anterior jugular veins. The subplatysmal flap are raised up to the thyroid notch superiorly and suprasternal notch lower, and retraction can be done with self-retaining retractors, or alternatively, they can be stitched in the 4 corners as shown in the figure. Thereafter, we open up the midline avascular plane, which is often called the cervical linea alba, between the strap muscles. The anterior jugular veins, if they are limiting in the field or they are appearing in the field of operation, they can be divided with ligatures. The strap muscles, the sternohyoid and the sternothyroid, are separated from the thyroid gland by dissecting between the false and the true capsule of the thyroid. It is important to know that you have reached the right plane, that is this plane between false and true capsules, because the true capsules, you can visualize the thyroid venous plexus which lies just underneath it. If you go beneath the true capsule, there will be hemorrhage. And if you go above the true capsule, you will be in the wrong plane laterally. The plane is dissected to the carotid sheath. Any fixity of strap muscles to the thyroid gland should raise for suspicion of thyroiditis or cancer, because otherwise it is a loosely attached tissue. If it's a large goiter or a vascular goiter, one might need to divide the strap muscles, and the division of the strap muscles should be performed cephalad, as the innervation of the muscles occurs inferiorly. Once an adequate exposure of the thyroid gland is achieved, the thyroid lobe is retracted medially, and the middle thyroid vein, if apparent at this stage, should be ligated and divided. After ligating the middle thyroid vein, attention is usually paid to the superior polar vessels. Some people prefer to dissect the inferior polar vessels, but common is to address the superior polar vessels, which need to be dissected from peritracheal tissue posterior-medially from the external branch of superior laryngeal nerve. So you enter the cricothyroid space of Reeves and dissect the superior thyroid vessels. The superior thyroid branches of the superior thyroid vessels should be ligated or sealed close to the thyroid gland. One should avoid ligation of its main trunk, and dissection should be performed medial to lateral in the cricothyroid space of Reeves. After addressing the superior pole, attention is paid to the inferior pole with ligation of inferior thyroid veins and arteries and identification and preservation of the recurrent laryngeal nerve. The inferior thyroid veins in the pretracheal region are identified and ligated. Then the dissection proceeds laterally, paratracheally, where the recurrent laryngeal nerve runs crossing the inferior thyroid artery and its branches. The parathyroid glands might be identified in this area. The inferior thyroid artery, if you retract the thyroid lobe medially and the jugular vein laterally, you can see it emerging from beneath the carotid vessels. And visual identification of the recurrent laryngeal nerve is recommended by the ATA guidelines, whereas many surgeons feel that staying close to the thyroid, one can avoid it, but one should try to identify the recurrent laryngeal nerve. It can be identified with a lateral approach, which was proposed by Theodore Koch, in which after division of the middle thyroid vein, the recurrent laryngeal nerve is identified at mid-polar level, or the inferior approach, which is more commonly done. Here, The approach is in the tracheoesophageal group, proximal to the inferior thyroid artery. The superior approach of identifying the recurrent laryngeal nerve is at the level of the inferior constrictor pharynx. The advantage of the superior approach is that this point is a little more constant point for position of the recurrent laryngeal nerve. The important way to maintain parathyroid vascularity and reduce risk of handling of recurrent laryngeal nerve is to divide the inferior thyroid tertiary branches at the thyroid capsule high on the thyroid. Parathyroid glands should be identified and preserved. If devascularized, should be implanted in muscles. A density test differentiates normal from pathological parathyroid. Parathyroid identification requires vigilant dissection of the posterior aspect of the thyroid. The superior parathyroid can be found cephalate to the tubercle of Zucker candle, and the inferior parathyroid located in a 1 centimeter radius around the inferior pole, almost always anterior to the plane of the recurrent laryngeal nerve. Sometimes there may be supernumerary parathyroid glands. If inadvertently a parathyroid has been removed, it should be kept on a specimen cup on ice. Frozen section should be done to confirm it is parathyroid, and then it should be minced into small pieces and left in a muscular pocket in the forearm or the sternocleidomastoid, and preferable to leave a radio-opaque marker in the area for further subsequent surgical intervention if required. After having addressed this inferior pole, now the thyroid is mainly attached to the pretracheal fascia and the ligament of Berry. It is important to dissect carefully in the ligament of Berry because the recurrent laryngeal nerve enters the cricothyroid muscles at this area, and it is accompanied by inferior laryngeal vessels. Bleeding at this point should never be clamped until the nerve is completely identified, and bleeding should be preferably addressed with bipolar or vessel sealing devices. Once the thyroid is thus dissected, if a hemithyroidectomy is being performed, there's a transection of the isthmus is completed and lymph node dissection if required is performed. But if there is a total thyroidectomy being performed, then the procedure is repeated on the other side. Hemostasis has to be secured. Where it is useful to position the patient head down while securing hemostasis. And then there is one closes the strap muscles in the midline, and the platysmal fibers have to be resutured. Skin closure can be continuous or intermittent. Visualization of the vocal cord movement at the time of extubution is a very important maneuver which has to be followed in all thyroidectomies. Substernal goiters usually do not require sternotomy. They can be removed by digital dissection along the thyroid capsules, but has an increased risk of recurrent laryngeal nerve injury. Sternotomy for substernal goiters may be required in superior vena cava syndrome, goiter with mediastinal blood supply, posterior mediastinal goiter, a large diameter of intrathoracic component, recurrent substernal goiters, malignancy, or invasion into mediastinal vessels or pleura. That was regarding in brief about the procedures of thyroidectomy. Coming to complications. Complications of thyroidectomy can be a thyrotoxic storm, bleeding, dyspnea or stridor, recurrent laryngeal nerve injury, superior laryngeal nerve injury, tracheomalacia, dysphagia, and hypoparathyroidism. Thyrotoxic storm can develop preoperatively, intraoperatively, or postoperatively. In anesthetized patient, there is evidence of increased sympathetic output like tachycardia and hyperthermia. And awake patients, nausea, tremor, and altered mental status will also be present. Cardiac arrhythmias and progression to coma can occur if it is untreated. During thyroidectomy, if there is a thyrotoxic storm, it is important to stop the procedure, administer beta blockers, propylthyrosine, and sodium iodine, and steroids, and cooling blankets and cooled IV fluids to restore the patient's body temperature with careful monitoring of oxygenation. Dyspnea or stridor post thyroidectomy can be due to tension, hematoma, laryngeal nerve injury, or tracheomalacia. Postoperative bleeding is usually low after thyroidectomy. However, an expanding hematoma can cause airway compromise and asphyxiation. So it's important to remove all bandages and examine for neck swelling and evacuate hematoma, which might be causing an airway compromise. In mild swelling without much airway compromise, imaging studies may be helpful. And if there are airway issues without any apparent wound hematoma, a fibrocleptic laryngoscopy should be done. Recurrent laryngeal nerve palsy can present with hoarseness, breathing difficulty, dysphagia, aspiration. Unilateral vocal cord palsy may not manifest for days. Bilateral and complete palsies may manifest immediately. These are the various positions for vocal cords in recurrent laryngeal nerve palsy. It is important to note that the cadaveric position of the vocal cords is paramedian. So in a complete bilateral palsy, the vocal cords will be in paramedian position and it will have, the patient can get stridor as well as aspiration. Whereas if it is a bilateral partial palsy, the adductors being stronger than the abductors, the vocal cord is more in the median position, causing stridor. However, in the unilateral palsy, one of the vocal cords will be paramedian, the other vocal cord will move normally. And if there is if it is a complete palsy unilateral, so there will be problems related to aspirations. If there is a unilateral partial palsy, the position of the vocal cord is median, and the chances of stridor is more, as shown in the figure. Recurrent laryngeal nerve injuries is seen in around 10% and 2% for transient and definitive injuries after thyroidectomies, and its incidence is higher after lymph node dissections. Preoperative, postoperative, and intraoperative visualization is important. Indirect and fiber optic laryngoscopy can be used for assessment. Laryngeal electromyography can be used to differentiate vocal cord palsy from cricoadenoid joint dysfunction due to intubation. In unilateral vocal cord palsies, corrective procedures may be delayed for 6 months, and the most common procedure performed is medialization of the cord and reinversion. Bilateral vocal cord palsies, you might need an endotracheal intubation immediately because the patient might have stridor, followed by emergency tracheostomy, and a definitive procedure of chordotomy or arrhythmectomy might be required later. The external branch of superior laryngeal nerve can be injured in up to 28% of cases. Most patients do not note voice change. However, there can be mild hoarseness or decreased vocal stamina, particularly for high-pitched sounds, which is important in singers. In laryngoscopy, there is posterior glottic rotation to the paretic side and bowing of the vocal cord. Video stroboscopy, in which the vocal cord movements, the pitch is measured, is useful in determining the superior laryngeal nerve palsy. As also, laryngeal EMG of the cricothyroid muscle can show its denervation. A large goiter, there might be a tracheomalacia, which patients may be symptomatic preoperatively. The trachea may be deviated or compressed. It is always important to exclude recurrent laryngeal nerve of injury in a case of dyspnea and not just tracheomalacia. True weakening and disintegration of the tracheal wall is rare. Severe tracheomalacia requiring tracheal resection or tracheopexy is a rare phenomenon. Dysphagia is an important complication after thyroidectomy. It can occur in both recurrent laryngeal nerve and superior laryngeal nerve palsies because they are involved in the swallowing mechanisms. The recurrent laryngeal nerve supplies the cricopharyngeal muscles, the inferior constrictor phalanx, and some of the vagus nerves supplies the esophagus, thereby causing dysphagia if they're involved in thyroidectomy. Also, there is an anastomosis between recurrent laryngeal nerve and external laryngeal nerve, or the sympathetic chain, which can be involved in these disorders. Hypoparathyroidism can result after thyroidectomy due to trauma, devascularization, or removal. Preoperative and postoperative ionized calcium levels or total calcium in albumin is helpful, or measurement of PTH.
Dr. Priya, only 5 minutes left.
Yes, I'm finishing. Symptomatic patients in the perioperative period should be treated with calcium and gluconate, IV calcium gluconate, and they can be supplemented with calcium and vitamin D for 1 to 2 months. If calcium supplementation is required for more than 6 months, it indicates permanent hypoparathyroidism. There are certain recent advances in the management of patients. One is intraoperative nerve monitoring. In this, the endotracheal tubes have sensors for vocal cord movement, and the vagus nerve and the recurrent laryngeal nerve and the superior laryngeal nerves are stimulated intraop with a probe and assessed during surgery. A baseline is taken before surgery and also during surgery at various points. They're stimulated and identified. It is a controversial issue because most of the people say it is costly, not always available, and does not significantly reduce nerve injury as seen in many studies in experienced hands. The other recent advances in thyroid surgery is in the intraoperative location of parathyroid glands. One is methylene blue. Intravenous injection of methylene blue it is taken up easily by the endocrine tissue of the parathyroid gland and can help identification. The other is a 5-aminolabulinic acid. The parathyroid gland has a high mitochondria, so it can get selectively accumulated in the parathyroid gland, and fluorescence seen up to 1 to 8 hours after oral administrations. Phototoxic effects on skin and eyes have been reported, which is a concern. Indocyanine green fluorescence, it is proportional to blood flow, and as parathyroid possesses an above average vascularity, they're expected to exhibit a stronger fluorescence than surrounding tissue and can be used for identification of intraoperative parathyroid glands. Autofluorescence is also another unique technique of identification of parathyroid glands intraoperatively. In this technique, a near-infrared radiation around 800 nanometers that autofluorescence is emitted, and it is 11 times higher than that of surrounding tissue. This is a unique feature seen in parathyroid glands. So these are the references from which I have taken the various content as well as the diagrams and the figures in the texts.
Okay, thank you, Dr. Priya. Now I think the Dr. Shubham is ready. Dr. Shubham, can you share your slides?
Sir, Dr. Kamal Kataria has joined.
Yes, sir.
Yeah, I have seen him.
Good evening, Dr. Kamal Kataria. You are very much.
Good evening, Dr. Shazan. I feel sorry, actually, I was not able to join it. Basically, there was a link given to me, was the delegate link. So I tried many times, but I was not able to join. So now they have solved this problem. Now, I have joined it.
Okay, thank you. We are very sorry for technical problem from our side.
Dr. Shubham. Dr. Shubham?
Yes, sir.
Share your slides and go. Yeah, I can see it.
I'll start, sir.
Yeah, start it, press. Yeah.
Good evening, everyone. My clinical case is a 40-year-old housewife who is resident of Indore, came with a chief complaint of ulcer over the right border of tongue since 4 months, pain at the site of lesion since 2 months, and she had difficulty in speaking since 1 month. A patient was apparently well 4 months back when she noticed an ulcero-proliferative growth in the right lateral border of tongue, which was spontaneous in onset and gradually progressive in size. It was associated with pain which was insidious in onset and non-progressive. Pain was superficial at the site of ulcer, which was dull aching, and pain was radiating to the right ear. Pain aggravates on chewing and tongue movement and relief with medication. There was no history of discharge from the ulcer. There was a history of excessive salivation and difficulty in pronouncing certain words. There was no history in difficulty in swallowing, no history of change in voice, no history of difficulty in mouth opening, no history of loosening of teeth or trauma, no history of weight loss, no history of cough, breathlessness, or hemoptysis. Coming to the past history, there was no medical comorbidity like hypertension, blood pressure, and diabetes. There was no history of radiation exposure. Personal history, she was vegetarian by diet. She used to chew pan and betel nut for the past 20 years and quit 2 months back. Her bowel and bladder habits are regular, and there was no history of smoking or alcohol consumption. The family history, there was no history of pregnancy in the family. Coming to the examination part, on general examination, the patient was moderately built and nourished. The ECOG score was 0. She was conscious, cooperative, and well-oriented to time, place, and person. pulse was 80 beats per minute with a BP of 130 by 80 millimeter of mercury. Her height was 150 centimeter with weight of 50 kg, BMI of 22.2 kilogram per meter square. There was no pallor, icterus, clubbing, cyanosis, or pedal edema. So after getting the informed consent, patient was examined in a well-lit room in sitting posture. On local examination coming to the inspection, her mouth opening was adequate. She had poor oral hygiene with nicotine staining of teeth and halitosis. There was an ulcer-proliferative growth approximately 3 × 3 centimeter in size in the right lateral border of tongue, which was located at 2 centimeters from the tip of tongue, and it was extending posteriorly up to the sulcus terminalis and inferiorly up to the ventral surface of tongue. The growth is oval in shape, pink in color with ulcerated surface covered with fluff and creases. The edge was raised and everted. Surrounding tongue is moist and healthy. The tongue protrusion is present and floor of mouth and neck appears normal. Coming to the palpation, the inspectory findings were confirmed. There was tenderness present over the lesion. The mouth opening was 5 centimeter, and there was an ulcer-proliferative growth measuring 4 × 3 centimeter in the right lateral border of tongue, located at 2 centimeters from the tip of tongue and extending up to the sulcus terminalis and inferiorly up to the ventral surface of tongue with induration surrounding up to 0.5 centimeter around the lesion. The ulcer was irregular in surface, firm in consistency, and it bleeds on touch. Anteriorly, it had well-defined margin and posteriorly ill-defined margin, and the lesion did not cross the midline. The base of tongue and floor of mouth was free. The tonsillar region and posterior pharyngeal wall was normal. Coming to the examination of neck, there was a solitary node of size 2 × 1.5 centimeter in level 2 right side, which was round, hard, mobile, non-matted, and non-tender. The skin overlaying the node was normal. There was no other palpable node. The indirect laryngoscopy performed was normal, and systemic examination was within normal limits. Coming to the summary of my case, 40-year-old female, non-pan chewer, complaint of ulcer in the right border of tongue with pain radiating to right ear and dysarthria. On examination, she had an ulcer-proliferative growth of 4 × 3 centimeter in right lateral border of tongue, anterior two-third and solitary node of size 2 × 1.5 centimeter in right side level 2. So my probable diagnosis is carcinoma of right lateral border of tongue, and clinical TNM staging comes to T2N1MX.
Hold on, Dr. Shubham. Now, to start discussion from here with the examination, history and examination part. Dr. Ramanuj.
Hi, very good evening. Dr. Shubham, it was a good case, good presentation. Just a few points to add to this. Number one is that you said the patient had a history of consumption of pan, isn't it?
Yes.
Okay. What are the ingredients in the pan that are carcinogenic?
So, pan, it's made of betel leaf, the betel nut. The pan may contain lime, slight lime, and areca nut. The most common cause of carcinogenesis is because they form DNA adducts in the mouth, which cause DNA strands to break.
No, sir, Dr. Shubham, which component is responsible for these molecular changes? You directly jumped from the pan to the DNA duct. Which one?
So betel nut, sir.
Betel nut. Okay, because you see, Shubham, the question that the examiner is asking, please try to understand. The components of the pan are betel leaf, which induces a more alkaloids to get dissolved, and thus they make more carcinogen because those which were pro-alkaloids will get dissolved now. The betel nut contains aracholine, which induces vasospasm and induces a state of inflammation. The slaked lime also makes the alkaline environment and induces chronic inflammation. The betel nut also is responsible for producing submucosal fibrosis, which as such is a pre-malignant condition, because the rest of my examiners will be asking you findings on the oral cavity. So now you said the patient had intake of tobacco. What is the form of tobacco that the patient did take?
So, patient used to chew betel nuts, sir. So used to chew supari.
Okay, but your oral examination findings, you documented that there are tobacco stains on the teeth.
Yes, sir.
Okay, so did the patient take any form of chewable tobacco like gutka?
Yes, sir. She used to take gutka also, sir.
Okay, so that is something of immense importance that needs to be discussed, because examiners are going to ask you, how does tobacco become a carcinogenic factor for an oral cancer. So please remember, these are those parts of the history that you must mention very clearly. Like you have omitted out the place of tobacco chewing. Okay. Last one, the next one to say is that you have said the mouth opening is adequate. What do you mean by the term mouth opening is adequate?
In patients who have pre-malignant lesion like submucous fibrosis, there is a restriction of mouth opening. And in patients who have involvement,
what is the normal amount of mouth opening over which you will say there is no trismus? The interincisor distance should be more than 30 millimeters. Some people say 40, but we will go by 30 millimeter. The interincisor distance, if it is less than that, we define trismus by that. Okay. And the next one is that you have palpated the right-sided or the ipsilateral nodes. You said, what is the clinical nodal stage of the disease that you did comment?
Sir, on the examination of neck, we could find a single ipsilateral node, mobile node of 2 cross 1.5 centimeters. According to the revised TNF staging.
How did you know that swelling in the neck was a lymph node, sir? It could have been any other swelling also. It could have been a lipoma. It could have been maybe a fibroma. How could you know that was a lymph node swelling? I know it's not a very, say, or it's an unconventional question, but how did you know that neck swelling was a lymph node?
So the swelling was hard in consistency.
Okay, nice. Number 2. So the swelling was round in shape. The swelling was hard in consistency, smooth surface, I hope. And the swelling was located in relation with the sternomastoid and in the presence of a known primary in the drainage territory. A swelling, the most common cause of a lateral leg swelling is a lymph node, until and unless proved otherwise. Okay, so these are the clinical things. And last one is that there is nothing called as an MX in the AJCC 8th TNM. It's an N0. Did the patient have any history related to a human papilloma viral infection or suggestive of that? Did you take a history regarding that?
No, sir, I didn't ask for that.
Okay, so please do take a history about an exposure or of any partner having a history of any human papilloma viruses, because this has been radically changed in the AJCC 8th edition. Okay, so this is something that you should keep in mind.
Well,
okay,
thank you.
So with this, thank you. That is from my end. Thank you.
Rajdeep?
Yes, sir. Thank you, sir. Now, Shubham.
Yes, sir.
So the points on the history were covered. Now, what are the features of advanced disease in a case of CA tongue?
In case of advanced disease, the muscles of the intrinsic muscles of tongue are involved. There may be a perineural invasion of the nerves. And if the nerve supplying the tongue site, like the chorda tympani, the lingual nerve, or the glossopharyngeal nerve on the posterior one third of the tongue.
You're talking about the sensory supply, okay?
Yes, sir. And if the tumor is spreading up to the posterior, involving the posterior one third of the tongue, it is considered a high-risk tumor.
No, I was talking about the clinical features. So what are the clinical features of advanced disease?
So in advanced
one is a neck node. You have already mentioned neck node is one of the clinical features. What are the other features?
So the mouth opening will be restricted. There will be inability of protrusion of tongue.
Protrusion of tongue, inability, and something else? Classically, the tongue is said to be deviated. Tip
it is deviated to one side.
Because one side there is restriction and the normal side pushes it forward. So deviation is towards the side of the growth.
Toward the side of the growth.
How do you assess the posterior third of the tongue?
So to assess the posterior third of the tongue, we have to use a tongue depressor. And we can also do indirect laryngoscopy or direct laryngoscopy to see the posterior third of the tongue.
You can palpate it also. First is palpation. You can't see the posterior third of the tongue. So you can either palpate it or you have to use an ideal indirect laryngoscopy. Right. So if the patient is saying that he has got some sensory loss in the chin or the lower lip, what does that signify?
So that signifies the involvement of the sensory nerve, which is done by the lingual nerve, which is a branch of the trigeminal nerve. If that nerve is involved, there will be sensory loss of the.
I thought you. I said numbness of the chin, lower lip.
Sorry.
That's not a lingual nerve, inferior alveolar nerve. So that's an advanced disease. Okay? So if the nerve also get involved. Similarly, if the hypoglossal nerve gets involved, which is the motor nerve, that's an advanced disease. Do they have ear pain?
Yes, sir. They can have a radiating pain to the ear.
Why?
So because the sensory supply from the anterior two-thirds of the tongue, they relay in the aortic ganglion, and also the chorda tympani, which is a branch of facial nerve, which carries a taste sensation from the anterior two-thirds. They also supply the inner external ear. That's why they may have a ear pain, radiating pain.
Okay, fine. Right. So this was about the advanced disease. You said the patient does not have any history of smoking or alcohol consumption. You have mentioned about betel and the tobacco use. Any other factors, risk factors?
So any dentures, they may have chronic ulcers, which are risk factor.
Sharp tooth also.
Sharp tooth.
And another S left. You may not find it commonly nowadays. Syphilitic glossitis.
Syphilitic glossitis, yes, sir.
Okay, these are.
Thank you, Dr. Asdeep. Dr. Sanjeev Singla is there? Singla, sir?
Yeah, I'm here.
Yeah.
So this is a very typical case and lot has been covered. So in history, what all history you would like to take to rule out the distant spread on history, not on investigations. In other words, where all do the metastasis from cancer tongue go, and how do those metastases present?
So the most common site of the metastasis is cervical lymph node. So in the history, they will give a history of swelling in the neck.
That is one, and you have already talked about the lymph node. Any other?
Then they can also spread to the lungs, which may cause hemoptysis or breathlessness in the patient.
That must be mentioned in your history, that there is no history of hemoptysis or breathlessness. Very good.
That I've mentioned, sir.
Yes. And now tell me, what kind of problems happen to these patients who have got such large, also proliferative lesions in the mouth? What happens to their eating?
Sir, because of the pain and the ulcer, they used to eat less, their appetite is suppressed.
So, in fact, what is the so when you say that they eat less and then they lose weight also, they become cachexic also.
Yes, sir.
So that is one point on history which you should again take with a pinch of salt when you say there is no history of weight loss in a patient who has a 3x3 ulcer proliferative lesion as the best big as the one we are seeing. Then eating will become a problem. Any chance of aspiration? Do they have a lot of saliva?
Yes, sir. They do have a lot of saliva because of two reasons. Because of the ulcer, there is irritation of the mucus, and the mucus glands secrete more saliva. And because of the pain in swallowing, they used to retain the saliva in their mouth.
So, history of recurrent attacks of LRTI, aspiration and pneumonitis, is also a very frequent feature in these kind of patients. These are indirect things which happen to them and should be brought out in history. Thank you.
Dr. Kamal Kataria. Any point you would like to make in the history and examination part of it?
So you told in your history there is no family history of such growth over the tongue. Is it possible such swelling can be part of some syndrome, some similar swelling? Because on the basis of history, you have not examined the patient.
Yes, sir. There are some familial cancers which are related to the oral cancer. like in Bend syndrome.
Yeah, very much right. Sometimes mucosal neuromas in Mann syndrome, they may mimic like a cancer. Anything else?
And there are other familiar cancers also which are related to oral cancer.
Okay, Subham, thank you.
Dr. Priya?
Can you, were there any pre-malignant lesions in the oral cavity, and can you name them and how did they look like?
A few pre-malignant lesions include like the leukoplakia. They are the white patches which present on the oral mucosa and the tongue, and they can't be peeled off. Then there can be erythroplakia, which are red patches, and there can be oral submucous fibrosis. Then there can be speckled leukoplakia or speckled erythroplakia also.
Okay.
What is the significance of HPV? Like Dr. Ramanuj said, what is the significance of HPV in oral cancers?
HPV is also considered a risk factor in causing oral cancers.
What is the significance? And is there any difference between anterior tongue and posterior tongue cancers related to HPV? HPV is, in HPV cancers, they are responsive to chemotherapy and radiotherapy. So especially posterior tongue cancers with HPV, you can treat them well with chemotherapy and radiotherapy. That's why they're staged differently in the HSCC classification.
Hey, Dr. Priya, you have to tell him whether HPV is a risk factor for carcinoma tongue or not. Let us confine ourselves to the discussion to the carcinoma tongue.
HPV is a risk factor, and HPV is a risk factor, but HPV of the carcinoma tongue, the anterior tongue, is not staged differently, but HPV related malignancies of the posterior tongue are staged differently in the HSCC because they are more responsive to chemotherapy and radiotherapy, and they have a better prognosis.
Okay, Dr. Shadan, you have any question?
Answers.
Yes, sir. Just few questions related to the history and examination. You answer about the pain, referred pain. I think the afferent is lingual because that is sensory for anterior two-third, and the efferent is auriculotemporal that supplies the tympanic membrane anterior part of. So that should be taken. And in a history, you said no history of difficulty in swallowing. Did you ask about any change in food habit? Because sometimes what happened, rather than eating solid, they change their habit to eating semi-solids, and so they adopt rather than actually not having any problem with the swallowing. Did you ask about that?
Yes, sir. There was. I asked about the solids and liquid diet. She was taking the same diet as before because the pain was not that severe that she could reduce the diet.
Okay, very good. What you said about that there is the induration is present, and what should be the ideal position when you should be palpating for induration, and what is the reason for this induration?
So that induration is also due to the cellular proliferation. That because the cells are proliferating in that manner, we find induration in periphery of the ulcer.
Very good. There is some mucosal infiltration, or it may be because of sometimes desmoplastic reaction. And ideally, when you are looking for induration, you should keep the tongue in a resting position, because if the muscle get taut, often the induration felt form. So if the tongue, most of the tongue is already in action, muscle is taut, then you may miss it. And you did not mention whether it is crossing to the midline. You just mentioned that it is coming to the up to the anterior part. Okay, sir. That much from the history, sir. One more question, may I allow to be asked? What are the important thing you would like to see related to the teeth, other than loosening of teeth? I think loosening of teeth, you just ask to exclude the involvement of mandible, isn't so? Yes. But other things you should be should look for when you are examining a patient with oral malignancy, that will help you in deciding the management part.
Not sure about the manner, but ill-fitting teeth and sharp teeth, or patient who have used dentures before.
That is related to etiology and the progress of the disease, but you should also be careful whether the patient has any caries that has been actually filled up. So it will help you to decide if you are doing CT scan with artificial teeth or cemented. So that will cause a lot of artifact. And before radiotherapy, you should be sure that the dental hygiene and caries should be removed. And other thing, will you be happy if your patient is edentless, or you will feel bad?
I think I'll be happy because in the patient have
Yeah,
teeth.
you should be happy because you get a easy access. It gives more space, and the soft pulp can be pressed, so it gives good access. So that is all from my side.
Subham, can you quickly enumerate the investigation 1, 2, 3, 4 you need to do before you? First, tell me, will you like to operate upon or use some alternatives?
So this I like to operate upon.
Okay, fine.
Since this
investigation will you like to do 1, 2, 3, 4, 5?
So for the confirmation of diagnosis, I'll go with the wedge biopsy or the edge biopsy of the ulcer.
Okay.
Then for the staging and for getting the lymph node status, I'll do an MRI of the head and neck and with the USG of the neck. Then I'll plan my surgery according to that. And since this is a T2 lesion, I'll go with the surgery and followed by radiotherapy.
T2, how did you measure the depth of invasion in your case?
The depth of invasion was measured clinically because the extent of invasion was 0.5 mm. And in the histopath report, I'll confirm what was the depth.
Okay, in the proliferative growth is very difficult to, it's not always histopathology. You can get the MRI done and you can find out the depth of it. Anything else you want to do?
Then because they're lymph node positive, I'll go with the modified radical neck dissection of the right side.
Okay, fine. Now it's over to Ramanu, sir.
Right.
Management part.
Now, so as we have discussed up to this much, the only point of contention is that we usually do a CT from the skull base to the neck. You have added an MR. Okay, that's one point. But now I'll not be fiddling on that area. Now, as you have said that, what is the surgery that you are going to do for the tongue, the primary lesion?
I'll do wide local excision.
What is the mistake, sir?
0.5 centimeter.
Okay. And what are the vessels that you are likely to ligate so that hemostasis is attained?
I'll ligate the lingual artery, sir.
Okay. And why ligating the lingual artery? Because you are already doing an ipsilateral comprehensive neck dissection. We have said an MRND. We use the term comprehensive neck dissection, which encompasses both RND and an MRND, which is a much more better term than to use MRND directly. So you usually ligate the lingual artery because that side is an hemiglossectomy that needs to be done on that side with at least 5 millimeters, preferably with more margin. How do you cover the defect in the tongue, or how do you go for a reconstruction after you have done a hemiglossectomy?
We can use a radial artery forearm flap.
Come on, doctor, you are not thinking, sir. Radial artery forearm flap, sir, you are not going in for a mandibulectomy. Are you planning to do a mandibulectomy also in this patient?
No, sir, because there are no signs of movement of mandible.
Doctor, please think before you answer, sir. You are trying to create a gap in the tongue. So what can be the tissues that can be helping you to do that? What is the most simplest thing that you can do? If you like to have a skin graft on that area, do you think a skin graft is a good choice or a bad choice?
Bad choice, sir.
That's a bad choice. The reason being? Okay. So the reason is that an active saliva extrusion does not allow the skin graft to remain, but still some people do that in the hope that some amount of take will be there. But there are various techniques like rotation of the tip of the tongue to cover with that area, or you can need a pedicle, even a myocutaneous flaps are used. Okay, radial forearm flap will usually not be required in this patient. Right. And so this is from my end, sir. Thank you.
Dr. Asdeep?
Dr. Shubham, let's talk about the neck dissection now. So what type of neck dissection would you like to do?
Sir, I would like to do comprehensive neck dissection of the right side.
Okay.
Then
what are the structures you will be removing?
I'll be removing level 1 to 6 lymph nodes. And
okay, 6 also? Where is the level 6?
Say the pretracheal lymph node.
The central compartment.
Central compartment.
So those are not routinely removed.
So I'll remove 1 to 5.
1 to 5. So which are these? 1, 2, 3, 4, 5. Which are these levels? Where are they located?
So level 1 is submental and submandibular.
1A, 1B. Okay.
1B. Then level 2 are upper jugular. They are above the hyoid bone in the anterior triangle. Then level 2 are deep cervical. Then level 3 are lower jugular. Then level 4 and 5 are the posterior triangle. Oh, sorry, level 5 is the posterior triangle.
Thodi gadbad hogi. 2 you said twice. So 2, 3, 4. They are present along which vessel? 2, 3, 4.
They present on the external jugular vein.
Level 2, 3, 4 lymph nodes are present along the which jugular? The internal jugular, not the external jugular.
Thank you, Dr. Rajdeep. Dr. Singla?
Okay, so tell me something. If supposing you had done an FNAC and this lymph node turned out to be reactive,
yes, sir.
Will your management change?
No, sir. I still go with the neck dissection.
Yes, very good. In fact, that is one of the reasons why FNAC of the neck has been given up, because regardless of the result, the decision to do a neck dissection depends upon the clinical presence of a node.
Dr. Shubham, with this, we wind up here because we are running short of time, and thank you, everybody. Now, the last one, there is a lecture by Dr. Shadan on lymph node dissection. Dr. Shadan, are you ready?
Yes, sir. Very much, sir. Thank you. Please allow me to share my screen. Okay. You can edit screen while other participants sharing. Okay, now I think I will be able to do it. Desktop. I want to go to desktop. Where is my presentation? As my slide is visible, sir?
Yes, visible.
Thank you very much, respected chairperson, organizers, and dear student. I will be talking on the neck dissection, the operative part mainly, and I will try to cover the relevant topics commonly asked in exams, DNB and MS exit exam, and I hope by the end of this lecture you will be able to cover the most of the topic that are commonly asked that are related to the neck dissection in your exams. So we all know that squamous cell carcinoma of head and neck is the sixth most common cancer in the just give me 1 minute, so I'm not able to see all of my screen. Okay. Sixth most common cancer worldwide, and it is also approximately 30 to 40% of all cancer sites in India. Metastasis to cervical lymph nodes are seen in about 40% of the cases, and it is the single most important factor that affects the prognosis, and it reduces the 5-year survival by 50%. The management of cervical lymph node is an important component in overall treatment plan for patients with squamous cell head and neck cancer. And we all know that neck dissection in its various forms is the standard surgical treatment for clinical as well as subclinical metastasis to the cancer of the neck. The sternocleidomastoid muscle, divide the neck into anterior and posterior triangle on each side. The posterior triangle consists of large occipital part, which is again subdivided into large occipital and small subclavian part by the inferior belly of omohyoid. And similarly, in anterior triangle, it includes the submandibular and carotid triangle, and they are separated from each other by a medially into we have a triangle called as submental triangle and muscular triangle inferiorly. The cervical lymph nodes are classified according to the system developed at the Memorial Sloan Kettering Cancer Center in year 1930s. This system divides the lymph node on the lateral aspect of the neck into 5 nodal levels, 1 through 5. So in addition, the lymph nodes in central compartment are categorized into level 6, and those in anterior superior mediastinum, not shown in this diagram, and as a level 7. So based on the patterns of lymph node spread from various primaries, the level 1, 2 and 5 nodes have been further subdivided into A and B subdivision. So now we have level 1A, that is submental group of lymph nodes, submandibular, that will be 1B, and similarly the upper jugular level 2 has been subdivided into A and B depending upon whether they are anterior or posterior to the spinal accessory nerves. Then we have the mid jugular group, level 3, lower jugular, level 4, and in posterior triangle that contains the level 5 lymph node. The lymph node is subdivided into A and B depending upon whether they are superior to spinal accessory nerve and or below the spinal accessory nerve. We all know the central compartment lymph node that are situated between the two carotid and vertically between the hyoid vein and supraesternal notch are level 6 lymph nodes. A uniform staging system for regional metastasis to cervical lymph node was established by the AJCC. And this staging system for squamous cell carcinoma has recently been updated in year 2017. So we have currently the 8th edition of TNM staging system. This system is based on the size and the number of enlarged lymph nodes as well as presence and absence of extranodal extension. In exams, you are expected to remember this nodal metastasis, and it is common for most of the upper aerodigestive squamous cell carcinoma except a few like nasopharyngeal and HPV positive and thyroid malignancy that you have to read separately. So based on this staging system is based on the number and size as well as presence and absence of extranodal extension, and based on all these 3 factors, the lymph nodes are clinically staged from N0 to N3. So what is the neck dissection? The term neck dissection refers to a surgical procedure in which the fibrofatty contents of the necks are removed for the treatment of cervical lymphatic metastasis. And the most of the credit for the neck dissection as a curative operation for cervical metastasis belong to George Washington Cryle, who described the classical radical neck dissection in year 1900, and this is also sometimes named as a Cryle's operation. And however, because of removal of extra lymphatic structure, this operation was not without morbidity, and it resulted in a cosmetic deformity and dysfunction of shoulders movement. And this led to development of what we call as modified radical neck dissection or functional neck dissection by Oswaldo Suarez. And selective removal of regional lymph node group based on predictable pattern of lymph node spread was later popularized by Valentin. And in 1985, Byers described the terms anterior and supraomohyoid neck dissection. Because of so many different names, it created a lot of confusion. So therefore, in 1991, the American Academy of Otolaryngology and Head and Neck Surgery published an article, and they classified the neck dissection into comprehensive and selective. And this was later updated in year 2002 and 2008. and it has become universally accepted and is currently endorsed by most of the onco surgeon and head and neck surgeon all over the world. So what the basic principle of this classification was, the radical neck dissection is considered to be the standard procedure, and all other procedure for cervical, all other procedure represent either one or more alteration of this procedure. So if we preserve one or more non-lymphatic structure that we remove in radical neck dissection, it will be called as modified radical neck dissection. And if it involves the preservation of one or more lymph node group levels along with the extra lymphatic structure, it should be called as selective neck dissection. Likewise, if you are removing additional lymph node groups or non-lymphatic structure, it should be called as extended neck dissection. So here is the slide that is showing the classification system that was there in 1991 and the recent modification in 2001. So as per earlier classification, we had a radical neck dissection that we know that involved the removal of level 1 to 5 lymph node along with the removal of sternocleidomastoid muscle, internal jugular vein and spinal accessory nerve. And to avoid the post-operative complication and dysfunction, there was a modification. So if you are removing all the 1 to 5 lymph node along with the preservation of either of these structure, it should be called as modified radical neck dissection. And in current classification system, they have proposed that you should write, rather than writing type 1, 2 and 3, you should mention the structure that have been preserved along with the you should mention the modified radical neck dissection. Similarly, earlier the term were used was supraomoid, lateral and posterolateral. In supraomoid, we all know that we remove the level 1 to 3, and if it extended, we also remove level 4. So in recent classification, they have said that you should write the sentinel lymph node dissection and use the parenthesis to denote the level that have been removed. As per the literature, there is no accepted minimum number of lymph nodes that we should be considered as the sufficient for an adequate neck clearance. The target should be all the target level of all the fibrofatty tissues and lymph nodes should be cleared from whatever level you are planning in your neck dissection. But in a study that is published in year 2017, for supraomoid neck dissection, the author has concluded that 18 nodes are good to detect the occult disease in the neck dissection. So as far as indication is concerned, the main indication we all know is when you have clinically positive operable lymph node, and also in clinically N0, depending upon the tumor factors, when there is a high likelihood of occult metastasis, as well as based on the institutional protocol. So the major contraindication for the neck dissection are the patient who are unfit for general anesthesia, or if there is associated comorbidity, a tumor neck nodal status is such that it is involving the surrounding vital structure that cannot be usually removed, with either cannot be removed, or if it will lead to significant morbidity like skull base or carotid vessel. Similarly, if the disease is metastatic or uncontrollable primary, there again it does not make it useful to do the neck dissection. As far as the patient preparation is concerned, the neck dissection is performed under general anesthesia. And as already Madam discussed, in thyroid position, it will be supine and with the reverse Trendelenburg position, 10 to 15 degree. And you have hyperextension at the neck, and it should be rotated to the opposite side for proper exposure. This is the position that we use in one of our patients. What should be the position of the incision? Historically, we have a different named incision, but the current literature favored the use of single incision that should be placed along the existing neck skin crease. So it doesn't mean that the other incisions cannot be used. So again, it will depend upon the preference of the surgeon and the status of the neck node, as well as we should also consider if you are involving the primary tumor resection, and also the nature of the reconstruction that is planned. So skin crease, the incision can be modified and can be different types of incision can be used. So this is the incision we have used, also called as modified Schwebinger incision in one of our patient. It has 3 limbs, but one should be careful. It provide a very good exposure, but one should be careful in vertical limb. It should touch the horizontal incision at vertical right angle, and also is the vertical limb should be away from the carotid pulsation. So surgical step, I will discuss it in the video, but the main step is the raising of the skin flap. While raising the superior skin flap, you should be careful not to injure the marginal mandibular nerve. Once the exposure is achieved, you should try to identify various important landmarks, also called as lighthouse, that help us in neck dissection. And then depending upon the surgeon's choice, the neck dissection can be started from level 5 to 1. If you are the surgeon is comfortable, reverse from level 1 to 5 will be done. And again, toward the end, you should secure the hemostasis, and skin is closed in 2 layers, first subplatysmal layer and followed by the closure of the skin with the suction drain. So important post-operative complication that one should be careful is, of course, the cosmetic deformity. And if it's a radical dissection, there is a significant shoulder dysfunction. On the left side, one should be careful not to injure the lymphatic ducts, that it can lead to a chylous fistula formation. And of course, if there is dehiscence and wound infection, and if there is a salivary fistulation, there is a risk of carotid artery, a major artery rupture, that is potentially a lethal complication. So in this video, I would like to share about the anterior border, and this is supraesternal knot. So this will be a lower border of boundary of anterior triangle, anterior border of sternocleidomastoid, midline inferior border of. So what we have in the anterior triangle, and there are 4 more triangles in that styloid muscle. So there are 2 triangles superior to styloid that are called as supraoid triangle, and 2 triangles inferior. I hope the audio is audible in the video. Submandibular triangle. This is the anterior belly of digastric.
It's audible. It's audible.
Thank you for replying. Another triangle is submental triangle that will be between the 2 anterior belly and hyoid bone. And then we have carotid triangle that will be formed by anterior border, sternocleidomastoid, anterior, posterior, superiorly, styloid muscle, posterior belly, and this is the anterior, inferiorly by the anterior border of superior belly of omohyoid. Superior that form the carotid triangle, and this is the most important triangle. We can see most of the vessels and the basic difference structure along with the jugular lymph node. Border for the level of lymph node and the triangle is there is another triangle level of lymph node is the posterior border of sternocleidomastoid, that is superior belly of omohyoid, and this inferior laterally by sternocleidomastoid. That will be the muscular triangle. Posterior triangle. Posterior belly, posterior border of the sternocleidomastoid, and so this is the trapezius muscle, and inferiorly by the posterior belly of omohyoid that divides the posterior triangle into 2 parts: small supraclavicular part and large occipital part. This is one lymph node, and one is again divided into 1A and 1B. These are the carotid triangle that we have opened. This is carotid artery, internal jugular vein, and this is basically answers. So they lie behind here. So they will be here. So level 2A and 2B. 2A will be anterior spinal inferiorly will be 2A, and posterior superiorly will be 2B. Hyoid bone. Then from hyoid bone to cricoid will be level 3, and below that will be level 4. That is the lower jugular group of lymph node. 3. And the posterior level 5 group of lymph nodes are here. That will be 5A and 5B, depending upon their relation with the spinal accessory nerve. This is a small video about the operative steps I would like to share. I hope I am not overshooting the time allotted to me. You can see the platismal. So the flap is raised, subflap is. One should be careful during the elevation of the superior flap as not to injure the marginal mandibular nerve. There are few steps that have been described to preserve the injury of this. One is to, of course, subplatismal, and it should be skin incision should be 2 centimeters at least below, and then you can open the anterior capsule of the submandibular gland. And the third technique is called as Hale Martin technique. You can see the marginal branch that we have done in this case. But we are going to take children. Common facial aim is dilated and the flap is raised along with it. Okay. And then you can see the marginal mandibular nerve now. But this vein and this will all go up. See there lot of different. Chalo, दिखा दो थोड़ा पास से. Expand दो. ऐसे भी है. This is sternocleidomastoid, the external jugular, and here we have greater auricular nerve. So that is the R point that we commonly say. And this is the upper and anterior belly of digastric. We have reached to the midline. Anterior superior belly of femoid. Yes, he can show us that this is the spinal accessory nerve. Even sternocleidomastoid, and this is the spinal accessory nerve that is coming like this. Okay. It divides there. So this is the spine with R closed off. This is the spinal accessory nerve that is going into the trapezius, and these are the brachial plexus. And here is the phrenic nerve, lateral to medial. So this is the layer of prevertebral. And these are level 5. To identify the important structure as not to injure. All the neurovascular structure are below the prevertebral. So not in the posterior triangle that we have dissected. And this is the second C. Again, we are brachial plexus, and this is the phrenic nerve. So when we lift it, this is a landmark for. So the lower end of the internal jugular vein can be identified just below the posterior to anterior. Now we are dissecting level 4. You can see this is the ansa cervicalis. Can you see? Different यहाँ पे vagus nerve, and this is lymph node. And you can artery. Okay. This is the transverse cervical arteries, vessels. And here is the what we are seeing is the spinal accessory. So that is above this will be level 2. Above this will be level 1, 2B, and below will be level 2A. 2A. So we have to remove the lymph node that we have already dissected. It is going behind the below the. Posterior belly of femoid. That is a very important landmark. Most of the important structure goes below. This is between the two division of carotid. You will see the posterior belly of hyoglossus. So we have cleared, and here again, let me show you. आने दो. इधर देखो. उसको रखो. ठीक है. This is the spinal accessory nerve. So we have this above this will be level 2A and below is level 2B up to the horizon. So we have cleared this and this also. Now after that we will remove level 1B and 1A and then we will be done. Here दिखाओ एक बार. This is anterior belly. The opposite side this will be submental triangle, and here we have a posterior belly, and this is styloid muscle, hypoglossal nerve. In current classification, they have used styloid as a landmark because it is more easily. You can see it has come like this. Below DT remain deep to the posterior belly of digastric. So this is anterior belly, and this is hyoid. And इसको थोड़ा करो ऊपर. Myloid muscle. That, and we can see here is lingual nerve, and this is the term. This is the term. Yeah. Now we have clear 5A, 5B. This is accessory nerve, spinal accessory. This is the phrenic, and these are the brachial plexus. And descending hypoglossi over this, and this is the internal jugular, और इसके साथ ये पीछे जो है vagus भी है, carotid, external branch, internal branch. We have clear all this. We have 4, 3, and 2, 2A and 2B. This is spinal accessory nerve. and 91B have 1A submental triangle. So this is after image after the closure. And we all know that there has been increasing use of robotic, especially for oropharyngeal cancer, transoral robotic surgery. And as mentioned, there is use of minimal access surgery for the thyroid also. So they have started using this newer minimally invasive technique for basically neck dissection also. But as far the current status is concerned, it is still evolving. In the latest literature that was published in year 2020, the author concluded that there is a lack of objective data on functional outcomes, and it warrants the need for further investigation on robotic dissection. So it is not, as per the current status, we cannot say it is inferior or superior. It is still evolving. And if somebody is comfortable, it is all welcome. And I think it is the future. Then we don't have to worry about the different types of neck dissection. So that is all from my side, sir. Thank you. I think I will conclude my presentation now. Thank you very much. Sir, you are muted. You are muted.
Thank you, Dr. Shadan, for the elaborate description of neck dissection. With this, we wind up our session here, and I would like to thank again the chairpersons, Dr. Ramanuj, Dr. Rajdeep, Dr. Sanjeev Singla, Dr. Kamal Kataria, Dr. Priya Hajra, and Dr. Shadan. Now, thank you very much, and I'd like to see you again next year. Thank you, everybody, and over to the organizers.
Sir, abhi 3 din aur bache hain, sir.
Thank you so much, sir, and all the chairperson for the wonderful session. And it was indeed a very informative one. With this, we'll come to an end of the session regarding the case presentation. Now we'll begin with the session on radiology. And may I invite for this session as chairperson, Dr. Pradeep Garg. Sir, are you there?
Yeah, I am there.
Yeah, Professor PGIMS Rohtak. Dr. Shalabh Gupta. Dr. Shalabh Gupta is Professor SMC Ghaziabad. Dr. Manoj Dukania. Dr. Manoj Dukania is a senior surgeon from RML Hospital, New Delhi. And myself, I would be there in this session. And now may I have the pleasure of inviting Dr. Nikhil Talwar, who is a professor of surgery from Lady Hardinge Medical College. And his talk would be on plain X-ray, chest, abdomen, and extremity. Over to you, Dr. Nikhil, please.
Good evening, everyone. I hope my slides are visible, Dr. Gyan.
Yes, they are very much visible. Yes.
Good evening, everyone. It's always a pleasure to be a part of the CME program. And we would be talking about a very important topic for surgeons. And as I always say, that good surgeon is the one who is good at reading the X-rays too. And radiology vivas are an important part of the exam as well. So let's get started all right away. Just a sec. Yeah, there was some problem with my keyboard. Now I'm using the mouse. Right. So how do you approach the X-rays when they are given to you in the examination or they're projected to you? So first is to identify the site of the X-ray, whether this is a chest X-ray, X-ray abdomen, X-ray QB, X-ray of the extremity, what is the view, whether any contrast has been used or is it a part of the study. Sometimes one X-ray may be given to you, which may be of a vesical calculus, which showing a radiopaque shadow in the pelvis. And then a lot of people I've seen, good students tend to confuse vesical calculus with a barium enema or maybe a cystogram film with a barium enema. So be very sure to ask for other films in the study if they are there. If you're not certain whether contrast has been used or not, you can always ask whether this is a plain or a contrast film or whether there are any subsequent films also. Then begin with the findings, begin with them in a methodical manner. I'll be talking about the method, then reach your diagnosis, and then be ready for the viva questions. Don't be in a hurry to reach the diagnosis. Enumerate the findings in a methodical manner and you will reach the diagnosis automatically. So we'll be beginning with a chest X-ray. Now in chest X-ray, most common view that we do is a PA film. And very commonly you are asked, how do you compare AP view with a PA film? Now very briefly, I'll tell you, in a AP view, the heart is away from the X-ray film detector. So naturally the X-ray beam is going to diverge more and the heart size on an X-ray is going to appear larger. As you can compare here, on the left side, you see that the image has been acquired by a mobile X-ray unit in the resuscitation room. The patient is supine and this is a AP view. Now in this clearly, as in the yellow arrow, the heart appears enlarged and the superior mediastinum also appears to be magnified if you compare it with the same patient whose X-ray has been done in the next morning in a PA film. Also in a X-ray of a chest with an AP view, the scapula are not retracted laterally as in the red arrows and they seem to be projecting on each lung. While in a PA film, the patient is basically hugging the X-ray detector so that the scapula are retracted. Now, when you approach a chest X-ray, you approach it in a systematic manner by the mnemonic A, B, C, D, and E. Now, A, you look at the airways, the trachea, the lungs, the pleural spaces. Then B, you look at the bones, the clavicle, the ribs, the scapula, also at the head of the humerus. Sometimes there may be a trick question that the patient has secondaries in the lung as well as osteolytic lesion in the head of the humerus. So always look at the bones. Then C would stand for the cardiac shadow, the shadow of the great vessels, the arch of the aorta. Then D for diaphragm. Look at the costophrenic angle, the cardiophrenic angle, any elevation of the right or the left dome of hemidiaphragm, or whether there is any free air under the dome of the diaphragm. Then E would stand for any emphysema, any subcutaneous emphysema, if it is there in the skin or the fatty tissue, and everything else, including the foreign bodies. Now we begin with our X-ray series of the chest. And in this X-ray, you can clearly see, as in the block arrows, the mediastinum is pretty wide. In the small yellow arrow at the top, you see that the trachea is deviated to the opposite side, and this is due to a large pneumothorax that is there on the right side, and there is a complete lung collapse, and there is a hyperinflated film. Now, in this X-ray, I hope you can appreciate that the trachea appears central, and if you look at the bones, the clavicles appear okay, but there are multiple rib fractures. All right. And if you look carefully, there is subcutaneous emphysema on the right side. Now, in the same patient, a chest X-ray has been done after insertion of an intercostal drain. This is the X-ray film after a couple of days. There are multiple rib fractures, as was noted in the earlier X-ray. The mediastinal shift has comparatively resolved. Also, you can see that what went unnoticed earlier was a right clavicular fracture in that X-ray. It was there in this X-ray. Because in the previous X-ray, there was no displacement. Now in this, there is clearly a right clavicular fracture also associated with subcutaneous emphysema. Now, subcutaneous emphysema, if it occurs after the insertion of a chest tube, always look at the holes of the chest tube. In the X-ray, the holes may be out. As you can see here, the chest X-ray is slightly inside. So sometimes what happens is you tend to pull out the chest tube after the X-ray, but not noticing that the holes may go into the skin and the subcutaneous tissue, resulting in a subcutaneous emphysema. Now, this is another classical X-ray in which you look at the airway. Here you look how the trachea is deviated to the left side. Then if you look at the B, the bones, there is tremendous scoliosis of the spine. At the same time, if you look at the lung fields, the right lung fields appear normal, but on the left side, there is a left upper zone consolidation. So this patient was basically a patient of pulmonary COX with old healed COX of the spine. Then this is another X-ray in which you appreciate that there is a complete whiteout of the right zone of the lung on the left side, on the left zone on the left side, on the right side. So the right film shows a complete whiteout of the lung. The costophrenic angle is not visible at all, although there is not a clear air fluid level, but there is a complete whiteout. So this is a massive pleural effusion. On the left side, the X-ray that is there, this is also a massive pleural effusion of the left side, and the trachea appears to be deviated. You can appreciate here that the right bronchus is getting more deviated. There is some amount of mediastinal shift also. Then sometimes you may be given films which may require a careful look. Now in this film, if you look, that this X-ray has been performed following the insertion of a right internal jugular central line, that is the yellow arrow. And it shows one of the potential complications of the central line insertion, that is a large pneumothorax that is there. If you look here, near the red line, so there is a large pneumothorax. Now, edge of the lung, the pleural line is indicated by this red arrow. And also notice the increased lucency of the right hemithorax and the absence of lung markings in the periphery of the hemithorax. So this will confirm that this is a pneumothorax. Then if such an X-ray is given, you may be asked in a viva, or you may be asked to enumerate in your spotting what are the potential complications of central venous line insertion. And then you will have to enumerate vascular injuries which may result in a hemothorax or a hemomediastinum, long-term complications like thrombosis, malposition, or a catheter fracture or a displacement. So be ready for associated viva questions also when an X-ray is projected to you. Now this is another classical X-ray in which a cervical rib is seen above the first rib. Then in this X-ray, if this X-ray is given to you, you will talk about that this is an X-ray of the soft tissue neck, AP and lateral view, along with X-ray of the upper chest, although the chest exposure is not adequate. Obviously, you see a large shadow, a soft tissue shadow on the right side, and a small soft tissue shadow on the left side in the neck, which is deviating the trachea, which is pushing the trachea to the left side. And here in the lateral view also, you can see that there is some amount of tracheal compression. So this is a large thyroid mass, which is pushing the trachea to the opposite side. Then you may be given a chest X-ray film in which you will have to assess the lung fields. So if you look at the lung fields here, the bones, the airway appear normal. In the lung fields, if you see, there are multiple coin-like secondaries, coin-like lesions, which are most likely secondaries, and these are known as cannonball pulmonary metastasis. Also, you can see a central venous catheter in place. And in this case, these lung secondaries, bilateral lung secondaries, were from a breast primary. Now, cannonball pulmonary metastasis may be seen in a variety of conditions. As I said, in the breast, it can be seen in the prostate also. Now, pulmonary metastasis typically appear as peripheral rounded nodules of variable size, which are scattered throughout the lungs. Now, at the same time, a pulmonary metastasis may be single. And as you see here, on the left, on the right side of the screen, a pulmonary metastasis may be single, and this solitary pulmonary metastasis is from a patient in a colorectal carcinoma. Then you may get a film like this, in which there is a normal radio-opaque shadow in the right lower zone of the lung, along with opacities inside. So this is basically ruptured hydatid with an intrabronchial rupture. So you can have air inside, which was confirmed on CT, which shows a large air-filled cavity with the germinal membrane lying inside it. Now, hydatid can also present as a solitary lesion, as if well-defined, very well-defined radio-opaque shadow. This will differentiate it from the fluffy shadows that you see in secondaries. There is a hydatid in the left upper lobe, which is unilocular. And this is another X-ray film of multiple hydatids, which show there are multiple hydatids in the right lung field, and there is another hydatid in the left lung field. The same was confirmed by a CT, and here you see a air fluid level inside the hydatid cyst. So this air fluid level indicates that there is a intrabronchial rupture of the hydatid that has occurred. Then we've covered the A, B, C. Now we come to the D. Always look at the diaphragm. So when you're looking at the diaphragm, see the level of the diaphragm. Normally, the right diaphragm is above the left hemidiaphragm because the liver is larger. And this difference between the right and the left side should not be more than 2 intercostal spaces. If it is more than 2 intercostal spaces, then you say that this is a abnormal elevation of the right dome of the diaphragm that commonly occurs in cases of liver abscess. Now, in this case, you see that there is a tiny speckle of free air under the right dome of the diaphragm. So whenever you say look for the free air, always look on the right dome of the diaphragm. A chest X-ray PA view is considered as a diagnostic modality of choice radiologically for confirming free air in the emergency setting. Then it can detect very small amounts of air, and classically it is said that the patient should be standing or sitting for at least 10 minutes for the air to rise up so that it can be noticed or picked up on a plain X-ray. And here you see a large, on the left side, on the right side of the screen, you see a large pneumoperitoneum. The right hemidiaphragm is there, and there is a large amount of free gas on the right side as well as on the left side. So when you're given such an X-ray, commonly you will be maybe given to your X-ray with free air to start your X-ray vivas, and you will be asked about the causes of free air. Then you enumerate the causes, that perforation of hollow viscus, it can be post-operative, and then you will be maybe given a case scenario along with this X-ray, that how will you proceed, that after you find free air in an X-ray, how are you going to further proceed with the management of the patient. Then when you're looking at a chest X-ray, always look at foreign objects, always look at tubes. Now this is a patient who is intubated. There is a flexometallic endotracheal tube inside, which is there above the tracheal bifurcation. Then there is a nasogastric feeding tube. Multiple ECG electrodes are there. Then you can see there is a central line in the right jugular vein with projection into the upper vena cava and the right atrium. All right. Also, you see there is an other central line. So basically, what had happened in this patient, that the right central venous line had got thrombosed, the left line was inserted, a chest X-ray, check chest X-ray was done, which is this one, before removing the right film. Also, you can see, if you appreciate, that there are a small amount of bilateral pleural effusions and basal atelectasis in this patient. Then, not only look at the tubes in the chest, always look at the tubes in the abdomen. I was talking about abnormal elevation of the right hemidome of the diaphragm in a chest X-ray. So here, in a case of liver abscess, you see the right hemidome of the diaphragm is elevated, and there is a pigtail catheter in situ, inside the right lobe of the liver. Now we come to the abdominal X-rays. So when you diagnose or read an abdominal X-ray, go by the mnemonic Abdo-X. Now A stands for air inside the bowel, any free air inside the biliary tree. B stands for the bowel, the position, the size, the nature, which bowel loop is it, the wall thickness. Then D stands for dense structures like calcifications, bones, any calculi. O would be organs and soft tissues. Look at the lung bases, look at the shadow of the liver. Spleen, look at the shadow of the kidneys in a good X-ray. The shadow of psoas muscles are visible in a good digital X-ray, and they give you a lot of knowledge. And X stands for the external objects, any artifacts, any foreign bodies, any stents, any tubes that may be there. Now, this X-ray may be commonly given to you of a small bowel obstruction, in which it shows there is a dilatation of the small bowel. Now, the normal diameter of the small bowel should be 3 centimeters or less on a plain X-ray film. And as you notice in this X-ray, there is a central position of the dilated small bowels and the presence of volvae conjunctivis extending across the full width of the lumen. And these two features are used to distinguish the small bowel from the large bowel on an X-ray. Now, in this case, with these small yellow arrows, you can appreciate that there are metallic clips which are there from a previous abdominal surgery. And this helps us to predict that most probably this is a post-operative adhesive intestinal obstruction that has occurred in a patient who was operated earlier. Then differentiate small bowel or large bowel obstruction from paralytic ileus. Paralytic ileus can occur from a variety of causes, from hypokalemia to post-operative paralytic ileus. I'm not going to go into those. What differentiates a paralytic ileus from a small bowel obstruction is basically the small bowel and colon are both gas-filled and they are not frankly dilated. And as in this X-ray, from the block yellow arrow, you see that the gas is visible in the rectum, which indicates that there cannot be total obstruction since the gas is going into the rectum as well. Now, this is another plain X-ray, a classical plain X-ray of a sigmoid volvulus due to a twist of the sigmoid colon at the base of the sigmoid mesentery, which is at a fixed position. So this gives you a classical bowel loop arising from the pelvis going up to the right hemidiaphragm. And it does not have any internal volvae conjunctivis. This is a clear dilatation of the large bowel. So your diagnosis in this case would be a sigmoid volvulus. Then this is a classical embryo sign of a cecal volvulus that is described, that there is a dilatation of the small bowel loops with prominent volvae conjunctivis in the central abdomen that shows there is obstruction. There are multiple air fluid levels in the erect view. A grossly dilated large bowel loop is seen extending from the right lower quadrant towards the right upper quadrant. And this is giving the shape of an embryo. And on an erect film, you can see a large air fluid level within this erect film. So this is a cecal volvulus. Then sometimes you may have a false appearance of free air under the diaphragm. But if you look carefully in this X-ray, this is not free air. There are demarcations of the bowel. And you can see these hostrations of the bowel that are there are extending across the lucencies. So this is not free air. This is an example of a pseudoperitoneum due to the interposition of the colon between the liver and the right hemidiaphragm. And this, as very commonly said, is an uncommonly seen but commonly taught Chilaiditi's sign. Then sometimes you may get a patient with a massive pneumoperitoneum. In this patient, you see there is a large pneumoperitoneum, and this was due to a colonic perforation. And in this case, you see a small amount of air on the right side as well as on the left side. You can appreciate the gastric bubble on the left side and the left hemidrome of the diaphragm. Between those, there is a free air. But always, if you want to diagnose free air, always look at the right side. Now, another sign that is there in a patient with free air in the peritoneal cavity is known as a football sign. And in this, what happens is, basically it's called so because a football-shaped object is going to be there, which is going to be the pushed up soft tissue and the bowel inside the abdominal cavity in the shape of a football. And surrounding that is going to be a free air. As you see in a lateral film, there is a massive pneumoperitoneum, and which is distending the whole of the abdomen from the diaphragm to the pelvis. So this is an X-ray of a neonate, which had a ileal perforation, which was proven on a laparotomy, as well as you can see a small umbilical hernia here in a lateral film. Then another sign of free air is known as a regular sign. Now, this is a 7-year-old child with acute abdominal pain and distension, and there was pneumoperitoneum, which has to be seen very carefully on an X-ray, in which you see that there is free air inside the bowel and free air outside. There is air inside the bowel and free air outside the bowel. That is, the white arrows are the free air outside the bowel that are demarcating the bowel wall. So this is known as a regular sign that the bowel wall is delineated by the intraluminal air and the free air outside it. Then there is another sign of ischemic colitis or massive fulminant colitis, which is known as a thumb printing sign, most commonly seen on the left side. It can occur in pancolitis also. And what happens is there is massive mucosal edema, which results in the appearance of the gas shadow of the colon in the form of thumbprints. And this is often a surgical emergency. Now, another surgical emergency that we tend to deal with in older patients is large bowel obstruction. Now, if you look carefully, a plain X-ray is one of the first X-rays that is performed when one of the first radiological investigation that is performed when the patient comes to us, and it gives you a lot of information. Now, if you look at this X-ray carefully, there is a gross dilatation of the transverse colon. All right. And then if you look, there is a soft tissue shadow in the left colon, and beyond that, the colon doesn't have much air. So this soft tissue shadow is basically a growth that is obstructing the left colon, and this was the same day or in the next day was confirmed by a CT, and CT also unfortunately showed multiple liver metastasis, as you can see. Now, there is another picture which is known as a colonic pseudo-obstruction. Now, it's not exactly obstruction. It requires conservative management, have to be patient for it to resolve. Now, this is an X-ray of an 80-year-old man who developed upper abdominal pain and distension 3 days after undergoing a elective right total hip replacement. You can see the hip implant here and some surgical clips, if you are able to appreciate in this region. Now, his abdominal radiograph showed severe diffuse dilatation of the colon from the cecum to the rectum, and the small bowel is normal caliber because the ileocecal valve is competent. So this is a colonic pseudo-obstruction because the whole of the colon is dilated. Then this is a classical double bubble sign that occurs in duodenal atresia or in an annular pancreas. Now here you can see this is the gastric bubble and this is the duodenal bubble, and this is the Ryle's tube that is there in the neonate. Then another common sign taught to you is the colon cutoff sign, which describes the gaseous distension seen in the proximal colon, associated with abrupt termination of gas within the colon, usually at the level of the splenic flexure, and decompression of the most of the distal part of the colon. Now, this colon cutoff sign can be picked up on a plain X-ray. It can be picked up on a CT also, and it is seen in different pathologies of the left upper abdomen, right from acute pancreatitis or from an obstructing carcinoma of the colon or inflammatory bowel disease, and sometimes even in mesenteric ischemia. Then this is a nice example of something we do not see very often. A plain abdominal radiograph showing multiple opacities in the right side. All right, and these turn out to be radio-opaque gallbladder calculi. So less than 10% of gallstones are radio-opaque. So here you see in this film, and this can be confirmed by an ultrasound. This can be differentiated from renal calculi on a lateral film. Now, as I always say, look at the X-rays always very carefully, and this patient had a previous history of pancreatitis. Now, here you can see from the small yellow arrows that there is coarse calcification in the epigastrium. And the patient's current admission was due to a left ureteric calculus, for which a double J stent has been passed. And also, you notice there is a copper T or intrauterine device in the pelvis that has been inserted in the uterus. So there are multiple findings in this X-ray. Then there is something which is known as a porcelain gallbladder. Here you see there is an opacification, a radio-opaque shadow of the shape of a gallbladder in the right hypochondrium, in the right upper abdomen. Now, porcelain gallbladder, as you know, is a very rare condition in which the inner wall of the gallbladder is encrusted by calcium. And it can be seen on plain abdominal radiographs very infrequently. And it is observed in elderly women and has a high propensity for development of gallbladder carcinoma. Then in the end, you always look at external objects, tubes, or any foreign bodies in a plain X-ray. In this case, you can see on the right side, there is a pigtail inserted for a psoas abscess, and on the right side of the screen, you see there is a pigtail inserted inside the liver abscess. Then this is another interesting X-ray in which, if you see, there is air within the biliary tree, which is indicated by white arrows. It is a common occurrence after a previous intervention like a sphincterotomy at ERCP, a CVD stent placement, as in this case, you see a self-expanding metallic CVD stent. It can occur post-operatively after hepaticojejunostomy or a choledochoduodenostomy. In this case, this pneumobilia is due to the metallic CVD stent. And when you see a metallic common bile duct stent, always consider a malignancy, because these are self-expanding metallic stents that have to be put in cases of a lesion that is completely occluding, and plastic stents are difficult to pass. Then we come to X-ray KUVs. Now, when you look at an X-ray KUV, what differentiates it? That it is from the lower part of the thoracic spine to the pubic ramus, inferior pubic rami, and they have to have a good exposure, a good bowel preparation. You have to prepare the bowel the night before by giving 2 tablets of Dulcolax and 4 tablets of charcoal. Dulcolax is going to be a laxative, while charcoal is going to absorb the bowel gases. And in this X-ray, you see one X-ray has on the left side of your screens multiple abnormal radio-opaque shadows in the region of the left kidney, suggestive of left renal calculi. And in this case, you see an abnormal radio-opaque shadow. And when you count the level, you will say opposite which lumbar vertebra. So you will count the lumbar vertebra from the sacrum. So you will say L5, L4, L3, L2. So opposite the junction of L2 and L3 vertebra, there is an abnormal radio-opaque shadow on the left side, which appears to be in the line of the ureter. So most probably a left ureteric calculus. Now the ureter basically traverses over the transverse processes of the lumbar spines, then goes over the sacroiliac joint, then turns medially towards the ischial spine and then goes into the bladder. So that is the line of the ureter. So those will be taught to you in the next presentation on IVPs. Now this X-ray of the pelvis shows a large abnormal radio-opaque shadow. Now, if this is given into you in a Viva and an oral, Viva always ask whether this is a contrast film or a plain film. All right. Then if it's a plain film, then this is a vesical calculus. If an oral IV contrast has been given, this can be a cystogram of a contracted bladder also. But if it is a cystogram, there will be a catheter. Okay, and please, for God's sake, don't confuse it with a barium enema. I've seen very intelligent students confusing a cystogram with a barium enema at times. So be at leisure, be relaxed while examining X-rays. Then this is another X-ray of a vesical calculus, a small one lying in the pelvis. Then this is an X-ray of a large calculus, a staghorn calculus on the left side. And it's called a staghorn calculus when the calculus extends beyond 2 or more major calyces. So you call it a staghorn calculus. Then this is another X-ray of a patient who was operated for other causes earlier and was coming with pain. So later on on imaging as well as on plain X-ray, there was an abnormal calcification on the right side. Now this calcification is classically very homogeneous and ground glass-like appearance. It's not a calculus, it's not a opacified gallbladder. And this turned out to be a opacified abnormal calcification of the kidney occurring due to renal tuberculosis, old renal tuberculosis, which was non-functioning kidney on the right side. And this is a classical appearance of a putty kidney. So a putty kidney is a pattern of renal calcification associated with renal tuberculosis, classically seen on the plain X-rays.
Dr. Nikhil, sorry to interrupt you.
Two more slides.
Okay.
I'm just finishing, sir. Thank you. So always look at foreign bodies. You have bilateral double J stents here. And on the other side, you have the whole plethora of stents, bilateral double J stents, which failed. Then, since the patient was in obstructive uropathy, bilateral nephrostomy, as you can see in these transverse stents, that was done. Thank you very much.
Thank you, Dr. Nikhil, for a nice presentation and showing a variety of X-rays, which a common surgeon will not have this. I think we'll take up a few questions at the end of the session. May I now invite the next speaker, Dr. Nain Singh. Dr. Nain Singh, are you there? Okay. Dr. Nain Singh is Professor of Surgery at Lady Hardinge Medical College. He'll be speaking on special radiology consisting of contrast studies, barium meal follow-throughs, barium studies, and of course IVPs. Let me tell you that barium and IVPs are least done these days, but nonetheless they are very important. Dr. Nain, please. Dr. Nain, you can start.
Sir, your voice is not coming, sir.
Yeah, your voice is not coming. Dr. Nain, can we see this issue of not hearing your voice?
Sir, we are just sorting it out.
Yeah, okay.
सर अभी आवाज आ रहा है?
हाँ आ रहा है लेकिन बहुत डिस्टर्ब हो रहा है।
सर आप दूसरे सिस्टम से ना अपना स्पीकर भी ऑफ कर दीजिए सर प्लीज। जिस स्पीकर पे आपका वॉइस नहीं चल रहा था उस वाले को सर।
Prashant, just assist Nansing sir, because we can't hear him. Probably the other system from which he is logged in right now has a audible system.
अभी सर देख के बताइए डॉक्टर ज्ञान, अभी आ रहा है आवाज?
डॉक्टर नैन्सी, अब ठीक है आवाज आपकी?
सर आवाज आ रही है?
हेलो,
now we can. Sir, you are very much audible.
Audible, sir?
Yeah. Go ahead, Doctor.
Most of the X-ray has been covered by Dr. Nikhil Talwar nicely, and advanced radiology will be covered by Dr. Ajaz. तो मेरे पास तो वो है जो रूडिमेंट्री हो गई है आज के समय में, बहुत कम यूज होती है। तो ये मेरे majority of X-ray has been nicely covered by Dr. Nikhil. हाँ, तो जैसे कि एक चेस्ट रे मेरे अपने बनाए फंडे, जैसे कि हम एनाटॉमी में मसल को याद करने के लिए बनाते थे, तो एक नॉर्मल चेस्ट एक्सरे में 4 कोण देखने हैं आपको। तो एक कॉस्ट्रो फिरेनिक हो गए, 2 कोण ये वाले एंगल, और 2 कॉस्ट्रो कार्डिक। तो ये 4 कोण दिखने चाहिए, और बाकी सेंट्रली हार्ट दिखना चाहिए। ब्रोंकोवास्कुलर एनाटॉमी इसमें दिखनी चाहिए नॉर्मली। सिमेट्रिकली आपको क्लेविकल रिब्स और पूरी चेस्ट सिमेट्रिकली दिखनी चाहिए।
हिंदी में क्यों पढ़ा रहे हो?
चेस्ट में और एब्डोमेन में जो व्यूज हैं, मेनली तो हम चेस्ट में चेस्ट पीएवीयू करते हैं। पीएवीयू का मतलब है कि पोस्टीरियर से आपकी रेज आएगी और एंटीरियरली आपकी फिल्म लगेगी। एब्डोमेन में आप पीएवीयू एपीवी दोनों यूज कर सकते हैं, और जो जितने भी आप एक्सरे करोगे उसमें आपको या तो ब्लैक ब्लैक दिखेगा या व्हाइट व्हाइट दिखेगा। तो ब्लैक किस चीज को दिखता है? वो मेनली एयर और एयर पॉकेट्स होते हैं, और जो ब्लैक है वो आपको दिखेगा जहां जहां पे बोन होगी, ब्लड रिच ऑर्गन होगा, मिनरल्स होंगे, वो व्हाइट व्हाइट दिखेगा आपको। अब जैसे ये वाला एक एक्सरे है, तो इसमें कॉस्ट्रोफिरेनिक एंगल इस तरफ का बहुत क्लियर दिख रहा है, लेकिन इस तरफ कॉस्ट्रोफिरेनिक एंगल है नहीं, एक्चुअली में तो कॉस्ट्रोवर्टिबल एंगल बन गया। तो लंग इसका ये वाला हाइपर इन्फ्लेटेड लग रहा है, और इधर में कॉस्ट्रोफिरेनिक एंगल नहीं है, कॉस्ट्रोकार्डिक भी नहीं है, कॉस्ट्रो चेस्ट के साथ बन रहा है। और एक ये शैडो आपको दिख रही है कि जो थोड़ी सी ज्यादा व्हाइट है कंपैरेटिवली इधर के लंग के, और ऊपर जो है स्मूथ है, बिल्कुल स्मूथ ब्लैकनिंग है जो लंग वाला टिश्यू होना चाहिए, उसमें कोई ब्रोंकोवास्कुलर मार्किंग नहीं दिख रही है। एओर्टिक नकल हो गई, और ये आपको ये कंपैरेटिवली ये नॉर्मल साइड का एक्सरे चेस्ट होगा। और अगर आप इधर देखोगे तो इधर कोई पैथोलॉजी है, जैसे कि ऑब्लिटरेशन ऑफ एंगल है यहाँ पे, और थोड़ा व्हाइट व्हाइट है, तो हीमोथोरेक्स होना चाहिए। ये जो है ज्यादा व्हाइट जो इतना लंग पड़ा हुआ है, ये कोलैप्स्ड लंग पड़ा हुआ है। और ये क्लेविकल की अगर बाउंड्री हम ट्रेस करेंगे तो मिडल 2/3 और एंटीरियर 2/3 में फ्रैक्चर है क्लेविकल के। एक ये पीस पड़ा हुआ है, एक ये वाला बड़ा है 2/3 वाला, और एक पीस इसका ब्रोकन नीचे पड़ा हुआ है। अब रिब्स की जो है काउंटिंग हम करेंगे, फर्स्ट रिब ये आ गई, सेकंड को अगर हम फॉलो करेंगे तो सेकंड रिब फ्रैक्चर है इसमें, थर्ड रिब्स हो गई, फोर्थ रिब हो गई, और फिफ्थ रिब फिर फ्रैक्चर है। तो लेफ्ट साइड का हीमोन्यूमोथोरेक्स हो गया है। रिब्स काउंट करने के इस एक्सरे को अगर हम वर्टिकली ना करके इसको हम रोटेट कर राइट साइड में, तो जो पहला छल्ला है, फर्स्ट छल्ला जो है काउंटिंग करने में जो पीजी कई बार गड़बड़ करते हैं कि ये सेकंड है या थर्ड है, तो उसका सबसे बड़ा फंडा, जो पहला जो छल्ला दिखता है वो फर्स्ट रिब हो गई, जो दूसरा छल्ला दिखता है वो सेकंड रिब हो गई, तीसरा छल्ला जो इधर लास्ट में लेटरली दिखता है वो थर्ड रिब हो गई। तो दूसरी जो बात है, जब चेस्ट ट्यूब इसमें डाली तो चेस्ट ट्यूब का जो लास्ट होल है उससे आप असेसमेंट करें कि लास्ट होल चेस्ट वॉल के अंदर जब जाएगा तो कितनी लेंथ ट्यूब के अंदर जाएगी। तो अब जैसे इसमें जो चेस्ट ट्यूब इंसर्ट करी गई तो वो मीडियास्टिनम तक जाके गई और वहां से टकरा के किंक हो गई और चेस्ट ट्यूब डालने में कोई बेनिफिट नहीं मिला, इसमें थोड़ा सा मिला लेकिन न्यूमोथोरेक्स रिजॉल्व नहीं हुआ। रीचेक एक्सरे किया गया उसमें पहले वाले में देखा तो वो इसमें रिजॉल्व हुआ, तो इसको थोड़ा सा विड्रॉल किया तो ये किंकिंग का खत्म हुई और जो पूरा लंग यहाँ पर कोलेक्स पड़ा हुआ था वो पूरा का पूरा लंग एक्सपेंड हो गया और ब्रोंकोवास्कुलर मार्किंग इस साइड के भी आ गई। थोड़ा सा हीमोथोरेक्स इसमें बचा हुआ है, लेकिन ये जो होल है यहाँ पे चेस्ट वाल के काफी नजदीक आ गया। अब अगर ये होल बाहर हो जाएगा तो फिर सर्जिकल एम्फाइजेशन शुरू हो जाएगा। तो जब ट्यूब डालने की बात है तो उससे पहले आप असेसमेंट करें कि आगे से हम ट्यूब की टिप कितनी काटते हैं। लास्ट होल का असेस करके भी 5 सेंटीमीटर 6 सेंटीमीटर 7 सेंटीमीटर कट करके उसको डालें। ऐसी एक्सरे एब्डोमेन हो गया। अब इसमें जितना ज्यादा मिनरल्स बोन्स ब्लड वाला ऑर्गन होगा वो आपको दिखेगा। अब प्लेन एक्सरे एब्डोमेन में भी आपको दिखेगा कि वो वर्टिब्रल कॉलम अच्छे दिखेगा, बोन्स दिखेंगी पेल्विस की, साथ में अगर आप देखोगे तो ये सॉस की शैडो भी दिख जाएगी क्योंकि सॉस की शैडो थोड़ी सी ज्यादा वस्कुलर होती है। इधर की थोड़ी सी ज्यादा अच्छी दिखेगी राइट साइड की, लेफ्ट साइड की थोड़ी सी कम अच्छी दिख जाएगी। और एक रेडियो ओपेक शैडो यहाँ पे दिखेगी आपको, ये दिख रही है रेडियो ओपेक शैडो। T12 ऊपर है, TL1 वर्टिब्रा यहाँ आ गई, नीचे की रिब्स दिख गई। और अगर गौर से देखेंगे तो ये देखिएगा आपको लेफ्ट साइड का किडनी भी इसमें दिख जाएगा प्लेन एक्सरे फिल्म में भी। ये लेफ्ट साइड का किडनी की बाउंड्री है। प्लेन एक्सरे एब्डोमेन में देखेंगे आप तो उसमें मल्टीपल आपको एयर फ्लूइड मिल जाएंगे। सेंट्रल एब्डोमेन में होंगे तो स्मॉल बाउल ऑब्स्ट्रक्शन हो गया। सेंट्रल एब्डोमेन में अगर आप देखेंगे तो स्मॉल बाउल हो गया। पेरिफेरी में अगर एयर फ्लूइड दिखाई देगा तो लार्ज बाउल ऑब्स्ट्रक्शन हो गया। और एयर फ्लूइड 3 से 5 तक नॉर्मल काउंट होंगे, एक फंडस में होगा। आलियोसिकल जंक्शन में एक एयर फ्लूइड डेडिकेटेड टेस्ट होता है कि बेरियम सल्फेट आप सोलो करने के लिए बोलते हो और उससे पहले जो प्रिपरेशन है उसमें की भी जो जिन चीजों से गैस्ट्रिक सेक्रेशन बढ़ते हैं वो चीजें शाम को नहीं खानी होती, फास्टिंग में इसको करना होता है। बेरियम सोलो, बेरियम मिल, बेरियम फॉलो थ्रू, बेरियम एनीमा। अब बेरियम सैलो की स्टडी क्या है आपका फेरिंग्स से लेके लोअर यूसोफेजल जंक्शन और प्रॉक्सिमल स्टोमक तक की है। तो इस साइड का जो है ये नॉर्मल बेरियम सैलो है, ये वाली फिल्म। ये राइट साइड की जो फिल्म है वो पैथोलॉजिकल फिल्म है। इसमें अगर आप देखेंगे तो लोअर यूसोफेगस की स्मूथ टेपरिंग आ रही है, स्मूथ टेपरिंग, जिसको आप बर्ड बीक साइन बोलते हो। और प्रॉक्सिमल यूसोफेगस डायलेटेड है, डायफिल्ड है, बेरियम फिल्ड है, सजेस्टिव ऑफ एक्लेजिया कार्डिया। ये वाला एक्सरे है कि इसमें देखोगे कि आप बेरियम में सोलो जब हुआ है तो इसमें यूसोफेगस में एक थिन लेयर आ रही है इसकी। तो ये एक्सरे है कॉस्टिक स्ट्रक्चर का कि पूरा का पूरा यूसोफेगस ही स्ट्रक्चर्ड है इसमें। तीसरा जो एक्सरे है मेनली आपको 3 एक्सरे सर्जिकल प्रैक्टिस में एनकाउंटर करने मिलेंगे, एक्लेजिया कार्डिया या कार्सिनोमा यूसोफेगस और या स्ट्रक्चर क्रोसिव स्ट्रक्चर के बाद में। तो इसमें जो उसमें बर्ड वीक साइन दिख रहा था आपको, इसमें देखेंगे आप अपनी कॉर्ड डिफॉर्मिटी जिसको सोल्डरिंग साइन कहते हैं वो दिखेगा आपको। और कितना सेगमेंट इन्वॉल्व है, कितनी लूमेन है, ये आप इससे असेस कर सकते हो बेरियम मील से। हाँ, ये जो है एक्सरे बेरियम मील का है जिसमें कि आपको पूरी स्टोमक की एनाटॉमी दिख जाएगी। फंडस ऑफ स्टोमक दिख जाएगा, बॉडी दिख जाएगी, एंगुलर नोज दिखेगी, पाइलोरिक एंट्रम दिख जाएगा, पाइलोरिस दिख जाएगा और ट्रायंगुलर शेप में लास्ट में आपको डोडेनल फर्स्ट पार्ट दिख जाएगा। तो ये नॉर्मल है। ये एक्सरे 1995 का व्हेन आई वाज एमबीबीएस स्टूडेंट फाइनल ईयर, बेरियम मील का। तो इसमें आपको दिख रहा है कि ये गैस है, फंडल गैस है, ये इसमें रूजीज दिख रही हैं म्यूकोजा की, और ग्रेटर कर्वेचर पे ग्रोथ आपको दिखाई देती है जो फिलिप डिफेक्ट के रूप में आती है। ये पाइलोरिक एंटमी डोडनल कैप। और अगर डबल कंट्रास्ट करते हैं एयर करने के बाद में तो आपको उसमें म्यूकोजा का पैटर्न भी दिख सकता है। और जैसे इस वाले बेरियम मील में आपको एक सॉफ्ट टिश्यू शैडो लेसर कर्वेचर में दिख रहा है, सजेस्टिव ऑफ पॉलिप और जीस्ट हालांकि हिस्टोलॉजिकल डायग्नोसिस हो जाएगी। तो पॉलिप या इनवर्ड ग्रोथ एट द लेसर कर्वेचर आप बेरियम मील में भी देख सकते हैं। जो सीटी में दिखेगा आपको तो ये इस तरह की ग्रोथ दिखेगी। कार्सिनोमा स्टोमक में आपको डिक्रीज कैपेसिटी और जो उसकी आउटवर्ड इनवर्ड ग्रोथ है उसकी वजह से जो डिक्रीज कैपेसिटी होगी स्टोमक की कैपेसिटी, वो इसमें आपको असेसमेंट करके मिल जाएगा कितना इन्वॉल्वमेंट है। बेरियम मील फॉलो थ्रू 25 से 50% बेरियम सल्फेट में फॉलो कराते हैं। 15 से 20 मिनट पे एक एक फिल्म लेते जाते हैं और टोटल ड्यूरेशन आधे घंटे से 2 घंटे का होता है प्रोसीजर करने का। पोजीशन आप चेंज करते रहते हैं। तो इसमें आपको तो जायजना में उसकी म्यूकोजा का पैटर्न, कहाँ ऑब्स्ट्रक्शन है, कहाँ पे नैरोइंग है, ये सारी चीजें आप इसमें इवेलुएट कर सकते हैं। और टर्मिनल आयन से यहाँ पे आलियोसिकल जंक्शन जो है उसको आप देख सकते हैं और ये सीकम में डाई जा रहा है। और फिर ये असेंडिंग कॉलम में देख सकते हैं, हॉर्स्टा के शेप में असेंडिंग कॉलम। और डाई का पैटर्न देखते हैं, जो आप वेलवेटी पैटर्न जायजनम से शुरू होता है वो धीरे 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 होता हुआ एक विशेष उसमें करेक्टर लेस होता चला जाता है और फिर यहाँ पर टर्मिनल वाले में जाके करेक्टर लेस हो जाता है। बेरियम एनीमा, बेरियम एनीमा में क्या है कि आप रेक्टम से एक ट्यूब डालते हैं और उससे बेरियम सल्फेट इंसर्ट करते हैं और पूरे कोलन को आप देख सकते हैं। जैसे ये नॉर्मल है बेरियम एनीमा, नॉर्मल पेशेंट का है। सिग्मोइड कोलन आप अच्छे से विजुलाइज कर सकते हो। हेपेटिक फ्लेक्सर, ट्रांसवर्स कोलन, डिसेंडिंग कोलन, आलियोसिकल, सिग्मोइड कोलन तक आप ये सीकम तक इसको इवेलुएट कर सकते हैं। ये भी बेरियम एनीमा की फिल्म है 1995 की। उस समय पे जब ये आपके कोलोनोस्कोपी और ये सीटी स्कैन हमारे यहाँ नहीं होते थे तो तब ये इन्वेस्टिगेशन काम के थे। आज की डेट में तो ये रूडिमेंट्री हो चुके हैं, बहुत कम लोग कराते हैं। यूजुअली आप प्लेन एक्सरे से काम चलाते हो और जो मेट्रो सिटी जो उसमें सीटी है हमारा या एमआरसीपी में इनको रिप्लेस कर दिया सारी कंट्रास्ट रेडियोलॉजी को। तो इसमें भी आप देखोगे तो ट्रांसवर्स कोलोन पे एक फिलिंग डिफेक्ट आ रहा है, सजेस्टिव ऑफ सम ग्रोथ हियर। टी-ट्यूब कोलोनजोग्राम है। डाई उसमें हम बेरियम सल्फेट यूज करते थे। टी-ट्यूब में मैग्लामीन आयोग्लूमेट डाई यूज करते हैं। इसके करने का तरीका 10th डे पे हम इसको करते हैं टी-ट्यूब इंसर्शन के। और टी-ट्यूब के अंदर जो है वो जो बाइल आता है ना वो फुल होना चाहिए और नीचे की तरफ उसको ड्रिप करके उसमें एयर नहीं इंजेक्ट होना चाहिए। फिर सिरिंज से भर के आप डाई इंजेक्ट करते हैं उसमें टी-ट्यूब में। तो वो आपकी लेफ्ट डक्ट को, राइट लीवर की लेफ्ट डक्ट, राइट डक्ट और सीबीडी पूरी को विजुअलाइज कर देती है और जैजनम में जाते हुए दिखाई देती है आपको अगर कोई ऑब्स्ट्रक्शन नहीं है। अब इस टी-ट्यूब कोलोनोग्राम में अगर आप देखेंगे तो ये अपर लिम्ब हो गया, ये लोअर लिम्ब हो गया, ये लॉन्ग वाला लिम्ब, वर्टिकल लिम्ब हो गया और बीच में एक हल्की सी रेडियोलूसेंट शैडो आ रही है। फिलिंग डिफेक्ट है, ये हल्की सी रेडियोलूसेंट शैडो आ रही है जो कि हो सकता है कोई रेजिडुअल स्टोन भी हो सकता है और एयर होगा। तो उसमें कंफर्म करने के लिए फ्लोरो आप इसको पोजीशन चेंज करेंगे। अगर ये इधर उधर मूव करता है तो ये एयर है और नहीं तो फिर ये स्टोन है रेजिडुअल। ये कोलिसिस्टोग्राम है। ये पेशेंट ऑपरेट हुई थी विद डायग्नोसिस ऑफ लॉन्ग स्टैंडिंग डायबिटिक पेशेंट थी। परफोरेटेड अपेंडिक्स के साथ में सस्पेक्टेड डायग्नोसिस क्लियर नहीं हो पा रही थी, सीटी इसका हो नहीं पा रहा था। तो उस स्टेज में इसकी अपेंडिक्सेक्टमी के लिए हमने लिया और अपेंडिक्स जब लोअर मिड लाइन ऑफ इंसिडेंस खोला तो अपेंडिक्स तक पहुंचे तो अपेंडिक्स वाज वेरी वर्जिन, पैथोलॉजी कहीं और थी। तो सारी बाउल को टेस्ट किया गया। उसके बाद जब कहीं कोई पैथोलॉजी नहीं मिली तो यहाँ से पस राइट पैराकोलिक गटर से पस की ड्रॉप आती शुरू हुई। उन्हीं पस की ड्रॉप को टेस्ट करते हुए चले गए तो ये केस था गॉल ब्लैडर परफोरेशन का, डायबिटिक पेशेंट लेडी। अब उसको पॉलीसिस्टेक्टमी के लिए प्लान डिसाइड किया बट कैलोट वाज बहुत फ्रोजन था, बढ़ नहीं पाया, आगे प्रोसीड नहीं कर पाए। तो गॉल ब्लैडर के सारे स्टोन डाल के और फोलिज कैथेटर डाल के इसको परसिस्टिंग लगा के बंद कर दिया। 10th डे का ये कोलिसिस्टोग्राम किया तो डाई जयजन में फ्रीली जा रही थी, कोई रेजिडुअल स्टोन नहीं था। तो अंग्रेजी मेरे से बोली जाती है। हाँ, we use intravenous urography. The dye usually use non-ionic iohexyl which has been largely replaced by nowadays CT urography. So when we proceed for intravenous pyelography, so we have to take a scout film like this, showing shadow of psoas muscle again, and one radio opaque shadow in right renal area. तो अगर आपको खाली यही फिल्म मिलती तो सीधे सीधे इसको रीनल स्टोन नहीं बोलना, इट मे बी ए रीनल स्टोन, इट मे बी रेडियो ओपेक, इट मे बी रेडियो ओपेक गॉल स्टोन विच इज ए रेयर एंटिटी, इट मे बी फीकोलेज, इट मे बी ए कैल्सिफाइड लिम्फ नोड। तो वो सारी के सारी 8-10 जो डिफरेंशियल डायग्नोसिस हैं आपकी, वो उसके साथ बताना कि इतनी सारी चीजें हो सकती हैं। इसी पेशेंट की आईवीपी है। आई टोल्ड यू कि वाइट तो जो जितना गोरा है, अब जैसे कि है इट प्रोड्यूस वाइट शैडोइंग ऑन एक्सरे, बट इफ यू इंजेक्ट ए डाई इट इज मोर, इट विल प्रोड्यूस मोर वाइटनेस ऑन द एक्सरे फिल्म। तो सेम पेशेंट के अगर देखेंगे तो यहाँ पे थोड़ा सा रेडियोल्यूसेंट एरिया है। इन आईवीपी रेडियोल्यूसेंट एरिया सजेस्टिव ऑफ स्टोन। और इस वाले पेल्विस में आप देखेंगे, इफ यू सी दिस पेल्विस इट इज मोर वाइट। रीनल फेस में थोड़ा सा इसका कंप्रोमाइज है किडनी फंक्शन, बिकॉज डाई इज गोइंग डाउनवर्ड ऑन लेफ्ट साइड एंड राइट साइड इट इज ओनली ऑन रीनल फेस। ये नाउ दिस डाई हैज कम टू द up to the ureter and it has almost finished the dye excretion. Complete bladder film. Now this is the ureter. Some people think they in between the two ureteric parts there is a gap of dye and they think that there is a stricture. This is not a stricture. This is a peristaltic waveform. Ureter in this area is in constricted phase and this is relaxed phase. If there is a obstruction, then proximal ureter will be dilated. MCU and RGU. Again, normal MCU में you have to fill the bladder and then you have to ask to micturate the patient, and you will evaluate the whole of the urinary bladder, any outward pouching of urinary bladder and prostatic urethra you can visualize. After that, membranous urethra you can visualize, and then bulbar urethra and then penile urethra, which can be visualized in micturating cystourethrogram. And if there is any vesico-ureteric reflex, it can also be visualized in micturating cystourethrogram. Like this is micturating cystourethrogram. Yes, this is RGU. In RGU, you insert a tube through the penile urethra and evaluate the length of urethra. In MCV, you have to fill the bladder with dye, and then you take a radiograph during micturation. In RGU, you just insert a small length of any infant feeding tube or any tube catheter in the penile urethra, inflate the urethra and see is there any stricture and how long is the stricture and which part is it in membranous urethra, is it in bulbar urethra or is it in penile urethra. Thank you.
Thank you, Dr. Mohan Singh. Hello.
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 Yes, sir, Dokania sir, we can hear you. Please carry on.
Thank you, Dr. Mohan Singh, for a nice presentation. Now I invite Dr. Ijaz Akhtar for his topic of advancement in radiology. He will discuss about, he's the professor of surgery at Lady Hardinge Medical College, and he will say advancement of radiological methods, say as MRI, CT scan, and other.
Thank you, sir.
Over to Dr. Ijaz.
Thank you, sir. My screen is visible.
No,
Not yet.
Not yet.
Okay. And am I audible?
Yes, you are very much audible, but we cannot see your screen, Dr. Ijaz.
Okay, I'm just trying to. Now it's visible?
Yeah.
Okay, thank you.
Thank
you. So thank you, Dr. Rukania, and thank you, the chairperson. So my topic is the CCT, MRI, and MRCP. So topic is very big, and I think I am the last one, so I have no time capping. So I will try to cover the every aspect regarding the exam point of PG exam point of view, how to read a CT, and so abdominal CT scanning has revolutionized the patient care in the past 2 decades, and CT abdomen scanning is used in the evaluation of various complex abdominal pathology, and its pathology, either it's benign or malignant, it can categorize on the basis of CT, and it's also tell about the lateral extension of the disease to helpful in the making of diagnosis and the staging of the disease. And there should be appropriate precaution, especially for the renal failure patient and allergy patient, to take precaution for the CT scan. So we will discuss in the different topics, like different describe type of the CT abdomen, different CT protocols, especially for the liver and pancreas, and how to read a CT abdomen, and some discuss important CT films. So basically, CT scan it's like an extended version of the X-ray. But in X-ray, you can visualize either in the black, either in the white. But in the CT, there is in between the black and white, there is a gray, and most of the soft tissue comes to the gray part. That is the count with the Hounsfield unit, that is HU. And they start, if you air the unit, HU unit is minus 1000, and if there is a bone, then it is plus 1000. And the soft tissue fall into the between the 15 to 100. So on the basis of consistency, it's look like different shadow. So now we'll discuss with types of CT. Basically, one is a non-contrast film, another is a contrast scan film, that may be a single phase, a multi-phase, or a special type, whatever is required. And in the single phase scan, either go for the acute abdomen or suspected abdominal infection, and for the hepatic parenchymal lesion, go for the portal venous phase or combined with the administration of oral contrast. And multi-phase scan consists of pre-contrast and combination of arterial phase, portal venous phase, and delayed imaging depending on the organ of interest. So with the use of contrast, either IV or oral, it gives the better picture about the pathology, either it's benign or malignant, or a hypervascular or hypovascular. It's dependent upon the uptake of the contrast. Now comes to types of contrast. In the case of oral, there is a positive barium or iodinated water soluble contrast. In the neutral, nowadays neutral is more in practical use, because the positive contrast can create the artifact and cannot give the good impression about the bowel wall. And another negative which is used by using the mannitol. And IV is iodine containing water soluble non-ionic contrast agent Omnipaque 350 has per ml. So dose, mainly if patient weight is less than 75 kg, then 100 cc is adequate. If 75 to 90 kg, the dose is 120 cc, and if more than 90 kg, then you can use the maximum dose 150 cc. And in some protocol like liver and pancreas, you use the 150 cc. So basic concept is start from the course of contrast, and you must know when contrast reach to where, and then take the film and then tell about the organ intake of the contrast. So in the case of early arterial phase, that is 15 to 20 seconds, that is contrast remaining in the main arterial system. In the late arterial phase, that is the important phase. This take time to 30 to 40 seconds, and it is the organ enhancement phase. Most of the organ is visualized at this stage. Then hepatic phase or portal phase, that contrast go through the portal venous system, and it takes 70 to 80 seconds. Then comes to then next is the nephrogenic phase, that contrast goes to the renal parenchyma, that is 100 seconds, and the last one is delayed phase, that is 6 to 10 minutes. And this tell about the any contrast remaining in the body, and that's mainly uptake by the fibrotic pathology. So early arterial phase contrast remain in the artery, and the late arterial phase is organ enhancement, and delayed phase all contrast wash out except the fibrotic tissue triple. And there is one phase called the triple phase CT, where 3 type of film is taken. One is a non-contrast, another is the late arterial, that is organ enhancement phase, and another third one is the portal phase, that is called the triple phase CT. And there are different protocols for the different organ like liver, like pancreas, and for the GI bleeding. So for liver lesion, first film taken in the 35 seconds, another film taken in the 70 seconds, that is the portal system, portal phase, and again after 10 minutes for the delayed film. And for the liver metastasis, again dose is 150 cc, and take the delayed film, because in the case of either you can differentiate the metastasis from the SCC. In the case of SCC, there is early uptake of the contrast compared to the metastasis. So this one is the non-contrast film, that is called the NCCT, and it's helpful in the detection of either the stone in the kidney. You can visualize the radiopexado or a stone in the kidney or ureter, and sometimes if there is a radiopaque stone in the CBD, either calcification in liver or pancreas, or sometimes there is a hypodense lesion visualized in the liver tumor due to the fat in the adenoma or myelolipoma. Then comes to the early arterial phase, that start from the 15 to 20 seconds after the injection of contrast, and it interprets the pathology in the arterial system, like dissection of aorta, aortic aneurysm, either arterial bleeding, like in the case of post-pancreatitis, you can see the splenic artery aneurysm or splenic artery bleed. So any pathology that create in the arterial system, it's detect in the early arterial phase. Then late arterial phase, that is the 30 to 40 second. And as I earlier said, this is the organ enhancement phase. The most of the organ is enhanced, or any hypervascular lesion like SCC, that will be also enhanced in the arterial phase. So hypervascular lesion, stomach, bowel, pancreas, parenchyma, spleen, kidney, outer cortex, all are enhanced in the late arterial phase. And it's helpful in the detection of SCC, FNS adenoma, and pancreatic adenocarcinoma, insulinoma, and sometimes bowel ischemia. And hepatic phase, that is comes in the 70 to 80 seconds, and it enhances the hepatic parenchyma, and it detects the hypovascular lesion like cyst, abscess, or most of the metastasis. Then comes to nephrogenic phase. It's the film taken at the after the giving the contrast to the near about 100 second, and it enhance the all renal parenchyma including the medulla, and it's detect the helpful in detection in the renal cell carcinoma. Even we can see the function of kidney. If proper intake is contrast is kidney, then we can comment its kidney is functioning or not on the CT. And last phase is the delayed phase. Is start from 6 to 10 minutes, and if contrast remaining after the 6 minutes, that suggests the fibrotic lesion or and still enhancement of kidney and urinary collecting system contrast can be visualized. And if there is any filling defect is there, then you can say it's a stone. And it's helpful in detection of liver and cholangiocarcinoma. It's a hypovascular lesion, so we can visualize in a delayed phase. And fibrotic metastasis, most of the commonly breast cancer. And in the kidney, you can visualize the transitional cell carcinoma. Oral contrast, as we already said, nowadays positive contrast is used only for the either distension of bowel and seeing any leak or any fistula in the bowel. Nowadays only neutral or negative contrast is used. So disadvantage of the contrast is positive contrast is that there is more radiation is needed and enhancement of bowel is obscured. So we can see here in this film compared to the contrast film. Here without contrast, neutral contrast, you can appreciate the bowel wall enhancement with a less vascular supply in this segment. And here is the bowel enhancement. We can visualize with the yellow arrow. Here we can see after giving the oral contrast, here we can see the leak from the sigmoid colon. This is a sigmoid colonic fistula. Now comes to the radiation exposure. So we can see in the chart, CT, abdomen and pelvis is the maximum radiation exposure compared to the other simple X-ray. Like if you see the chest X-ray, it's 0.02, or you can count a number of X-ray 1. If you go for CT, abdomen and pelvis, it's 500 times compared to the chest X-ray. Now comes to the different planes. So most common plane is the axial or transverse plane, and another film is the coronal, that we can see the longitudinal view from anterior aspect or posterior aspect, and the sagittal view we can visualize from the lateral aspect. And the CT, all three film can combine and reconstruct the film. So how to interpret the CT? So first, to identify the patient name, age, sometime date of birth is written, you can count it, and date and time of the study. And orient yourself and see the section. It's sagittal, is coronal, is axial, as we say in the previous slide. And hold the film properly, and you can visualize which one is the right side, which one is left side. So you are looking, you are seeing the film, then you are looking at the patient lying on their back from the feet first perspective and viewing the axial images. So always begin cranial and go gradually, move the caudally, and assess the structure from the superficial to deep, and first analyze the tissue of abdominal wall and then progress to the internal structure. And the most important thing is, if you follow the one organ, track through the entire sequences. And try to see the contrast in the arterial system and bowel, so you can comment on its contrast film or non-contrast film. And with experience, follow organ that lie in the same transverse plane. And first, to identify the normal structure, like in this film, you can visualize the liver, IVC, aorta, spleen, stomach, air in the stomach. And the next second film, you can see here is the IVC, here is the aorta, there is a kidney ossification is there. So you can comment its contrast film is this because the kidney opacification is there. There is a contrast in the portal venous system. So first to learn how to identify the normal structure. So if you know the basic anatomy, then you can identify easily. Then comes to, and always, as you earlier said, follow the organ. So there is short video. So comes from upward to downward from its right lower liver, which is a hypotense lesion in the liver, and with the pericystic edema you can visualize. So this is a case of liver abscess. Again, I am showing the film. And you can also visualize the pleural effusion as any collection in the subhepatic spaces. So comes to the liver. How to read a liver in the CT. So liver has a dual supply from the hepatic arterial system and portal venous system. And liver has a different lesion like hepatocellular carcinoma, metastasis, etc. So in the arterial phase, hypervascular tumor will enhance with the hepatic artery, like HCC. And the portal venous phase system, there is if there is a hypovascular tumor and detected like metastasis, so there is a tumoral washout. If early tumoral washout is there, there may be suggestive of vascular tumor. If retention of contrast in the blood pool, that may be the suggestive of hemangioma. If retention of contrast in the fibrotic tissue, that may be the capsule around the HCC or the cholangiocarcinoma. So this is the classical view of the HCC, and you can notice the first film is a non-enhanced, so there is no lesion we can visualize, but in the case of early arterial system, there is a uptake of contrast in here. And just in the portal venous system, portal venous phase, the disappearance of the contrast from the lesion. And in the late stage, equilibrium stage, that is around 6 to 10 minutes, the contrast remaining in the liver, but here contrast is washed out. So it's suggestive of the HCC. Another film of HCC, you can visualize in the arterial phase very easily. In the portal venous phase, it's disappear. And in delayed phase, even contrast in the liver, but the contrast wash out in the HCC lesion. Now come to the liver mets. This is a case of liver mets with the cecal malignancy. Here you can visualize the good visualization in the portal phase. The whole liver is covered with the big mets. Another film is a case of CA breast with the liver mets. And first film is the arterial phase. Second one is the portal venous phase system. And here you can visualize the breast tumor with the exudate lymphadenopathy. Another pathology in the liver is the dilated IHBR. So you can visualize the dilated IHBR in the case of jaundice, and if you can scroll down in the downward, then you can find either confluence is involved or not. Basic requirement for the surgeon is confluence is intact or not. So you can visualize, but it's better appreciate in the MRCP. This is a coronal section, shows the CBD, that is abrupt cutoff, and here there is a soft tissue lesion that is suggestive of ciliate of pancreas with the IHBR dilatation. Then come to hepatic cyst, the well circumcised And this one is the amoebic liver abscess. If you compare from the hydrated cyst or the simple cyst, so you can see here is the cyst wall, here is the abscess wall is there, and you can found any pericystic fluid you can visualize in the liver. The smooth wall, there is no pathology in the gallbladder, but visualize there xanthomatous gallbladder. It's a dilemma for even the radiologist to differentiate between the xanthomatous gallbladder and the malignancy. The whole valve is thickened even more than 4 mm. Sometimes whole gallbladder is thickened, sometimes patchy. You can thicken valve, you can visualize in the gallbladder. So it's present like a mass, and it's generally radiologically it's mimic like a GB malignancy. Even we cannot differentiate intraoperatively between the xanthomatous and the CA gallbladder. And the last one is for the gallbladder is the CA gallbladder with the local filtration of the local infiltration of in the liver. Here we can see there is a focal growth on the body of the gallbladder, suggestive of the CA gallbladder. And this one is the case of gallstone ileus. Here we can see there is a air in the CBD and air in the gallbladder, and the same and another film from the same patient. We can visualize the radiolucent stone in the bowel, small bowel, terminal ileum, suggestive of the gallstone ileus. Another film, but in this film there we can visualize there is a radiopaque stone in the terminal ileum, suggestive of the gallstone. Now comes to the pancreatitis. So usually CT scan preferred in the pancreatitis after the 48 hours because it pick up the inflammation after the 48 hours. And it's categorized that 4 types. One is the normal pancreas, another one is the enlargement of pancreas. Next one is the inflammatory changes in pancreas with the peripancreatic fat, and next one is the ill-defined single peripancreatic fluid collection, and last one is the 2 or more poorly defined peripancreatic fluid collection to categorize the mild, moderate, severe pancreatitis. So here you can visualize the peripancreatic fat collection. You can visualize here the bulky pancreas with the stone in the gallbladder. Another film, you can visualize the gallbladder wall edematous with the bulky pancreas and small collection is there. Again, film, bulky pancreas with the peripancreatic fat edematous and inflammatory with the collection. And in the case of pancreatitis, we also visualize the necrosis of the patient, how much necrosis of pancreas is there. Is more than 30%, more than 50%, more than 70%. So CT severity index. In the post-pancreatitis, if there is a collection is resolved and it's make the false wall that create a pseudocyst pancreas after the 4 week. So CT scan is useful to tell about the size of the cyst, pseudocyst, site of the cyst, and maturity of the cyst wall. And the site of the cyst is useful in the planning of surgery. Either it's adjacent to the stomach, then plan for the cystogastroscopy. If there is a near adjacent to the duodenum, then plan for the cystoduodenoscopy, or if there is a jejunum near to jejunum, then plan for the cystojejunectomy. There is another film. Left side film is the pseudocyst, and right side of the film is the cystic tumor. So you can appreciate the difference between the wall of the pseudocyst and the wall of the cystic neoplasm. Here is a wall is very thickened, which is made up of the pancreas. Here is a wall is very thin line, which is a pseudo wall is there. Then finally is the CA pancreas. So CTs can tells about the extent of the disease, and with more respect of encasement of SMV and artery. So here you can see the CVD, you can see the pancreatic duct dilated. Here you can see the mass. Here you can see the gallbladder. With the multiple lymph node, you can visualize around the portal system. Then last in the pancreas is the pancreatic trauma. So basically, minor trauma, it's mainly undiagnosed, but with the use of CT, we can visualize, because in USG, most of the time it's obscured by the bowel. So CT is the good for the pancreatic trauma. Here you can visualize the break in the pancreas. Here is total breakout of the pancreas, and here totally disruption of the pancreas with the, you can see the SMB and SMA is there. So it's helpful in the making of diagnosis and taking the decision of surgery, if surgery is required or not.
Doctor, I'll ask for a minute. Actually, can you wind up this session fast?
Yes.
Actually, you are left ideally with 5 minutes, but looking at the interesting films that you are showing,
actually, sir,
wind up in 10 minutes.
Actually, sir, topic is very vast.
I know, it's very vast.
CT, MRI, and RCT. So
actually, we can continue discussing for hours together, but I request you to wind up in 10 minutes.
Okay.
Thank you, sir.
Next film, just I run the film. The next film is the gist. You can visualize the growth, and this one is the stomach. This one is the gastric tumor. You can see the thickening of the pyloroenteric wall area. Now comes to the benign. You can visualize the ventral hernia with the omental herniation. Here, the post-op case of ileostomy closure and hernia through the ileostomy side. Here you can see the herniation of the bowel. Now it's emergency film. So you can, just like in the X-ray, you are seeing in the X-ray in the right dome of diaphragm. Here you can see the gas above the liver. Sometimes you can find the retroperitoneal air, like any ERCP procedure, any stab injury, and small obstruction. This is a case of distal normal bowel and proximal dilated bowel lobes is there. Comes to the renal part. So take the three film. One is a non-contrast, that is the unenhanced, another is the corticomedullary part, and third one is the nephrogenic phase. So we can visualize the tumor in the very good visualization in the nephrogenic phase. Here is the whole kidney is covered with the renal mass with the central necrosis, and Wells tumor in the children, renal cyst, and polycystic kidney. And in the case of polycystic kidney, it can also visualize the cyst in the pancreas and the liver. And last in the CT is the CT angiography that is useful to detect the aneurysm or useful in the peripheral vascular disease or any injury. You can visualize the CT angiography. So summary about the CT is the single phase, maybe the multi-phase or a special protocol, and always see from the abdominal wall to the internal structure. And liver and pancreas CT protocol are important to discuss the diagnosis of hepatic and pancreatic malignancy. And your approach matters, not the final diagnosis. Come to the MRI and MRCP. So basics of MRI is to create two images of body internal structure by passing radio through the magnetic field. And MRI is especially good for the imaging of soft tissue in the body, including brain, nerve, and muscle and pelvic area. And as you already know, the human body is built up of different elements, but in the case of MRI, hydrogen is important to create a picture in MRI because, and it's a ionic state, like it's like a proton, and it's not only positive charge but also magnetic spin. And MRI utilizes this magnetic spin to property of proton of hydrogen to elicit the images. So this one is a picture. In the natural state, the hydrogen ion moving like this, but when patient comes to the MRI room with the magnetic field, the magnetic effect they align in one and create images. The basic concept of MRI, the alignment and net effect of the movement of the hydrogen create the images. And these signals are detected by the receiver, and T2 weighted images is rely on the transverse relation, also called spin relaxation of the images. As a surgeon point of view, you can see the free water in T1 images, free water look like gray. In the T2 images, in T2, it's free water, either bile, either the gastric content, it will visualize like a white. The basic concept of seeing the MRI is if you see in the T1 images, the fluid like structure content visualized like a gray, and in the T2 images, it's look like a white. Why so? In the case of MRCP, patient should be kept NPO, because if there is a fluid in the gastric content, so it's create the artifact and not give the good picture of MRCP, because it's T2 look like it white. No mobile, no internal cardiac pacemaker, no implants, no stent anywhere, and it's claustrophobic. Advantage is compared to the CT, no ionizing radiation and no short and long-term effect, and it's tell about the variable thickness of any plane, especially the muscle area, and better contrast resolution and various sequence to play the characteristic abnormal tissue. And it's one more important thing is if where is the CT is contraindicated, you can comment the MRI or MRCP. Disadvantage is it's time consuming, near to take 15 to 30 minutes and not easily available. And last and important is not easily readable by the surgeons. So come to the MRCP. So it's tell about the biliary and pancreatic stone, stricture or ductal dilatation, very accurate for CBD stone and mural disease of CBD. And it's tell about the length of the extrahepatic bile duct involved by the disease as well as the proximal extent of the disease. Unlike the ERCP, MRCP does not require any contrast material to administer in the ductal system to see the confluence, formation, and length of the help to make the surgical decision. And this film is the basic normal film. Here you can visualize the hepatobiliary system very clearly with the gallbladder, with the cystic duct, with the common hepatic duct and right duct, left ductal system, and there is a pancreatic duct. As we already said, patient preparation NPO should be there because of creating the artifact. And basic principle, the body fluid and the signal intensity of T2 images, their appear white and background tissue should be dark. So come to the indication part. So in the case of biliary disease, indication is either cystic disease like the choledochal cyst and any congenital variants like aberrant right hepatic duct or cystic duct incision, lower cystic duct incision, either choledocholithesis, primary sclerosing cholangitis, post-surgical biliary complication, and cholangiocarcinoma. In the case of pancreatic pathology, like periemporic carcinoma, CID of pancreas, chronic pancreatitis, and some anomaly pancreatic division. The choledochal cyst, you can visualize that there is a fusiform dilatation of the whole CBD with the dilatation of the right and left ductal system with the pancreatic duct. Another film of choledochal cyst, and then we can categorize the classification on the basis of MRCP. Like type 1 is a fusiform dilatation, circular dilatation. Type 2, and this one is the most common, 70 to 80% type of choledochal cyst. And type 2 is the isolated diverticulum. Type 3 is the choledococele. Type 4 is the whole system, extrahepatic system is dilated. And type 5 Caroli disease, that is the both extrahepatic and intrahepatic dilatation of the system. There may be the anatomical variation that, like in this picture, you can see the low cystic duct insertion. So if you go for the laparoscopic cholecystectomy and anatomy, you can find an anomaly, then chances of CBD injury is there. Here is the cystic duct insertion from the aberrant right hepatic duct. So if you plan for the surgery, it's more chances to clip here, and chances of the CBD injury, ductal injury is there. You can find. As choledocholithiasis, you can visualize the stone in the gallbladder and the CBD. MRCP is highly accurate in the stone in the MRCP, sensitivity around 88 to 92%, and specificity is 91 to 98% detecting the choledocholithiasis. Overall, for gallbladder stone, USG is superior, but in case of cystic duct stone, MRCP is better than the ultrasound. Again, there is a stone here in the lower end of CBD. Mirzi syndrome, there is a cystic, there is a stone in the neck. Primary sclerosing cholangitis, there is a structure, multiple structure in the CBD and the intrahepatic biliary part. Useful in the post-surgical complication, like when you go for the biliary enteric anastomosis, there may be the stricture or peripancreatic anastomosis, a post-surgical stricture. So here we can see the case of hepatogonostomy with the stricture at the anastomotic site. Here is the CBD injury part. There is a complete cut off from this one. Cholangiocarcinoma. Basically, it's MRCP tell about the length of the extrahepatic biliary duct involved in the disease as well as the proximal extent of the disease. Again, film of cholangiocarcinoma. Pancreatic division, here is a ventral duct and dorsal duct open separately. Normally, it's combined, then open into the ampulla. But in this case, here is you can visualize the when patient in renal failure, then you can give the recommendation for the in the case of pancreatitis to MRI and MRCP. In the pancreatic carcinoma, there may be double duct sign where you can see the dilated CBD to the lower end with the pancreatic duct dilatation. So advantage of MRCP is non-invasive, no sedation required compared to the ERCP, and it's delineate the ductal anatomy and delineate the anatomy of post-biliary enteric anastomosis, and even image define extraductal structure and useful in staging malignancy, but not like CT. and limitation is only diagnostic. And sometimes it's create the artifacts due to the gas clot, metallic clips, and motion pulsation. And sometimes there is create the artifact due to the respiratory motion similar to ductal stone structure. Here we can see there is a, due to the respiration motion, it's look like a CBD structure is there. And in this film here we can see that because of the right hepatic artery pulsation, again here it look like any CBD injury or any CBD structure is there. So MRCP versus CT. So CT is better in malignancy to differentiate from the benign and malignant structure, and it's tell about the lateral spread of malignancy, staging of malignancy, and any encasement of adjacent structure. It's tell about the regional lymphadenopathy and hepatic mets. MRCP give the clear picture of hepatobiliary anatomy. If CT is contraindicated, MRCP is the one-stop shop. So in simple way, if we want to see in the intraductal part, MRCP is good. If we want to see the extraductal extension, then CT is good. So, if you compare for the choletocolysis, MRCP versus CT, here in the case of CT, you cannot comment it's own or any pathology is there. Especially in the case of CT, if patient is in cholangitis, the CBD wall may be enhanced because of the inflammation. It's maybe confused with the cholangiocarcinoma. Here is in case of MRCP, there is stone is there. In the case of cholangiocarcinoma, you can better visualize the wall thickening and mass is there. And the same film in the MRCP, here just abrupt cutoff of the CBD. In the case of periampullary carcinoma, in the case of CT, you can visualize the mass, we can visualize the lymph node, we can visualize the encasement, but in here you can get abrupt cutoff and a hepatobiliary system. So MRCP versus ERCP. MRCP prefer if there is a gastric outlet obstruction or duodenal stenosis or any reconstruction of the biliary tube, and it can detect the bile duct obstruction occurring in the complication of chronic pancreatitis, and post-ERCP pancreatitis correlated with the extent of pancreatic ductal filling, further undergoing advantage of MRCP of pancreatic ductal imaging. So this is the roadmap of jaundice. Nowadays, the one investigation is emerging, that is the endoscopic USG. If we compare from the CT in the case of C8 of pancreas, if we combine the endoscopic USG with the FNAC, it's give the better result than the CT scan for the C8 of pancreas. So preoperative method is the abdominal ultrasound to tell about the gallbladder status, to tell about the CBD. Endoscopic USG tell about the exact staging, T staging of the disease. MRCP give the tell about the hepatobiliary system. CT tell about the lateral spread and the disease pathology. When you need the intra-op method, then go for the para-op cholangiography or intra-biliary endoscopy and laparoscopic USG. And this is the overall comparison in the hepatobiliary system. So you can see here is the sensitivity is 80 to 100% for the MRCP, and specificity is 90 to 98%. But CT scan sensitivity is 63 to 98, 96%, but specificity is 93 to 100%. So this is all for the. There is some slide for the MRI. If you give the permit, then I can present you.
I think it has been very exhaustive talk. Lifetime collection of X-rays the audience has seen. Ladies and gentlemen, this must invite a lot of questions. I'm sure you must be having a lot of questions. But we'll take up all these questions on WhatsApp. I'll request Dr. Nikhil, Dr. Nayan, and Dr. Azaz to post their numbers on WhatsApp. So that whatever questions are there, they can either ring and find out the answers to the relevant queries.
Okay, sir.
Okay. Thank you so much, all the speakers, for an extremely informative session. We do agree with the fact that actually few of the topics were exhaustive, but nonetheless, we had to cover up everything that is pertaining to the MS examination. Thank you, Dr. Azaz. You did full justice to your topic, and so did Dr. Nansing and Dr. Nikhil Talwar. For the information of everyone, even at 10 p.m. right now, we have around 200 students still logged in. We had peak views at one point of time around 370, and the total views, which is not a very good figure. For example, when a student log in twice or thrice, that will give a kind of an ambiguous figure, but that has been somewhere around 900. So we have had a very good attendance on the day one, and I'm highly thankful to all the chairperson and speakers for giving us this tremendous support on the day one itself. And with this, as Dr. Pradeep has already summed it up, if you have any queries and questions, you can put them on chat box. We have been trying our best to answer all of them there instantly. And it's not a bad idea. As sir has suggested to have their numbers, we would give it to you. And you can put your queries on WhatsApp of our esteemed members as well. They would be more than happy to answer your questions. With this, I think we come to an end of the day one. And again, a very thanks to all esteemed faculty members as well as students who are there with us till it's almost 10 p.m. right now. Thank you so much.
Thank you very much.
Looking forward to meet all of you tomorrow in the morning. We'll be beginning in time and we'll try to finish in time as well. Thank you so much. Good night.
Thank you. Thank you.
Thank you. Ashish and Pragya, you can stop the recording, please, and transmission.
Okay, sir.